the early onset scoliosis to the adolescent scoliosis as well as the adult deformities. We have some interesting case-based panel discussion also. We have the base free paper session also. We also have the exciting postgraduate quiz mastered by the none other than Dr. BRD sir. We are the eminent national faculty who will talk on the different topics of complication as well as the pre-operative planning and management of various kind of spine deformities. So to start this today's session, which is first session on the anterior approach in spine deformity, may I please request respected chairpersons and the moderator of this session, Dr. Harimanan sir, Dr. KP Pathak sir, and Dr. RN Nayak sir, to chair the session, please. May I please request the speaker for the first session, Dr. Dhruvin Patel, Dr. Sandeep Sonone, Dr. Amit Sanghvi, and Dr. Vinod Gautam. So the first topic is anterolateral thoracotomy approach, which will be by Dr. Dhruvin Patel, sir.
Hari, start. Hello, very good morning. The today's topic is anterolateral thoracotomy approach, especially for a spinal deformity. Now, in our routine practice, we do perform mini open thoracotomy kind of approaches, but that is mainly for a degenerative pathology like a heart, calcified thoracic disc, or maybe sometimes for a TB spine or for a trauma. But for purely a deformity purpose, say like adolescent scoliosis, and if you do have to do a thoracotomy, nowadays it's very uncommon approach to perform, especially for a deformity. I mean, to be very frank, in my practice, I have not performed thoracotomy for a deformity in many years to come, but still it's an approach that we should be knowing. And for that purpose, it is important. So the standard skin incision starts in the selected rib. You select the, say, if it's a right convex scoli, you know the apex of the rib, and then at apex of the deformity, you select the rib and you start your incision at that level. The approach is more or less decided on the basis of your apical vertebral area. And then on the basis of a CM, you start your dissection with the skin subcutaneous tissue. And the primary muscles that you encounter with this approach is basically the serratus anterior and the latissimus dorsi muscle. Now, depending at how much anterior or posterior you go, you might encounter more of a serratus anterior. If you go a little bit backward, you may encounter more of a latissimus dorsi muscles. So that's muscle dissection as it goes on. Latissimus dorsi is one muscle which can even be reflected backwards if you are more remaining anteriorly. However, say for some degenerative or a degenerative aspect, we might have to go like a posterolateral rather than anterolateral. So in that case, we might have to dissect latissimus dorsi a bit more, but that can be reflected. As soon as you reflect the latissimus dorsi, you do encounter the rib. Now, generally speaking, since we need to harvest a rib, we just cauterize over the surface of the rib subperiosteal and we take out the rib. However, the other approach for a deformity, and if you are not going to harvest the rib, the better would be to open the intercostal space by going just beneath the inferior margin of the rib. Now, as we have all learned from the anatomical classes that the vein, artery, and nerve is a VAN type of structure which lies along the inferior group of the inside of the rib. But if you remain very careful, you can erase these intercostal muscles along the lower edge of the rib. The advantage of that technique is that the intercostal nerve gets reflected along with the intercostal muscles into the pleural cavity. So by that way, you can very easily save these nerves. And the advantage is that when you put your retractor, the nerve doesn't get compressed between those rib spreader. So that intercostal neuralgia would be very less with this approach. Yes, we do insert a standard rib retractor with this approach. We put a moist sponge and then we put a rib spreader. To harvest a rib, yes, we can use a periosteal elevator or some rib respiratory and all that. but that is if you want to harvest the rib. And when you open the rib spreader, we have to be a little bit careful, because if you have not harvested a rib, you can easily fracture or dislocate your rib from the articulation. And both this retractor can be placed to gain a very wide and a very good exposure for the deformity aspect. I mean, you can take out the disc from the apical area, you can put a chip graft in that, and you can close your wound accordingly. As far as the closure is concerned, I mean, once you complete your discectomy part, even you can put your anterolateral implant in the thoracic area also. And coming to a closure part, obviously we have to take that we have gone through the pleural cavity, so we need to expand our lung adequately before we close our chest cavity. So one or two drainage tube can be kept, one anterosuperiorly, the other posterior-inferiorly, or even a one single tube is also okay for that. The important aspect here is the suturing of the ribs. Now, this is the area where we need to protect the intercostal nerves, because when you close it, you pass your suture along the superior margin of the superior rib, and when you take it out, we take through the muscles, and the nerve get reflected within the cavity, so that you don't bite your nerves when you close your wound. And by that way, you can easily approximate your sutures very, very adequately. And this kind of technique doesn't give you intercostal neuralgia whenever you close your thoracic cavity. And this kind of approaches are very well done by thoracic surgeons who routinely open their thoracic cavities. So this is one technique which can be employed whenever you want to close a thoracic cavity part. And continuous is always better, or even intermittent can be taken. Obviously, once we close the rib part, we need to suture the serratus anterior muscles. Latissimus dorsi can be reflected very adequately. If not, even that need to be sutured. And once we suture our muscle part, then the rest part is just a subcuticular closure of the skin and subcutaneous fascia and all that. So that's a standard thoracotomy approach for a deformity aspect. Now, I mean, we routinely perform thoracotomy, as I told you, for a degenerative pathology. The current concept is to go retropleural rather than through the pleura itself, and that is much more amenable and more advocated approach nowadays for a degenerative condition of our thoracic spine. So as soon as you take out the rib bed, you go through the endothoracic fascia, and if you keep on depressing the endothoracic fascia, you can easily reach up to your target disc space and you can do your surgical aspect. And that approach is more direct and more nearest if you want to reach the anterior pathology at the thoracic level, especially if it's a hard disc. This approach can be employed. Thank you very much. Right, sir.
To put the intercostal drain. I had one occasion where next day I asked, my surgeon, you sure that your assistant has
Thank you.
Thank you.
Thank you for sticking to the time. I'll invite Dr. Sandeep for his talk on anterolateral thoracoabdominal approach.
Thank you very much. And thank you, Neeraj and the Spine Association of Gujarat for having us over here. So just an extension to the approach which Dr. Dhruvin mentioned, that is the anterolateral approach to the thoracoabdominal spine. So with the advent and emergence of the transpedicular approach, the indications for this approach are really dwindling. However, in significant deformity cases like scoliosis or kyphosis, like in this case, where there's a significant void anteriorly and destruction of more than one bodies, this approach definitely has a role to play, and it gives a good exposure and good opportunity to reconstruct the spine. So this is a case where we have gone posteriorly, tried to correct the deformity, but as you can see on the post-operative CT scan, there's a big void anteriorly. And there's a difficulty in transpedicular approach, although you can do it because you need to mobilize the lumbar nerve roots, which is not always a good thing to do. And sometimes you can have difficulty insertion of the anterior reconstructive options that you are thinking of, like whether it's a cage or a graft. So in this case, an anterior approach is a good approach. So in the standard position, we go by a left-sided approach, lateral position or a floppy lateral position, depending on what you prefer. In scoliosis, I usually go by a right-sided approach because you need to go from the convex side of the curve. You take a gentle curvilinear incision over here, which blends anteriorly into the mid-coronal plane, go along the 10th rib onto the anti-abdominal wall. So you need to identify the 10th rib pre-operatively and intraoperatively. So you palpate from lower down, 12th, 11th, and 10th, which are the floating ribs. Make sure, as Dr. Dhruvin said, you raise a good subcutaneous flap, identify the muscles because post-operative suturing of muscles is very important. Palpate the costal cartilage and identify the anti-abdominal muscles. So this is the rib exposure. You go along the middle of the rib. Usually in this approach, you have to excise the rib. You cannot get away without just going in between the ribs. You have to excise the 10th rib for you to get a good exposure. So that's the rib exposure that I am doing. Go proximally and distally, taking care not to injure the neurovascular bundle which runs along the inferior margin of the rib. Now, this is the most important thing. You need to expose the costal cartilage quite meticulously because this is what is called as the gatekeeper of the approach. So excising or incising the costal cartilage meticulously is very important for you to land up onto the diaphragm. The next step is exposing the thoracic cavity as explained by Dr. Dhruvin. I usually excise the 10th rib. After excision of the 10th rib, you expose the pleura and make an incision in the pleura and enter the thoracic cavity. So this is the costal cartilage, which is at the anterior end of the incision. From this point onwards, the incision will blend anteriorly and inferiorly along the thoracic wall. You should take care while exposing the pleura or incising the pleura not to injure the underlying lung tissue. So I just make a small nick over there, ask the anesthetist to hold on the ventilation and take a clean cut going right up to the costal cartilage where there is insertion of the diaphragm. So make sure that you protect the lung tissues at all times, otherwise you might land up with lung damage. Now, this is what I'm doing. After that, you need to go and try to expose the lower part of the incision. So a meticulous dissection of each layer of the anti-abdominal wall is very important. I usually dissect these layers with the fascia, cut it at different levels. So if I'm cutting the external oblique a little bit posteriorly, the internal oblique will go more anteriorly so that you don't create a uniform zone of weakness from where you can have post-operative hernias. So you cut the external oblique, you cut the internal oblique similarly, and then you can divide the costal cartilage. Now, very important that you keep the muscle attachments on the costal cartilage on either side, because this is where you need to approximate quite well when you're suturing. So I usually take small tags in the costal cartilage, cut it. While cutting, make sure that you protect the costal cartilage, you protect the peritoneum underneath the costal cartilage by good clean dissection. You can use peanuts or mops or whatever gauze pieces that you want and dissect of the costal cartilage from the underlying peritoneum. The peritoneum is adherent anteriorly. It is more loose or more dissectable as you go posteriorly because of the presence of the retroperitoneal fat. So you cut the costal cartilage, then the rest of the dissection of the transversalis abdominis is by finger dissection. So you put in your finger, separate that transversalis from the anterior aspect of the peritoneum and enter the retroperitoneal space. So this is the exposure. We have the thoracic cavity which is exposed. We have the diaphragm which is exposed in between, and we have the retroperitoneal space which is opened. So from here on, the most important part starts, that is resection of the diaphragm. Make sure that you have a circumferential exposure of the diaphragm proximally from the top and the bottom. The diaphragm, usually the peritoneum is attached or adherent to the diaphragm in the middle part. So you go peripherally along the, keep a 1 centimeter sort of a patch of diaphragm so that you can suture it quite well later on. I usually take multiple tag sutures so that later on approximation becomes easier. As you go anteriorly, as you go towards the vertebral column, you will encounter a thick tendinous structure which is a crush of the diaphragm. Very important that you have a good clean cut in this crush of the diaphragm, because there's a tendinous structure which you have to suture properly later on. Otherwise, you can land up with internal hernias where the retroperitoneal structures can herniate into the thoracic cavity. The intercostal vessel of the 12th vertebral body, 12th level, is exactly beneath the crush of the diaphragm. So you need to dissect the crush properly and then expose it, and then expose the anterior aspect of the vertebral body like we do in a standard fashion. Similarly, exposure of the lumbar vertebral bodies is done anterior to the psoas muscle, tying the intercostal, tying the segmental vessels and exposing the body. In my practice, in the last almost 6-7 years, I have never exposed the mid lumbar bodies through this approach, because more often than not, all these things can be done by a posterior approach nowadays. So purely the apical release, especially in scoliosis cases, is to be done by these approach. So this is what you can do. You can do your release, you can do your decompression, reconstruction, whatever you want to do it. The most important part is suturing. You need to suture the crush of the diaphragm quite well, as was explained by Dr. Dhruvin. The rest of the thoracic wall has to be sutured properly. Diaphragm, very important that you close the diaphragm in continuous layers, continuous sutures, so that there's no gap in between. And then you can close the muscles of the abdominal wall. And finally, you close the costal cartilage so that you have a good approximation. Run your finger all through the incision. Make sure that there's no area of weakness, no area of void where there can be internal herniation. And then you close the chest wall. In scoliosis, the right-sided approach is the most preferred approach, obviously because of the right-sided curves that we get. Now, contrary to the thinking, in scoliosis, it is very easy because of the rotation of the vertebral body. So once you do a thoracotomy, the whole thing is right in front of you. You just have to cauterize or clip the segmental vessels, and the whole soft tissues just fall onto the concave side. So that's what I'm doing over here. Very important in scoliosis that you go right on the opposite side, because you need a good release. And for that, you need to have a good disc release also on the concave side as well as the concave side. And then this is how you can do a good apical release and get a very good correction once you go in and use your strong posterior instruments to correct the curves. So all in all, it's a relatively morbid approach, but however, it gives an excellent visualization and access to the anterior column for good anterior release and reconstruction. Thank you very much.
Yes, Sandeep, your indication for a standalone anterior approach.
Yeah, so in like I showed, if there's an anterior void, especially at D12 to L2 level, then if I cannot manipulate the L1 or L2 nerve roots too much, obviously with the expandable cages coming, you can still do it, but it's not the same type of reconstruction that you get to an anterior approach. You can really put in a good tricortical graft or a good cage covering the whole end plate. In scoliosis cases, as I said, I rarely had to go to L1, L2 level through this approach. Most of the anterior release in scoliosis, in rigid deformity, apical release can be done by a transthoracic approach.
Thank you, Sandeep.
Thank you.
I'll invite Dr. Amish for his talk on retroperitoneal approaches.
Good morning, everyone. I thank SAG to give this opportunity to me about speaking about anterolateral approach in spinal deformity. The indications are Lenke 5C curve that is usually less than 7 segments. If the curve is less than 85 to 90, and there should be a good flexibility on the traction X-rays. It is also an approach which is often used for release of these curves in cases of rigid curves. And it is also nowadays coming up for doing OLIF and lateral lumbar interbody fusion for adult spinal deformity as an adjunct to posterior fixation. There are certain contraindications for this approach, like it is not good for L5S1 segment because of the high iliac crest and the great vessels are around. If there is retroperitoneal fibrosis, and if the psoas is riding high, like it is covering the anterior anterolateral surface of the vertebral bodies and it is projecting beyond the anterior surface of the vertebral body, then it's not a good approach to choose because you have a lot of problems with retraction of psoas and there can be complications of lumbar plexus. So understanding the anatomy, as you can see here, you have to follow the red line. You enter the abdomen through the abdominal wall muscles, reach the retroperitoneal cavity, and then you swipe down to reach the anterior surface of the psoas, and you reach the corridor between the great vessels and the anterior surface of the psoas, as shown by the red line. And that is the area where we are working in this approach. That's the lateral view of this approach. As you can see, the green arrow going down, the ureter and the retroperitoneal structures are retracted ventrally and medially, and you stay just along the surface of the psoas muscles and you find the medial border of the psoas muscle. So the steps are, you position the patient in the 90-degree lateral decubitus position with the hip and knees flexed to relax the psoas for the easy retraction. The left-sided approach is the commonly used because aorta is easier to handle. Although for the scoliosis patients, we always approach from the convex side. The table is often flexed to increase the iliocostal interval because then and then you can reach up to L4-5. It's an oblique flank incision, usually centered over the level of exposure. You start anywhere from 11th to 12th rib based on your proximal level of exposure, and you go down obliquely across the abdominal wall to reach a point at the lateral border of the rectus abdominis, somewhere between the umbilicus and the pubic symphysis. So that will expose right from L1 to L4, L5. The superficial dissection will involve skin followed by external oblique muscle, which has fibers directed forwards and medially, and followed by internal oblique and the transverse abdominis. Once you finish cutting the abdominal wall muscles, you'll reach the retroperitoneal fat. As you can see in this picture, you use your finger dissection or a blunt gauze dissection to retract the retroperitoneal structures along with the ureter. It is retracted forwards and medially, and you keep on swiping your fingers till you reach the anterior border of the psoas muscle, and wherein you have to locate the medial border of psoas muscles, which will take you to the anterolateral surface of the vertebral body. You have to identify genitofemoral nerve, which is lying exactly on the anterior surface of the psoas muscle, and you have to always try to preserve it. Once you reach the subperiosteal structures, your subperiosteal area, psoas is retracted posteriorly, and you reach the corridor between the great vessels and the psoas muscle. The segmental vessels are identified at this juncture because they are lying at the middle of the vertebral bodies. You have to identify each of them. You have to either cauterize them or you have to ligate them to prevent the bleeding. And you have to always identify a sympathetic chain which lies just lateral to the ALL and try to preserve that. Once that is done, you perform discotomies at each level to release the curve. The pedicle screws are inserted in each of the vertebral bodies. Single or double rod configuration can be used, and the curve is corrected by rotation of the rod and the compression maneuver. The cage should be used always in the lower lumbar spine to maintain the lumbar lordosis, because this is a kyphogenic procedure. Here, when we compress the lumbar spine, it will create kyphosis, and to preserve the lumbar lordosis, cages should be always used down L2, L3, L4, L5. Again, there is a extension of these procedures for OLIF and lateral lumbar interbody fusions in adult spinal deformities, and wherein OLIF is a procedure which when we approach anterior to the psoas muscle, while in the lateral lumbar body interbody fusion, we go through psoas. The problems here are the lumbar plexus lies in the posterior half of the psoas muscle. So as you can see here, there are 4 zones of psoas muscle, and you should always try to keep the dissection in zone 1 and zone 2, if at all psoas is to be splitted. But usually anterior to psoas is the preferred approach. Again, there are certain anatomical problems at the level of L4, L5. There is a cleft of psoas major, which is described as a cleft which lies just lateral to the L4-5 and the L5 body, wherein there are plenty of vital structures are there: femoral nerve, obturator nerve, ascending lumbar vein, iliolumbar vein, and these are the structures which are likely to be damaged when you reach the L4-5 level. The complications, there is a chance of ilioinguinal and iliohypogastric nerve damage, which can lead to sensory deficit. Damage to genitofemoral nerve can lead to loss of cremastic reflex and sensory deficit of the intermedial thigh. There can be damage to a sympathetic chain. So all these structures need to be identified and preserved. Damage to superior hypogastric plexus can lead to retrograde ejaculation. There can be motor deficits because of the injury to the lumbar plexus, especially over retraction of these muscles. But most of the time, 50% of the time, they recover by the end of 6 months. The vascular injuries are common in venous. Venous injuries are more common than arterial injuries, although there was one aortic perforation reported in the literature, and there can be incisional hernia as well. There are certain limitations in the scoliosis surgery for anterior surgery for scoliosis, because it's a kyphogenic procedure. So you always try to preserve the lordosis. Less derotation is possible often compared to the DVR as in posterior techniques, and there is a higher pseudoarthrosis rate, especially at the lowest level fused. There are certain advantages like the fusion level can be saved, and there is always a coronal rebalancing over a period of time. There is a good article, this is the last slide, wherein they reported 107 patients with a mean COBS of 38 degrees preoperatively, and there was a correction of around 85%. So there should be a good knowledge of anatomical structures. L4-5 has highest risk of injury, and there is a lesser magnitude flexible Lenke 5C curves are the good indications. It often helps in saving the fusion levels as compared to the posterior technique, and the kyphogenic nature of correction, less derotation, and the higher pseudoarthrosis are some of the limitations. Thank you.
Thank you. I think you should more light on the signals. Now, just one thing, which 4. If that starts bleeding, you are in trouble. So that is the only suggestion.
True, sir.
One thing I would like to understand better is that one of the slides said that the internal oblique is cut perpendicular to the line of incision.
True, sir.
Everything is cut in the same line, no?
No. I mean,
otherwise it becomes like a
external oblique
McBurney
has the
incision.
fibers which are going like this. The internal oblique fibers are like this. Everything is cut along the line of incision, but the internal
But
oblique,
it says perpendicular.
the line of fibers.
Slide said like that.
Yeah, the line of fibers. I agree.
Thank you, Amish. I think we'll conclude the session. Sorry, we have Vinod Gautam. Sorry, Vinod, for his talk L5S1 anterior approach.
Good morning, everybody. First slide. I'm going to talk about anterior approach to L5S1. The importance of anterior approach is that The great vessels divide at the level of L4 and L5, and you cannot retract at the level of L5 S1. So you have to go anteriorly. Apart from deformity corrections, there are different indications for this, like degenerative disc disease, degenerative pathologies, and specifically where you have done multiple posterior surgeries at this level. And you cannot go again posteriorly, you have to go anteriorly. Options for fusion are anterior A-lif, P-lif, T-lif, O-lif, and L-lif. So they have been discussed. For L5S1, the best approach is anterior. So old method was in 3 steps. To expose spine, the access surgeon has to be called general surgeon. Then the spine surgery is done by spine surgeon. Then again, confirmation of lack of injuries and closure of abdomen by access surgeon. So this was the old method. Since we have a new technique called as mini phalansteal incision, we can do ourselves. I'll show you the video first. So these are the different methods by which we can approach the spine. We are talking about A-lif. For L5S1 exposures, we used this mini phalansteal incision, which is in midline and in between the umbilicus and pubic symphysis. We expose the linea alba, we cut transversely, and we make 2 flaps, superior and inferior, so that now the exposure will be vertical. The rectus on the left side is cut and exposed. This is the rectus. Then we go into the retroperitoneal space. Inferior epigastric vessels are visualized and preserved and retracted anteriorly. We are directly onto the psoas muscle and genitofemoral nerve. Now low profile retractor system is applied with narrow blades. Iliac artery and vein is exposed. And medial sacral vessels are double clipped and ligated. Now the dissection is used by P-nurse so that there is no thermal injury to the sympathetic nerves which are crossing the L5S1 discs, as this can cause retrograde ejaculation in future. Now we developed a plane between the cartilage part and the bony part of end plate. We take it out piecemeal. This is the level where we can take our microscope and inspect posterior longitudinal ligaments, decompress the neural tissues, and small fragments of the disc can be removed. So this shows on both the sides you have major vessels, and then there is a disc space. Prepare the bone graft. This is a trial. Use the trial and confirm under IITV the depth, the inclination of the lumbar spine. This is how you can pack the size, proper size of the disc. Punch it, place it, confirm under IITV. And you can lock it. After this, whenever you take out the retractors, the peritoneum will fall back on its place. And you just have to suture the linea alba and the rectus. You always suture with heavy PDF so that there is no herniation. This step is very important because in anterior, the herniation is a big problem. This is after 3 months. And this next day we get an X-ray, and after 3 months we get a CT scan done. So the NT approach does not require access through the spinal canal, so no detection of the spinal roots on the cauda equina. So the iatrogenic injury to the posterior muscles is avoided. There's an efficient vascular access below the bifurcation. Hence, L5S1 with NT approach is the choice of treatment. It demonstrates high fusion rate, good radiological outcome, good restoration of the height and lordosis, reduces the risk of dural injuries. The risk is vascular injuries, visceral injuries, and retrograde ejaculation, which you should take care of. Thanks.
Lumbosacral junction is a very anterior structure.
Yes, sir.
So there's no point in having an incision which is starting from posterior at all. The entire incision may be just anterior and gives without much retraction, gives the lumbosacral junction.
Yes, sir. It was in the center of abdomen. It was anterior. Yeah.
Any questions from the audience? We'll be able to take a couple if they have for any of the talks. So, yes, sir.
Yes.
And when you do the anterior dissection, in order to avoid the retrograde ejaculation.
So dissection should be strictly with peanuts. No cautery is used. That is the key, because thermal damage can also take place even if it is nearby.
Yeah.
Thanks, and sir, you would have done these cases earlier. Any tips from your end, sir? Tips about preventing the anterior injury, in order to avoid the retrograde ejaculation. Some people inject the saline.
Okay.
Some people inject the saline so that you can visualize it better.
Okay.
So that is one of the tips, which probably is something your experience.
Oh, very true. Because this vessel now is embedded in the fatty tissue, and sometimes while dissecting you can damage them. Best way is to inject the saline in the tissue and then gradually retract it. Dissection of that now is very important, as you have already mentioned the complication of retrograde ejaculation. I think that's the only thing you can do to prevent injury to that now.
Point taken, sir.
Saline injection, I think you suggested, no? For a quicker dissection. There's a time when the saline was used in the neck, in the breast, and all such, the Halsted. And then there was a kind of more of a religious this thing, whether you should inject saline in a carcinoma case at all, because it would spread. But saline, then may I add adrenaline to it? It will still better. And some authors for no reason say xylocaine. When the patient is under GA, I don't know what xylocaine is going to do. Have you read that xylocaine add to it? I don't know why they want to add xylocaine. And all said and done, one more thing, tranexamic acid.
Lighter note, I was just there in Australia for this anterior course, and same anxiety and same point of discussion came, and I was same way anxious to ask the same question to a few of the good people who were very frequently doing anteriors and olives. I asked, what about the retrograde ejaculation? So everybody uniformly, they would be around in the age of 50, 55, 60, said one thing, Who the hell cares? They were not concerned. One of them said, that is the last thing that will come to my mind. They don't even explain that to this. That age group that comes to them, therein they don't consider this even asking or doing that. So they are quick in, quick out. That's it. I was surprised and I was fooled by the answer and the question which I had got asked.
Thank you. Thank you, sir.
I thank all the speakers for their excellent talks on anterior approaches.
Good morning, everyone. Myself, Dr. Rohit Thakur. I welcome you all in a SAG Meet on a masterclass on deformity. After a wonderful session on anterior approaches in deformity, we hereby start our next session on surgical tips and tricks. So for this session, I will like to invite our moderator for this session, Dr. M.M. Prabhakar sir, to come on dais. And I request Dr. K.P. Pathak and R.N. Nayak sir to continue to moderate this session. And speaker for our this session is Dr. Hitesh Modi, Dr. Khushal Shah, Dr. CHIRAYU PAMECHA, Dr. Hari Menon, and Dr. Ajay Krishnan. So let's begin our next session.
Good morning. I am Hitesh Modi and would like to talk on preoperative planning in spinal deformity. So the question arises, why do we need preoperative planning in any surgery? If we typically discuss about a scoliosis surgery or spinal deformity surgery, then the goals are prevention of curve progression, cosmetic appearance, restore sagittal balance, and relieve the pain, and thereby prevent any complications such as pulmonary or cardiac. So typically preoperative planning will include medical history and clinical history along with physical examination to see the age of onset, any stigmata like café spots associated or other physical anomalies, and to have a clinical appearance. Blood investigations to see hemogram, renal functions, and other seromarkers to prepare as well as preserve PCVs or any other blood products. Cardiac functions in form of ECG, 2D echo, as well as pulmonary function test to evaluate the restrictive lung pattern, and prepare the post-operative respiratory support as well. It is better to start chest spirometry exercise before considering the spinal deformity surgery to improve the lung capacity, as well as the radiographic evaluation, which we will discuss in next slide. So coming to the radiographic evaluation, getting recent full-length X-ray of whole spine in standing position with pelvis and hips included, along with right and left lateral bending films are the standards now before proceeding for the surgery. It can help in guiding fusion levels as well as the judgment of the correction. On radiogram in AP films, we need to check Cobb angle, central sacral vertical line, pelvic obliquity, Reser sign, pedicle rotations, and identify primary or secondary curves and associated congenital bony abnormalities. In lateral film, we need to check pelvic imbalance, pelvic tilt, sacral slope, lumbar lordosis, thoracic kyphosis, and C7 plumb line measurements. These are all radiological measurements on AP and lateral films. Pelvic obliquity is definitely an important aspect whenever you are doing a neuromuscular scoliosis. And when it shows obliquity shows more than 15 degrees, then often fixation to the sacrum or pelvis is helpful, according to my published report in 2008. CT scan would be helpful in identifying the bony abnormalities, hemivertebra, diastomatomilia with bony bar, associated lysis or listhesis, and pedicle diameters for the screw fixation and screw sizes. MRI is typically not important in doing adolescent idiopathic scoliosis. However, it is indicated whenever we are doing congenital or neuromuscular scoliosis to see any intraspinal pathologies, tethering of cord, diplomylia, or other cord signal changes. So once we have completed all necessary evaluations, it is important to find out how much correction we anticipate after the surgery. And sometimes I feel it is also important to discuss and communicate in preoperative counseling. And there are two important research being published based on the fulcrum bending X-rays published by Professor Keith Luke and Kenneth Chung, who were my mentors in Hong Kong, suggested that you can predict around 120% of the correction based on the correction achieved on the fulcrum bending. And the second approach, which is more popular, by evaluating the side bending standard films, which can give you the idea about flexibility, curve type, and fusion levels, along with the prediction of the correction as well. Now, this slide shows that we also need to identify superior, judge about the superior and inferior fusion levels, and we need to consider the stable vertebra, neutral vertebra, as well as apical vertebra whenever we are doing preoperative planning. This review article published in 2013 focuses on identifying the level of interbody fusions as well as need of neural decompression whenever we are doing a spinal deformity surgery. I feel it is beyond the scope of discussion here. One important thing and important part in treating severe deformity is to plan various types of osteotomy procedures to achieve desired correction, whether it is a Pontes as osteotomy, SPO, pedicle subtraction osteotomy, or VCR. Literature says despite of the treatment algorithm and classification systems developed well, there is 31% difference exists between surgeons while planning preoperatively. However, preoperative planning often helps surgeon regarding expected blood loss associated complications. And I feel we not at the moment we may not go deep during the present discussion. One of the most important aspect in preoperative planning is what kind of the screws, like monoaxial screws, polyaxial screws, reduction screws, whatever is required, we need to judge preoperatively, and at which level we want to insert by clinical as well as radiological examination. Additionally, it can also guide which side rod should be fixed first and what kind of rod derotation technique or compression distraction technique is used depending upon the type and examination point of view preoperatively. Last but not the least, that planning for preoperative traction in cases of severe scoliotic deformity has been mentioned well in literature from 1975 to 2021 articles. However, preoperative traction has been tried successfully by Lord Krishna while correcting the deformity of Kubja to the Hippocrates era in applying body weight as a traction force. Similarly, the research article suggests that preoperative skull and femoral traction often augments achieving more correction during the surgery in severe deformity cases. And in the end, I would like to mention that planning for intraoperative neuromonitoring, preoperative proper counseling, and postoperative ICU planning should not be forgotten while planning for scoliosis surgery. Thank you.
Your talk is well understood. As far as I am concerned, the indication for surgery in correction of scoliosis is the deformity is severe enough to compromise the chest and abdominal function. One. Second, cosmetic. For cosmetic surgery, when there is a rib hump, you correct the rib hump. Now, I would like to know from different people, would you like to accept a mobile, little deformed back or a stiff back? Please. Use.
Actually, this question is very valid. And some of the patients, they do ask, what about my mobility? Now here, the priority should be pointed towards the indication of surgery, which you rightly raised. So if a young girl is coming who is concerned with the deformity and back, contour of the back, you have to explain her, yes, you will correct, but at that segment, you will not be having any movement. But at the same time, we have to explain to the patient the benefit of it. That is one, cosmetic correction, and in future, because gradually later on also there is add-on. There is an add-on curvature proximally and distally. And most of the time, all these operated patients, they are able to carry all activities. Okay. See, there are few things which is like a contact sport person, sport personnel who want to do significant bending and all, that might only restrict and that too. But the hip is normal, the cervical spine is normal. We try to prevent as many segments as possible to include the fusion. And that is the reason nowadays it has gone from, saving the segment, okay, and the mobile fixation, okay. So actually this question is very valid, and I think this discussion came in a very right time. Thank you.
Severity of scoliosis, the indication of surgery.
Yeah, actually that also depends upon multiple factors. When the patient has appeared to us, riser's sign, then what are the condition of all other epiphyses, okay, and age, menarche. So if the significant curve is there, see earlier also it used to be standard teaching, below 40, try to manage with the Minerva jacket, or you give Milwaukee brace, okay. So as soon as you find that, now this is the single appearance of the patient, and telling the thing is not right. We have to follow the patient. So follow-up is extremely important to know how much is the progression in these many years. I think that also dictates the guideline. Thank you.
Thank you very much.
It is. Do you recommend the neuromonitoring intraoperative in all cases or certain cases, or you also depend upon the Stagnera Wacom test?
Sir, in my hospital, I think we are using neuromonitoring in almost all cases, including TLIF also, except only microendoscopic discectomy we don't use. But yes, I agree. Whenever we are approaching for any kind of spinal deformity surgery, I think we have to go with neuromonitoring.
Thank you.
Thank you.
Now next speaker is Dr. Kushal Shah, and the topic is surgical optimization of the patients with the adult and pediatric spine deformity.
Good morning, everyone. At the outset, I would like to thank SAG for giving me this opportunity. So when this talk was given to me, the first thought came into my mind that why are we talking on this? So you don't want any of your operated patients lying in an ICU like this. You don't want to take rounds in an ICU. You don't want a wound to be complicated like this without any reason. And you don't want an excellently done surgery patient lying in a wheelchair like this on a long term unhappy. So is there anything apart from surgery that we can do more? Yes, that's optimization pre-operatively. When we talk about optimization in children and adults, the adults would come first, and adults for all practical purposes would mean geriatric patients rather than young healthy adults. So what all optimization can be done? The medical one, the nutritional optimization, functional and cognitive, and the bone density. Let us take each of them. The medical one, something what Hitesh we already talked about, and I won't talk much upon it because it is the most common thing done perfectly by almost all of our physicians. the basic blood investigations, ECG, echo, allergy profiles, chest X-ray or HRCT, and other patient-specific requirements, whatever they are. And these are the general guidelines that if there is hemoglobin concentration is less than 8 or plasma sodium concentration less than 120, hyponatremia, hypokalemia, uncontrolled diabetes, any of the cardiac events like LVF or chest infection, we don't operate upon our patients. So these are the general guidelines. I don't want to talk much on this. We would focus on the next topics, that is the nutritional optimization. Next. Okay, nutritional optimization. So there is a very nice paper by Cross et al. In American Academy of Orthopedic Surgeons, where he states about evaluation of malnutrition in orthopedic surgery as a whole, which would include all types of orthopedic surgeries. Serum albumin level less than 3.5 gram per deciliter, total lymphocytes count less than 1500, and serum transferrin level less than 200 would consider patients having those would be considered as malnourished patients. They also take into consideration a complex form, mini nutritional assessment form. And as I found, it is commonly used in all the hospitals in the Western world. What is important for us is they have an indicator score. Less than 17 points is a malnourished patient. And all these patients who are malnourished by blood values or these forms have to be given a nutritional rehabilitation before the surgery. One. And again, this is what we know, that if HbA1c values exceeds 7, then we have to delay a elective spine surgery. There is another value, serum pre-albumin levels. It is by Salvetti et al. In JNS. And if the pre-albumin levels are less, then chances of post-operative infections are pretty high. Now we know that obesity is also one of the part of malnutrition. It is not just underweight, obesity is also malnutrition. So patients having just 5 points rise of BMI have 21% increased chance of SSI. This was a review article in European Spine Journal. Having said that, it is not just that the obese are at risk, the underweights patient, who has BMI is less than 18.5 are at the highest risk of surgical complications and resurgeries. So the nutrition plays a big role in the result of our surgery. This would end up my nutritional part. Coming to the functional and cognitive optimization. This is a very subjective thing, but it has been very nicely described in literature. There is a nice article in JAMA by Min et al. They have devised a new score known as VESPA. The VESPA score would be including 6 basic activities of daily living and 8 instrumented activities. They are basic, like bathing, dressing, laundry, paying the telephone usage, etc. They would also take into consideration the gait and mobility, how many falls are there for the patient, the time to get up and climb a stair. If it is more than 20 seconds, it is high risk, and poor results of balance if they cannot stand steadily, and the mini cognitive score, which we all know as the mini COG score. Taking all this point into consideration, a new score has been devised, the VESPA score. If the value of VESPA is more than 9, then the patient is high risk of having poor long-term outcome. The functional and cognitive is for long-term rather than immediate post-op outcome. The another one is a frail score, as we all know, the fatigue, resistance, aerobic capacity, illness, and loss of weight. 3 to 5 score is a frail patient. All frail patients are bound to have higher complications, longer hospital stay, and poor long-term outcomes. Bone density optimization. We all know that ultimately we are talking about deformities. We would be relying upon the bone strength for 2 things: hold of the implants, and secondarily the fusion. A nice article by Wong et al. They have said that osteoporosis, as we all know, decreases these rates. So pre-operative DEXA scan or CT scan is required. And they have gone up to the extent of saying that if the DEXA score is less than -2.5, surgery should be avoided. From -1.5 to 2.5, teriparatide should be given. And those patients who cannot be given any sort of this therapy have to be advised, explain the risk of the complications because of osteoporosis. Coming to comprehensive optimization, these are individual parts. If you go to comprehensive optimization, there is a very nice article in GNS. I would advise everyone to read this by Adolescent et al. It is from Rush Medical Center. They have come up with a program known as POSH, Perioperative Optimization of Senior Health. Patients more than 65 years, all are given geriatric evaluation for complex spine surgeries. And this reduces the hospital stay, post-op complications, ICU requirement, and improves long-term outcome. So this is all I talked about. Pre-operative assessment for all these parts. The patient has to be explained, the relatives have to be given the realistic expectations of the surgery. The primary health care provider has to be taken into account for his medical complications and immediate post-op treatment. All this would lead to less post-op delirium and improved functional recovery. This would end my adult part. Coming to pediatric optimization. Pediatric would be relatively easy. It would be considering three things: the congenital anomalies, the nutritional part, and the functional and cognitive part. We are not much worried about the bone health in pediatric patients. For congenital anomalies, there is a very nice paper by Chen, and they have given a list of congenital anomalies along with the bony deformities. I won't go into the list of those anomalies, but nice to see is this algorithm. Very nice to see that along with what he is evaluating the bony part, along with that, the parallelly, the medical part has also been evaluated. The renal evaluation, cardiac evaluation, I'll be finishing in 2 minutes. The neurologic evaluation, if needed, MRI, and then in the end, the pulmonary functions. For India, our own Jaiswal sir has also written a paper in which he has stated that patients requiring growth rod surgeries have at least 50% of comorbidities, and most of them being cardiac. Nutritional, they are stressing, AO Spine has been stressing on hemoglobin levels pre-op. They administer hemarinics and up to the extent of erythropoietin to get hemoglobin levels of 12.5 gram per deciliter pre-op, which would decrease the post-op blood transfusion. And higher BMIs in adolescent idiopathic scoliosis have high risk of adverse events as compared to normal BMIs. Functional and cognitive. This is a tricky thing. The AIS children are teenagers. Most of the surgeries are for the looks of, is more of a cosmetic thing. So they consider cosmesis as one of the most important part, and that would consider one of the mental health. And along with that, if there is some pain, it has also to be taken into consideration. So a mental health provider should always be there in a patient of AIS surgery, and realistic expectations before spinal fusion surgery should be considered. So to summarize, optimization improves post-operative outcomes irrespective of age, being pediatric or adult. Basic blood reports are not the end of investigations. Nutritional optimization plays a big role. Functional and cognitive assessments predicts long-term outcome, and congenital scoliosis are tricky patients requiring detailed workup. Thank you for your patient listening.
Thank you very much. A very thorough accounts of evaluation of the patient. As far as the spine is concerned, the surgeon will evaluate. But as far as fitness for surgery, refer to the physician. We find him fit or unfit. The physician simply writes fit with calculated risk.
Due risk.
So he doesn't know what calculation he has made. Only one sentence is written. So then I have to again request the physician, ભાઈ તમે કંઈક એક પાનું ચિત્રીને લખો એમાં કે તમે શું જોયું, what are the things which you have seen. You please write in detail to make it look satisfactory. So otherwise we have to make a pro forma and make all this time. You must do echo, 2D echocardiography, and all these things must be done. You never know what turns out in the echo. You never know which patient, whether young or old, is suddenly going to pop off on account of something which happened somewhere. So, are you willing to make a pro forma?
Actually, sir,
it will run into some pages, you know.
Actually, sir, I could not include because of short of time. There is already American College Society NSQIP pro forma. If you enter the name of the surgery, the age and comorbidities of the patient, they would immediately give a result as in what risk, how many percentage is there. It is online. We should try one. ACS NSQIP. Name of the surgery, comorbidities and age of the patient. And if you give the answer, they would give ICU admission, this many percentage, surgical site infection, this many percentage. It is already online available for us. But I could not include because of shortage of time.
See, because physicians, sorry. Physicians, you know, one of my teachers, a physician, it's very long ago now, since I am also not that young as I used to be. But during the annual function, mimicry was being done. So he would put the stethoscope on the chest of the patient, but forget to put it in his ears. If that is how you are going to evaluate your patient, then where do we get? And if you are going to make a pro forma for evaluation pre-operative, are you making a pro forma for the other details of the patient? Still, we don't have any. Years ago, I made out some pro forma that in a spine case, what all things must be mentioned. Yes, no, tick, cross. Hyderabad knows about it. He also made some alterations in it. And then he has kept it under his seat. Nothing else. There should be something common. If you want to evaluate. You see, if you have made some goodish amount of nest egg or money in your profession, and you're thinking of making a residence or house of your own, then you make a plan, then you go to the municipality, then you get this permission, that permission, finally building use permission, everything. But do you ever talk about the foundation? Nobody talks about how it is just taken for granted. Have you, any building a house, have you ever talked about the foundation, the word? No. The record is the foundation. So if you think that, what is it called, this record business?
Registry.
Huh?
Registry.
Registry, that's what I used to talk about. So if you think registries are bound to fail, at least have some common pro forma. Pro forma you must have, so that whether it's the north of Gujarat, middle or south of Gujarat, or from Kashmir to Kanyakumari and west to east, your pro forma should be the same. Where is the shame in that?
Yes. True,
So
sir.
otherwise, how, and remember, the final judges of a physician's or a surgeon's action are non-doctors, non-medical people. Whether it is the public, whether it is the relatives, whether it is the local gunda, or whether it are the judges panel or a bench or whatever it is, and whichever level of court. Only non-medical people are going to judge us finally. So do we want to have a pro forma or not? For evaluation and for everything.
It's necessary.
Thank you.
sir.
Yeah, this is a valid topic, but every time you listen to, you come up with 2 or 3 new scores.
Absolutely.
First time listening. So it is never possible to update to that level. At the same time, this can be divided completely into medical evaluation, which is a separate subject. One is pediatric, one is the geriatric, and third is the nutritional. If you group into this, it is very easy to mentally comprehend things and remember. That is the only thing to be followed. Otherwise, it becomes so difficult to remember the new score. It cannot be reproduced. Even teacher, our sir, they all have taught breathing tests, simple, your skin fold test, your albumins, your counts. This all had been followed earlier also, but this makes more complicated.
Correct, sir.
So everything is normal, but your anesthesia friend should be, our cooperative. Huh? Thank you, Hussam.
Thank you, sir. Thank you, sir.
Now the next topic is by CHIRAYU, and the topic is tips and tricks how to communicate pedicle of the deformed spine.
Good morning, everybody. To my honorable teachers, regards. Thank you, Neeraj. Thank you, SAG. So I'll just come to a simple topic now. Not many performers, just how to cannulate a pedicle in deformed spine. So you have to be very, very careful. There are important structures around it. So I'm just going to talk about thoracic pedicles, I think. We're not going to talk about lumbars and in deformed spine. So be careful. There's aorta, there is a spinal cord around. So you have to plan it well. There are various options. You can have pedicle screws. You can have screws at other locations like iliac screws, hooks, wires and cables. And if you can't do anything, if you're stuck, then don't do anything. You can even come out without an anchor in that particular area. The key is that you have to be safe, efficient, and where and when needed. Thoracic pedicle screws in deformity is the topic today. I'm just going to talk about it. There are different techniques. There is a freehand technique. There is fluoroscopy guided technique. I think then there are the O-arm based navigation technique. Robotics have come in. But in my practice, I think these two are most important. Fluoroscopy does help, but O-arm and robotics is not possible at every center. So I'm just going to talk about freehand and how a trigger EMG can make it safe. So these are the standard steps of any pedicle screw. You have to expose well, You have to know the starting points. I'm going to come to each one of them. The trajectory, how to use the probe, sound it well, or what we call as palpation, under tap it, less than 1 millimeter of the actual size, re-sound it, and then place your screw. So if you actually look at the last line, pedicle screw insertion steps have not changed since 1996 by the gods of pedicle screw, Professor K.M. Lenke. So this is an article from 2004. So exposure has to be perfect. You have to expose the entire area right till the tip of the TP. You have to see the facets well. Mind you, I'm just talking about thoracic pedicle screws in deformed spine because most of our scoliosis are in the thoracic area. So I'm just talking about that right now. The step 2, the most important step, is to identify the superior articular facet. There is going to be a video which is going to talk about it, but just the rules. The superior facet rule states that the ideal entry point for the thoracic spine is 2 to 3 millimeter lateral to the middle of the superior facet. So the number 2 mark is actually the entry point. So once you expose the spine well and expose the superior facet of that particular vertebral body, you will be easily identifying the entry point. Ventral lamina. This is something which has come in. So the yellow line is the ventral lamina. So the ventral line is the yellow line is the ventral lamina. This is the dorsal lamina, and the red line is the medial pedicular wall. So this is like a house, and this is the roof. So the ventral lamina is the roof of the spinal canal where it meets with this wall. So you can actually enter the pedicle and scrape on the medial wall of the pedicle and enter the vertebral body. So your target. So this chart you can place in the operating room. Although I think these are just a millimeter variations, but just remember one thing, that in the thoracic spine, the cephalocaudate position, the cephalocaudate keeps changing. So this small chart can help you to mark your entry point, but I think the video will tell you more. The pedicle screw starting, try and go more ventral. So earlier we would go through the dorsal part. This is the lamina, these are the pedicles. Now the concept is in the thoracic pedicles, try and take a more ventral entry by removing the superior facet, the TP junction bone, and thus being able to start closer to the target. The more close you are to the target, the less likelihood of entering the spinal canal. So the more ventral entry will help you. For that, you just need to take off the inferior facet of the superior body and expose the superior facet well. So this is the gear shift Lenke probe. So once you start, initially you will direct it laterally, and then you come out, sound it, and then you go in medially. So you just scrape laterally to the ventral lamina, and you will automatically fall into the pedicle. So this is extremely important, whether you're dealing with a deformed thoracic spine or a normal thoracic spine. So just to show that, it's a short video, and you scrape and you enter there. So there is a pedicle channel classification, which you need to do in the pre-op planning. So if you have these kind of pedicles, so remember that type C and type D are a bit tricky ones. So you can actually go out and out technique instead of going the transpedicular way. This is, I think everyone knows that the pedicle is the diameter of the pedicle. Once you go from lumbar to thoracic, this is the width of the pedicle. And remember the angulation, the medial lateral angulation is usually around 10 degrees to 15 degrees here. But then as you go up in the thoracic spine, the angulation increases significantly. Most important tip, that you have any doubt in any part, don't hesitate to do a posterior column osteotomy or a laminotomy. It can easily make you feel the pedicle wall, and you can put a Woodson elevator or a McDonald's on the lateral wall, and that way you can easily scrape through. You can have these kind of pre-op models, and you can even have them in a plastic bag autoclave. You can do 3D printing, and they can be very useful if you don't have the O-arm or the navigation guided gadgets available. And this is the standard way. Once you have through, then you palpate all the 4 or 5 walls, take a length, and then insert the screw. You can take a check X-ray like that before you insert the screws in the spine. This is a short video. This is from Kshitij. If you can see, these are the 2 types of probes here. And I'm just going to show how he excised the, so we are just exposing. This is the transverse process. The inferior facet of the superior body has been removed, and this is the area. And the pointer is towards that superior facet line and the entry point of the thoracic pedicle. It's a standard way to take entry, and then all the other steps are standard. So I'm just going to go ahead. I think neuromonitoring has a very important role. It's a standard of care. So I think sir asked that whether you use it for all. Yes, I think you should use it for all. And it can be useful in making your screw safe. Bone is a poor conductor, so more current is required to elicit a response. So if you are able to generate a response for a screw at a much lesser current, then that means you are near the neural tissue. Remember that blood is a conductive allowing current flow. So try and do this when the blood is not there. If you do it in the presence of blood, then you may have a false feeding. And touch the screw tip instead of the polyaxial head. And response received at 8 MA is cause for further investigation. So this is a standard one, that if you have a 5 MA, then very probable that your screw is either touching the root or the cord. And this is, if more than 15 milliampere, you don't get a current, then that means you are safe. So this is very useful. And I'm just going to end with these 3 cases, very short ones. So AIS, 13-year-old, double curve, standard measurements as Hitesh mentioned, and the bending films. So I would plan this with a CT where I'll sit in the console and not order a CT and see at that where there are those small boxes. And these kind of pictures, I'll save it on my iPad for every level 1 shoot and just put it on the anesthesia workstation. And when I'm at D4, I'm just going to look at this one, then D5, then this one. So you can easily actually go through. And so all the levels, just a single shoot, axial cut. So that is useful. But you need to be in the CT console yourself and not the technician who can give you a very nice fancy 3D picture which has of no use. And other one is a traction film, pre-op, if possible under sedation. A negative view sometimes shows you better pedicles than a positive view. So you can actually see more. And the last slide, in this case, CT saved me because this looked like a very, very routine curve. And actually when the pre-op CT was done, most of the pedicles were atrophic. So you may have actually planned a surgery without a CT in this case, looking at it. But I think a CT can be very useful. So to the take-home messages, pre-op planning, CT is mandatory and try and be in the console. 3D models are useful. Freehand insertion is important. First try the deformity, non-deformity cases and then the free deformity ones. Fluoroscopic guidance in concave pedicles is risky. No, never hesitate to do a posterior column osteotomy. Triggered EMG is useful. Navigation, of course, if you have it, then wow, but don't rely on 2D CM guided navigations for deformity surgery. And anyways, in the concave pedicles, which are the risky ones, we are anyways going to do a posterior column osteotomy. So even without navigation, you can actually do a fixation pretty easily. So thank you very much. Thank you.
Thank you, Chirayu. Now, with the gadgets available to you, the best is the tactile feel with a blunt probe.
Yes, sir.
That's the best thing. And other gadgets, they can help you all, whatever you have mentioned. Now, thank you very much.
Thank you.
Any question?
The final sanctity of your result and the degree to which you have made the correction does depend on how well you have prepared the field to allow the correction.
Yes, sir.
It depends on the metallurgy of the implant also. Who has made it? What kind of metal is it? Whether it's going to bear that correction or whether it's going to give way by the time you are closing. I would like to point out that because implants differ a lot in their quality of steel.
Thank you, Chirayu. We are running short of time.
Yes, sir.
So I call upon the next speaker, Hari Menon, to talk on the curve correction, derotation technique. Hari.
Morning, sir. Thank you for the invite. Can we have the presentation? Yeah, thank you. So obtaining the maximum correction through inclusion of minimal fusion levels, getting a well-balanced spine, improvement of cosmosis and prevention of deformity are the main goals of scoliosis surgery. We know that it's a three-dimensional deformity. The apical vertebra is translated laterally in the coronal plane, anteriorly in the sagittal plane, and it's rotated in the transverse plane. So Number of correction maneuvers are available. An ideal correction maneuver would be the one that corrects the deformity in all the planes. So do we have such a maneuver? Among the list, the major ones are the rod derotation, the cantilever, and the direct vertebral rotation. All the other maneuvers should be used as fine-tuning after you obtain your major correction with these three maneuvers. So let's start with the rod derotation. Initially described by Cottrell and Dubois in 1988 with their CD system. It used to be called the CD maneuver and later popularized by Sook et al. In the early 90s with their pedicle screw system. So you place a rod on the concave side of the deformity, secure it, and rotate it 90 degrees. So you have a curvature on the right side, you rotate the rod to the left side. So this would generate a posterior medial vector, which would, yes, correct the translation, restore the kyphosis in the sagittal plane to a certain extent, but probably doesn't do much for the rotational element. On the contrary, for rigid curves, it may even increase the rotation. You can also use the rod rotation on the convex side. The advantage is that the magnitude of the deformity is slightly lesser on the convex side, making it easier for us to insert the rods. The pedicles on the concave, if small, on the convex side, they are larger, and any unfortunate event of cutout is less dangerous as compared to the convex side, as compared to the concave side. You can also attempt a simultaneous double rod rotation. Cantilever means a projectile that is fixed to one end and is able to withstand loads on its entire length. This maneuver is usually used in correction of kyphotic deformity, but it can also be used in scoliosis surgery, where you contour the rod to the sagittal profile, secure and tighten it to the proximal end, and slowly and sequentially get the screws as we go distally. An important correction maneuver is a direct vertebral rotation proposed by Lee in the early 2000s. The concept is a vector is generated on the posterior force, on the posterior side, which is through long screw derotators. This force is applied both on the convex as well as the concave side and in a direction that is opposite to the deformity. So if you remember, rod rotation was to this side, while a DVR would be done to the opposite side. You may do the DVR segmental, that is individually rotate each and every vertebra, or you can do an en bloc where through specialized instrument, through a quadrilateral frame, all the vertebrae can be derotated. The point to be remembered is that the neutral vertebra needs to be secured when you are doing your direct vertebral rotation, lest the rotational forces are transmitted below to your minor curve. Rod translation, these are all now minor correction maneuvers that are there. Rod translation is again contour in the sagittal plane, secure proximally and distally, and then sequentially get the screws into the construct as you move towards the apex from above and below. This maneuver works well with the US's side opening system, and they have their rod persuader, which helps in the correction of the deformity. Differential rod contouring is where the convex rod is under contoured as compared to the concave rod. The difference should be more than 10 degrees in the curvature of the concave versus the convex. So the principle is that when you put in the under contoured convex rod, the vertebra is pushed anteriorly, thereby resulting in correction of the rotational deformity. In situ bending never is a major correction force because it would place a lot of stress on the screw bone interface. Compression distraction can be added, that is compression on the convex side, distraction on the concave side. But remember, in the thoracic spine, compression would cause a hypokyphotic effect. Spontaneous correction is where you get the correction of your minor curve with the correction of the major curve because of the harmonious motion of the double curvature. So my sequence of correction would be having a very good soft tissue release, followed by more curvature of the concave and under contouring of the convex, concave side derotation, followed by cantilevering on the convex side, a direct vertebral rotation. I may add a compression or distraction. And if there is significant deformity even after the correction, I may add a thoracoplasty. But there are other factors as well that are responsible for correction. That is implant density. How many screws do you have per vertebra? 2 being the maximum. Ideally, it should be in the range of 1.4 to 1.6. Have you instrumented all the strategic vertebra? What is the concentration of your screws around the apex? Because all these maneuvers would work well if the concentration of screw in the periapical region is good. And the type of implant, that is monoaxial versus polyaxial versus uniaxial. To conclude, none of these maneuvers are mutually exclusive. You have to use a combination of all the maneuvers. These maneuvers work well when the magnitude of the deformity, the COBS is less than 70 degrees and the flexibility is more than 50%. For more rigid curves, you would need osteotomies, which is probably the topic for the next talk. Thank you.
Dr. Menon was very clear how to maneuver the rod during the surgery. Thank you, Menon. And again, I call upon Dr. Ajay to talk on anterior approach. To talk on spinal deformity, when, which, and how.
Good morning. The platform has already been made by Hari, wonderfully discussed, and the clear principles. If the deformity is flexible, then these maneuvers are working. And if the deformity is not flexible and the curve is of a higher magnitude, then we have to go in. We have to go in with the osteotomist. They are probably the most radical procedures what you do in spine, and being spine surgeons or orthopedic surgeons or neurosurgeons, we all are sparked or say it is very exciting for each of us to do this procedure. At the same time, this can dash your expectations also. Yeah, coming to the osteotomies. To make it simple, I'll take up a classification and make it understand. So Schwab classification is the first one, which comprehensively includes most of the classifications to give a fair bit of idea what can be done, because there is very significant amount of communication gap, nomenclature differences, and number of procedures what has been mentioned in the book. So Schwab, he mentioned it into 6 grades. The 1 and 2 being the smaller one, and on the posterior, that's dealing with only the facets and the soft tissue. The 3 and 4 is basically more aggressive and dealing with the body also. And 5 and 6 are excision of the complete bodies, or we say VCR. So this is the best way to remember it. I'll go one by one. So the grade 1, it is the partial facet joint resection. This is the 1945 description, early started in the ankylosing, early wet cases. And the examples of they are this Smith-Patterson osteotomy, Chevron osteotomy, or extension osteotomy. These have multiple osteotomies have been described, but this deals basically with one thing: removal of the inferior facet of this segment. That is one. This needs the anterior column mobility. So the ALL and this needs to not be fused. Then only you can get the cantilever and get the action at the segmental level. The other one is also of the smaller mode, that is grade 2. That involves complete facet joint resection. That is to say the superior and inferior both facet resection with more wider removal of all the soft tissue attachments, supraspinatus, infraspinatus, the capsule, the ligamentum fleum, all of the extent of it is removed. So it creates this much a void. And 1987, Alberto Ponto is who described it very well. And this is a very good procedure. But again, this is segmental procedures, and you need to add more than one segment to get more greater corrections in flexible or even tighter deformities, both in kyphosis as well as in scoliosis. The amount of correction you get in the grade 1 is described though till 10, but you don't get that near. You get usually around 5 degrees. And what you get from the complete facet joint resection and a complete Ponti can be up to 10 degree. And this 10 degree can be increased to up to a 15 degree if you go transfacetal and do a anterior discal release. So a posterior procedure itself, you can get more up to 15 degrees. So an example of a grade 2 is a neurofibromatosis. Scoliosis is there, but it is well balanced, but it is the kyphosis, the component which is more apparent. And that's why you will do only the local thing and multiple segmental Pontis, and you can get away with a good correction without doing aggressive and a significant VCR or things. This is another for a Ponti. This is a very rigid curve. This is say 76 degree, got corrected to 34 degrees just by doing Pontis. So in a sagittal plane also, you can get corrections, and you can do in the, in the coronal plane also, you can get good correction by doing asymmetric releases. Say you on the concave side, you release less, and you can release more on the convex side and compress it from their side. So it is all about a wedge and its compression of our traditional training. Now the grade 3 and 4, that involves the posterior elements as well as going into the vertebral body. And basically it is involved with removal of the pedicle. So grade 3 is removal of the pedicle. So what you do here is you remove the pedicle, you remove a wedge from the body, and you remove both the facets. You have enough of space posteriorly, and you do a compression there. So it is extension osteotomy which you create. And for this osteotomy also, the basic requirement is anterior mobility. So you need that anteriorly there is soft tissue hinge or a bony hinge, and it is difficult to do or when it is completely fused, but you can still do with it. You have a hinge on which you do this, and the ideal thing is a sagittal deformity with a sagittal imbalance of more than 12 centimeters. So the deformities with Pontis and things you can go for in sagittal plane up to 6 to 8 centimeters. You can easily correct a sagittal global profile also. But here you can easily correct beyond 12 centimeters of SVA imbalance. So this is a grade 3, a PSO, an Anki, which is a 12 centimeter, which is the SVA which is there, and you can correct it with a single level PSO, and you get this correction. So this for Angst-Pont, this is the deformity correction surgery which you do. You are doing more nearer to the apex of the deformity in the dorsolumbar region. But at the same time, if you want to achieve more correction here, that is to say, if you want to restore more lordosis, you have to keep your osteotomy lower. If you do a L4 or L5, you can even restore better lumbar lordosis. So grade 4 is again a pedicle removal, body resection type of osteotomy, but here you also remove a part of the disc. One disc, either the superior or the inferior disc is removed. That makes one good thing in this achievement. That is to say, the degree of its achievement goes on to even 45 degrees. That is the 45 degrees and even 60 degrees in some hands. So you can remove this wedge, or you can remove this wedge and the lower disc. So this is there. But this is difficult to be applied into ankylosing spondylitis because there the anterior ALS is fused, the anterior disc is fused. So this is more for the lumbar revision surgeries, flat back syndromes, where this is very much helpful.
Then the grade 5 is about a complete vertebrectomy with above and below disc removal. And this is complete removal. And this is what we call also VCR. And this grade 5 and 6 is more for attaining balance as well as correction of the translation and the angulation. So that is the most important thing. So you are shortening at the same time you are translating, then only you are needing the 5 and 6 grade of the procedure. And this includes angular deformities, the hemivertebral resections, spinal tumor resections, post-traumatic deformities, or the spondyloptus like the high-grade spondyloptosis. So single vertebra excision like an en-bloc vertebra for a solitary match, this comes into the grade 5. So you are completely denuding around the cord and then you are removing it. Grade 6, again, this is multiple vertebra removal. The type 5 with multiple vertebral removal. Here you are removing the ALL also. In 5 and 6, you are removing the ALL. So the worrisome thing is that you are having a chance of decompensating and translating. So this is multiple vertebral removal for kyphotic. You achieve good corrections, but at high risk. And this is the simple way to remember this, the degrees which you get with each of this. Some special mention about a crack osteotomy. This is to be done in again revision cases like these cases where already there is a fused mass there and there is SVA there. So you try to break it off through the fusion mass. You go through the pedicle and then break it and then correct it. So this is crack osteotomy for fusion procedure. Just not to forget, this is addition now over this schwas which has been done. This is for minimal invasives. For the lumbars, now a simple lordotic olive cage can also give you a good amount of correction to 20 to 30 degree, which can be increased by posterior combination fascectomies or complete fascectomies. You can achieve up to 50 degrees, 60 degrees by 1 to 2 levels of lumbar surgeries. So this needs to be added with the minimal invasive spine advent. Thank you.
Ajay is very clear in osteotomy and Pontes, and so there is no need to ask any question. Thank you, Ajay. And I also thank the organizer for giving this opportunity. I thank my both the chairmen, Pathak Sahib as well as the Nayak Sahib. Thank you.
Thank you, sir.
Thank you all. After a too long session, it's time for a coffee break. So we are having 10 minutes coffee break and then we are coming up with plenary session and inauguration. So probably that would be the most important. I thank all the chairpersons. Thank you so much.
Coffee is outside. Please go outside.
May I have your attention, please? Please take your seat. We are about to start the plenary session. May I request all the office bearers to wear their badges. So the flow of the plenary session is first the auspicious inauguration, and followed by we have a presidential oration, and then we have Dr. Dinubhai Patel memorial oration by none other than Dr. CHADDHA. May I request Dr. Bharat Dave and Amit Jhala. Pratik, Amit Bhai and Bharat Bhai. May I request Bharat sir and Amit sir to take the chair. Amit bhai, please come on the dais. Now we are ready for the inauguration. May I request our all past presidents, Dr. Nayak Sahib, Dr. Pathak Sahib, Dr. Prabha, to come forward to light the lamp. Pratik, lamp lighting, please. May I request President Dr. G.D. Tharadhara sir, Bharat sir, Amit bhai, please. May I request our faculties, national faculties, Dr. SRIVASTAVA sir, Dr. CHADDHA sir, VISHAL, Guru, RANJITH, APPAJI, SANDEEP, SHAILESH, CHIRAYU to please come forward for the inauguration. May I request Dr. Subir Jhaveri, our Vice President.
आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय श्रीपज्योतिर्नमोस्तुते श्रीपज्योतिर्नमोस्तुते श्रीपज्योतिर्परब्रह्म श्रीपज्योतिर्जनार्दनः श्रीपज्योतिर्परब्रह्म श्रीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोस्तुते.
May I request all the office bearers to please come forward for a photograph. Hitesh, all the EC members, Mayur, please. All the EC members, please come forward. Thank you. I will hand over the session to session chair and moderator, Dr. Bharat Dave and Dr. Amit Jhala. Amit bhai? Yeah.
Hello. Yeah. So now moving on to one of the most prestigious session of this meeting, and these are the presidential oration and the Dinubhai Patel president oration. We all know that Dr. Dinubhai Patel was stalwart, and he actually started not only our Spine Association of Gujarat, but he also started the Association of Spine Surgeons of India. So we have this in his name, Dr. Dinubhai Patel oration. Before that oration, I would like to introduce Dr. G.D. Charadra, who is going to give the presidential oration. Because of the COVID, he had a long tenure of presidentships for 3 years, and this was the first time that any president has remained for 3 years. There were so many thoughts before this meeting, how to have this presidential oration and how to have this meeting, whether you should conduct it virtually last year. And then there was a thought that we might have to do a very small meeting. But I think he has got a grand meeting today, and he's going to present us his thoughts and views on the TILIF. Let me introduce him. Actually, we know each other for last 30 years, and we have been together in the same unit since 1993 to 1998. We worked together in the same spine unit or the same orthopedic unit. And then after that also, we have continued to work together. So I know him for last 30 years. He has passed his MS in 1992. So he has completed 30 years as an orthopedic surgeon. And for last 25 years, he was with the teaching institute, BJ Medical College. And he was also head of the unit, and he retired in 2016 as a professor of orthopedics. Having said all that, let me give you his personal, and because I know him very personally, he is one of the great teachers, a very, very meticulous surgeon, honest, thoroughly, not only to himself, but patient also. So whenever you see him counseling with the patient, he is very, very genuine and thorough person. And in surgery, he will not allow even a 1 or 2 degrees of mismatch. So he's that perfect in his surgery also. With all this small introduction, yeah.
Would like to add on to only one thing. He's the fan of the female club. Why I say this? Because he does the meticulous planning of the food. And he is there dot on time. Whenever there is a meeting, whenever there is sort of, the program, and he is the one who is assigned that food and beverages. And, he's just there. And he does the testing, and he just does the meticulous planning. So that is Dr. Charadra. So welcome, Dr. Charadra.
So even today's food that you are going to eat is a menu of Dr. Charadra.
Thank you, Bharatbhai and Amit, for your kind words. And I welcomes all the delegates. Thanks for my faculties who came, spare their time for their valuable feedback and knowledge. Where is the slides to start with? Okay. So, this topic of this lecture, in this conference, an advanced topic, I am hesitating to go on this TILIF topic for some time. But Subir told me that we need some your wisdom. But I think still I am struggling with my wisdom teeth. What is to wisdom? But still decided, Let's have some basic for particularly juniors and your resident doctors. During my residency, my dissertation topic was spine. There is some temptation for spine. I learned my fusion in 1992 while fourth year at SAJAN Hospital and Ramadi's course, International Spine PLIF course. During my residency, the gazettes are not available, pedicle screw and everything. We used to bend the 6 mm K nail and take sublaminar wiring and do fixation in traumatic spine also and sometimes tuberculosis also. So I passed through from sublaminar wiring, Harrington, Steffi, modulars, pedicle screw systems. So we have to accept the changes. We have to follow for survival, for our profession. We have to accept the changes. We have to follow the principle, new principle, everything. Just like AO. Initially, they say the rigid fixation. Now AO came to be a stable fixation, biological fixation. So that is one part. We have to accept this journey, new events, new gazettes and everything we have to accept and go on. Now regarding TLIF, why I have selected? Because this is very creamy surgery for initial. Sorry for my throat actually. This case. Sorry, yeah. Thank you. This case, young patient, isolated disc degeneration with protrusion and back pain and everything. We'll find different view on this one. Endoscopic surgeon or minimally say, I will go for just minimally invasive and decompression and forget about. Patient visited another doctor who is favoring the fusion. Say, oh, there is a possibility of the recurrence there. Listhesis may occur. Back pain will persist. Again, patient consult to third surgeons. Okay. If you go for fusion, that possibility is there. Adjacent segment problem occurs. And if complication occur after surgery, then another fourth surgeon say there was no need of the surgery also. So we are getting a patient with different opinion every day. So I am saying we, means including me also. Not I am blaming anyone, but me also. So this case, you see, excellent fixation, segmental lordosis maintained, cage placed well, everything looks good. And we can Atma Tara Bataviye, patient. You will be fine, you can do everything, there is no recurrence, there is no back pain, and to some extent it is right. So many my patients, after 15 years, 20 years, they are doing farming, driving tractor also. But is it true? Why is it not moving? Not moving. Why not you show me a total, total play, total display? It's not moving. Yeah, that's a good thing. Okay. Yeah. So this is true. All these things in longer follow-up. There are many factors for long follow-up, long-term result. There are many factors. Some ones are in our hands, some ones are not in our hands. We see, this is one case. Old lady, severe claudication, perianal hypothesia, flexion attitude. We did it. Good length, good convergence screw. These are bicortical screw, cage placed well, good alignment. Do you think everything is good? Yeah, patient is happy. After 10 days, I allow her outdoor activity. She is fine. No claudication, no perianal problem, everything. After 1 month, I allowed her to do outdoor activity. But she started walking in the garden, everything. Still, she is asymptomatic. No complaints. He doesn't know anything about what's going inside. But this is happening, screw pull out. This patient, we have given pre-operative, post-operative paratide, teriparatide. Still this happened. Why? Not only osteoporosis, but muscle weakness, patient's preoperative attitude, flexion attitude, walking in a flexion attitude, chronic fatigue muscle, that also play a very important role. Sometimes what happen, senior consultant see the patient lying down in the ward and then he attend the patient in the OT after prone position. He may not have seen patient walking in the OPD, or it may be attended by junior doctor or physiotherapist. We will miss in old age, not only osteoporosis, but long posture of the patient, osteoporosis should be considered. This another case having a long journey. I did this patient in 2008, L45 TLIF. Within 20 days of surgery, patient driving 250 kilometers came to me and I say, why you are doing this one? So I am very fine, I have no complaint. Then after 3 months, I lost the follow of that patient. After 7 years, he came with back pain again. We see there are problem with L5S1. MRI. There is a multi-level disc degeneration, but there is retrolisthesis L5S1, some problem. So now he blaming me, something wrong from my side. So again problem occur. Why? Initially he was very happy. So he consulted another surgeon. Another surgeon has operated L5S1. See, both cases, the cage is also rotated after some time inside, after operation. Still, after second surgery, patient was not happy. Persistent back pain, everything is going on since. So why? So even after another, I think 4 years of second surgery, still patient have a problem is going on. Balance, it is commentable. Sagittal balance, in this case, if you see, there is a commentable. But why this happening? We evaluated further. Again, patient come back to me, blaming other surgeon. સાહેબ તમે પહેલા સર્જરી કરી મને આટલા વર્ષ કઈ જ નતું, આ બીજી સર્જરી કરી મને અત્યાર સુધી પ્રોબ્લેમ ચાલુ છે. So this is X-ray. Problem occur in the cranially. CT scan, so good fusion in lower part. So no, any problem or any pain generation is not there. So now whom to blame? This pre-existing disc degeneration or the previous surgeon or activity of the patient. So these are the factors are not in our control. It's before surgery, that we will see later on. So in 2020, he came to again to me with forward flexion attitude, and we have done this dynamic X-ray, CT, and MRI, everything. 2, 3, 3, 4 problem. So pre-existing disc degeneration, normally here there is a loss of lordosis in lower lumbar lordosis. Usually we will find hyperlordosis in upper lumbar vertebra as a compensatory mechanism. But in this case, we are not getting retrolisthesis, but we are getting antrolisthesis. As you have seen previously in this X-ray, you see here. So here is the segmental alignment is the factor, or there is another factor also for antrolisthesis. You see here, total sagittal orientation of the, total vertical orientation of the facet joint. So normally, if you see the L4-5 lordosis is not maintained, then hyperlordosis occur in the upper lumbar, but here it is occur in another way, antrolisthesis. So not only standing biomechanics, but pre-existing disc disease, natural alignment of the facet joint, patient activity, many factors which are not in our hands, that we have to identify very well before surgery. Another case operated in 2018, already pre-existed many level disc degeneration except one level in lumbar spine. We operated L4-5, very obese patient. This is an X-ray of after 14 years. This X-ray taken, we came to 2020. After 14 years follow-up is a very good follow-up. In a pre-existing disc degeneration, obese lady, housewife, very good follow-up. but patient presented with claudication. There is no instability. I have taken X-ray, I have not shown here, but you see MRI shows severe stenosis. There was no facet arthritis, diffuse disc bulge, ligament of flavum thickening was there. So we decided we go for olive instead of to open up to the S1 again for connecting road. In a obese lady, we decided to go for olive. We did olive. Patient was happy for 2-3 days. In a post-operative ward, he started walking. Now claudication, everything is good. After stitch removal, 10 days again, she came back. I have again claudication. So what went wrong? Everything is look good. So patient have a post-COVID. We have seen many patients post-COVID muscle weakness, vitamin D3 deficiency. Injection Aeroketal, patient start, oh, I feel better. Another case, segmental lordosis matters, single segment lordosis matters. There are many literature says it doesn't matter if there is a good overall sagittal balance is maintained, their single segmental level is not better. But I say it matters when there is a pre-existing disc degeneration is there. Presented with young male patient with cauda equina bladder bowel involvement. We did decompression and fusion. Questionable lordosis means alignment, but L3-4 it is a straight horizontal L3. Patient was happy, fully recovered, neurology, power, bladder bowel, everything. 7-year follow-up. He is farmer, he is doing everything. Sitting on ground, bending forward, everything. Now after 7 years, he came with back pain and radicular pain again. And that time I found this X-ray. The subsidence of cage, loosening of implant, nutty is gone. So when this happened, we don't know, even patient don't know. But patient have a adjacent segment degeneration at the caudal level with complete myelobacter, radiculopathy and claudication. So at this case, we can say that there is a compensatory hyperlordosis at the caudal level leading to the secondary stenosis and degeneration associated. So we must maintain segmental lordosis in a cases where there is a pre-existing disc degeneration there. Otherwise, we may find foraminal stenosis or pseudobulge or anything, whatever. Another case, having metabolic bone disease. Very difficult to negotiate the even 5.5 screw. I inserted 5.5 with pedicles after tapping even. This patient have some cardiac anomaly. After cardiac surgery, we did decompression of this level. 1 year follow-up, patient have no problem, no complaint, no back pain, no claudication. But as per my routine follow-up, at 1 year, I did flexion, extension, X-ray. There was a breakage of screw. Metabolic bone disease, particularly fluorosis or DIS, chances of fusion rate is very low. An implant failure, even though this everything is good, case is at place, no any segmental mobility, but still screw broken. Implant failure, case displacement, everyone have faced this problem. This patient having diabetic neuropathy or autoimmune disorder, he fell after 20 days of surgery in bathroom because of orthostatic hypotension, case displaced. And as we have seen in all cases, kidney cases are on OT, you have seen a perfectly dead lateral. Post-operative X-ray, we found slightly rotation of kidney case. It is very commonly we have seen. Why this happening? As we see, the kidney case is bullet shaped. There is a narrow space, comparatively narrow. Normally, if in this case, I will give you an example. This is right side, this is left side. We are operating from right side. We put a rod on the opposite side with slight distraction or some stabilization of segment. We insert the case from the right side, and our attitude or even just practice is there. After inserting the case, we try to compress with single rod on the opposite side. If you compress here, it is eccentric compression on the narrow part may displace the case slightly posteriorly or this one. That first displacement have more risk for subsequent rotation of the kidney cage. During my early phase, most Miami was there. I used to take bilateral compression simultaneously. But nowadays, implant company not providing two compression, two distraction in their set. So in this case, after putting kidney case, it is better to put a rod on the your side, compress first on this side. So you will stabilize the case properly, or you compress bilateral simultaneously. So this I haven't seen many, even my cases also. Infection, many inherent factors are there. Some are our in hands, some factors are not in our hands. So I'm not going in detail that about peak case. It is considered as something bioelastic initially, and it is lot of used peak material. Nowadays, literature shows peak case can produce aseptic loosening. In this case, displaced case, I initially think it is mostly it's because of infection. Open up, curated everything, biopsy, culture, everything is normal. Put a bone graft in the gap, patient was all right during follow-up. So it is aseptic loosening, and because of that, all literature review, now they came with a titanium coating on peak cage also. So is it TLIF is forgiving surgery? I say no, after all long journey of my follow-up and this one. There are many factors, some in our hand, some are as not our hand, that I already mentioned. So complication occurs with overconfidence or ignorance. Sometime after one or two initial case of TLIF, we are so happy, chalta hai sab kuch. For short term, definitely we will be very happy, but we don't know what is longer follow-up. During 30 years, we face our case during follow-up. So complication occur with confidence and ignorance. Okay, thank you very much.
May I request the past president? Sir, please. Sir, please. May I request Dr. Nayak sir to come and give a memento to our president, Dr. GD Dattara sir.
Thank you. That was excellent experience sharing by Dr. G.D. Tharadra. Now, in the crowd, what I can see is from baby boomers to Generation Z. And we have all, kind of audience here. The spine fraternity, as such, most of us are from the orthopedic crowd and orthopedic trainees, and probably the humbleness you probably, gain, achieve, get, when you become a spine surgeon. And that's what the humble introduction is of Dr. Ram CHADDHA. I invite Dr. Ram CHADDHA to give his presidential oration of Dr. Dinubhai Patel. Please, sir. How to introduce Dr. Ram? He has sort of imbibed the spine within him. And the S start with sympathetic and empathetic gentleman and the man. He is very, very polite. I have seen him attended his meetings, have been part to many meetings as well from the day I started the spine practice. He is probably, I starts with ideal human being. If you really want to know, if you really want to, have kind of, somebody to follow or somebody to mentor, then probably he's the one who should be, probably the ideal human being. He is naive in each of the meeting. When you listen to him, we were together in few days ago, one of these the non-verbal communication meeting, and that naiveness gives the best out of him as well. You know, he will start speaking and he will share his experience. And it was one of the best experience I ever had about the NVB, non-verbal communication. We had the meeting, which is IOA meeting as well. If not, you know, if you have not attended, might as well worth attending. How do you, you know, communicate with your patient, and, you know, how do we make best out of the non-verbal communication, patient's attitude, and the doctor, as a doctor, how we should behave. So that was Dr. Ram. And I think E is spine, S-P-I-N-E. E is immaculate. He is spotless. Well dressed. He is one of those, you know, guy who would like to, you know, sort of ideal human being as well. So with that, I welcome Dr. Ram. One sentence about Dr. Dinubhai Patel. I see him every day in out. There are persons who are sort of, you know, every day in my friends. Was teacher when he teacher as well, because he donated ago before he, you know, something may come to his mind. You know, he went to the anatomy department a few months ago. Remember that, you know, we had this signed document which was signed by him that I would like to donate my body. So that is Dr. Dinubhai Patel. After the death, you know, he remained teacher. And till then, you know, he used to share each and every experience of him. And I have learned a lot of things from him as well. So that is why, you know, he is in front of my eyes every day, in and out. So coming to Dr. Dinubhai Patel's oration, I invite Dr. Ram. Please start your oration, sir. Thank you very much.
Respected seniors, dear colleagues, I am indeed humbled to be present here speaking about a legend who has been a role model and mentor to many of us. I thank you for giving me an opportunity to pay my homage to this godly human being. Dr. Dinubhai Patel Memorial Oration, a man who graced this earth and this universe for a short period of time, but left a huge dent not many could repair or change. He was humble in his aspirations, graceful in success, and very resilient in failure. Early education to orthopedics, he stood first in Baroda in 1949, 2 years after our nation got independence. Became an MBBS from the Baroda Medical College, the MS University in 1956. Went to England in 1959, was a favorite student of the anatomist Dr. R.J. Last. Came back to India and joined the VS Hospital and Civil Hospital BGMC in 1962, a year before Dr. Bharat Dave and Ram CHADDHA were born. The year we were born, he established the Department of Orthopedics in Gujarat. And what he taught us was that we don't need to just go through life, but we have to grow through life. Professionally, he became the honorary head of the BJMC and Civil Hospital in 72. He encouraged both research and patient service, which were both very, very close to his heart. He was a poet in there. Pebbles on the Shore is what was published in 1979. He was given an additional position of additional director of the Paraplegia Center in the new civil hospital at Ahmedabad in 1984. He then initiated his paraplegic safari project, which was a pet project for him, and he traveled all over to gain people to participate in the same. It's probably the first time that a gold medal was initiated by his students who had so much respect for him. And I am really touched that all the people got together, initiated the Dr. Dinubhai Patel Gold Medal. This man looked far beyond and changed his focus when he wanted to. Why did he do that? Because he believed you get what you focus on, so focus on what you want. His persona, he was a cartoonist besides being an excellent poet. He traveled all over with his camera, with everything, with his caricature artists that he had. He was a photographer. He actually had the second ASICON in Ahmedabad in the year 1987. He was the ASSI, Association of Spine Surgeons of India orator in 2002 and received the Lifetime Achievement Award in the year 2003. There is no organization in Gujarat or in our country which existed at that time related to orthopedics in Gujarat and spine in our country, which he did not steward and was not the president of. He was the past president of the Ahmedabad Orthopedic Society, the Gujarat Orthopedic Association, the then Gujarat Spine Association, which is now the offspring is called the spine, the message that we have today, and the Association of Spine Surgeons of India. I pay my respect to this man who had a passion for his purpose, a compassion for his colleagues, and dispassion for any sort of designation. I share a small journey inspired by this legend who still lives within many of us. I believe success is not final. Failure is not fatal. It's the courage to continue that counts. And here I quote Winston Churchill. I begin where Dr. Tharadhara probably finished. 2001. Something that I essayed to give my ego a drive. I corrected what looked uncorrectable at that time, stabilized it and put a non-fusion option at the level above. I was happy and so was the patient for 12 years. 12 years later, he came with an adjacent segment disease, which I didn't know was called the same at that time. We said, it's just a process of aging. So what? We removed that flexible rod, put in a solid rod and went above. Then the story began. Every year, something happened. And Dr. Tharadhara, unlike you, he kept coming back to me. If somebody else takes over, it's great because then all your past sins are washed out. But this man had extra love for me. He came back and I didn't know what to do then. I had done my best. It looked biomechanically good, but as you rightly said, quality of bone, he's aging, he's male. So what? He could have osteoporosis. We also gave him expensive teriparatide at that time, sir. Despite that, I learned that now we've got adjacent segment disease. 4 surgeries, 2012, between 10 and 12, 4 surgeries. Then he came back and I was very happy. Now I've even put something in between. Things look good. I've gone beyond the thoracolumbar junction. Everything will be fine. And I felt really good. I said, success is final. Failure was not fatal. And I thought I'd achieved it all. Not for too long. 2014, a disc pops out there. Nahi yaar, mere implant ko to kuch nahi hua, abhi disc ko kya karu? Disc pops out. It comes with, for the first time, a neurology which needs surgery. We go in as an emergency and I go all the way up this time. I learned to go beyond D4. It's the best. So I went up to D4 and I stopped. And I said, now nothing will happen to you, sir. He's growing older, so am I. He's growing wiser. Maybe I'm not. And we reached that level of D4. And I said, sir, abhi kuch nahi hoga. We finished teriparatide for 2 years. I said, now your bones are better than mine. Then this man comes again in 2015. This time with a disc popping out at D3-4. I had never seen this in my life earlier, and I don't think you would because you haven't seen this gentleman. This time I said, I'm going to go something even further. So I put in screws and I put in wires. I said, we're going to put screws, rods, wires, and I go all the way up to D1. I said, now I started planning cervico-thoracic junction pe kya karunga. 2016, this is where he was. Unfortunately, he succumbed to a medical cause a year after his last surgery. Ladies and gentlemen, I look back and I look ahead like Janus in the month of January. And I go back 1978, 26th of May, when I passed my SSC examination. This was the day I gave my last paper. These were my classmates. That obese kid in the center down there is yours truly. We had an Idli Dosa party. I was coming back to Matunga, where I live, from Mahim, which is across a bridge called the Tilak Bridge. And I was coming by this BST bus. I had not traveled much by these buses, but I got in there and took out a crisp 1 rupee note. You remember those notes where Gandhiji looked to the left? This is that note. Now he looks to the other side. So this is that note, and I took it out and handed it over to the conductor, and these were the tickets that we had at that time. This is what our conductor looked like. And I gave him that very proudly, taking out that 1 rupee note, and the conductor looked at me and said, "I want change." I said, "I have no change." Tang, he pulled that bell down. That's how we have it in Mumbai. And he said, "Aap utar sakte hain." The bus conductor taught me that first lesson in life: always bring the change you need. I came home walking across that Tilak Bridge, an obese kid like this, weighing about 90 odd kg. It was quite a challenge. I got home, handed over that crisp 1 rupee note to my father. He looked at me and said, "Son, always bring or be the change that you want or you need." Two wise people, the bus conductor and then my dad, said the same thing. And I started scratching my back, looking at that bicycle which I was given to lose some body weight. What is change? Change is a challenge minus LLE. All you need to do is leave your lethal ego aside. You will achieve change. Where does this come from? It comes from the wants, the needs, and the deserve. I've always said, and I believe in it, you will be served what you deserve, not what you want, nor what you need. Ladies and gentlemen, you may strive till the end of your life. You will be served only what you deserve. And how do you improve on that? Do you remember this? During COVID times, you all received this information. I'm only repeating it to you. The experiment of hope. What is this experiment of hope? Well, in 1950, Dr. Kurt Richter in Harvard got these brutal study sanctioned, which he did on rats. What did he do? He put them in those big sort of beakers that we had, filled them with water and allowed them to swim. These poor animals can't swim. And most of them started sinking at about 15 minutes. Then he came up with another idea. At about 13 and a half, 14 minutes, his team started taking out some of the rats, cleaning them up and dropped them in again. This time, he let them sink and wanted to see if they come out in 2 minutes, 5 minutes, 10 minutes. Ladies and gentlemen, do you think that they lasted for a longer or shorter time? Well, they lasted not for a few minutes, not for a few hours, but for 60 hours. 60 hours, those rats which were allowed to swim again survived. What does this mean? It means that if you've been rescued once, if you have that hope, you can actually outdo yourself. If hope can get exhausted, the rats can swim for much longer. It's your belief in yourself which pushes you. The first time when you've not seen any hope or belief, you give in much easier. But otherwise, you can outdo yourself multiple times. What's the role of hope and what does it teach? It teaches us that we should never, ever give up. It's the courage to continue that counts. Let's look at those two little frogs who were on a rainy day running around and they fell into an urn of milk. One of them was like that lazy rat. I'm using the word lazy because he'd never seen hope. He sank. The other one kept paddling, kept paddling, kept paddling, till that milk turned into butter and he rescued himself out. Yet another story where there was a lion who got his hands onto a cow. It was raining, this cow had strayed out and the master, the keeper was not around. And this lion pounced on her, she jumped into a running river and they both got stuck. It was pouring very heavily. The lion was within striking distance but couldn't reach to her. Both of them were stuck in that river. And the lion was just waiting and he looked at that with thoughts that let this rain stop and I'll now have a lovely meal. What did the cow think? The cow thought, let's wait for a little longer. My master will come. I have faith, hope, belief, and trust that he will come and rescue me. And that's exactly what happened. What is faith? Faith is full assurance in the heart. It is an acronym. What is fear? It is false evidence appearing real. When faith overcomes fear, that's success. We all look at this word hope. What is hope? Well, hope is just the first rung of the ladder. Hope builds belief, belief builds trust. For us in the English language, all three seem the same, but I'll run you through what they really mean and things which are close to us. Hope is with what your patient reaches you and takes your appointment. Belief is what develops in that patient when he's sitting outside your clinic waiting for you, talking to your staff, talking to other patients who've been there. And trust is when he finally agrees to let you perform surgery on him. Am I clear? It's hope, belief, and trust. To make it even clearer, very often we used to see this in our childhood, and you must have seen it in Gujarat, we saw it in Maharashtra, where people who were not very well to do would come and perform like circus artists or trapeze artists in open areas. We would have this family where there would be a mother who's breastfeeding her child, and there was this husband who would walk up a large ladder, stand at one end of a rope, and then like a trapeze artist walk across that rope to the other end. Have you people seen it? Yes, you have. We would all hope that this man does not fall. Am I correct? That was hope. Then this mother would hand over that infant whom she was breastfeeding to the father. And we would all say, no, no, don't do this. He would then climb up with this child and walk across with that child on that rope. That built your belief that this man is capable of doing it. What is trust then? Trust is when you as a bystander can hand over your 1-year-old infant to this man to walk across that rope. We have to go through hope to belief to trust. It's when we believe and get trust that all that we've done will become successful. Trust is the cornerstone of anything that we achieve in life. I shift directly from trust to where did this all begin? It began from what was our basic need for survival. What is the need for survival? According to Abraham Maslow, who many years back spoke of the hierarchy of needs, he said right from bottom, physiological needs, where we want to survive, then we cry when we want to survive when we are born, then we need some sort of security of our parents, then we want some stability, then we want success. And at success, we stop. No. There is a fifth rung of the ladder, which is the second mountain to climb, which is significance. And each one of you today have to climb that second mountain, not after the fourth mountain, but from the very beginning. From survival, we have to do something of significance. At the time of stability, we have to do something of significance. At the time of success, We have to consolidate that significant mountain. And hence, we have to go beyond these two additional needs that we have created now of Wi-Fi and battery, and look far beyond these distractions and actually develop our actual way of looking forward and looking back. One step forward and two steps back, so that we can recoil, build momentum, and go ahead. We've done this over the years, but we still need reminders. I take you to a story we've heard so very, very often. 11th of April, 2011, a young lady gets thrown out because people are trying to steal things from her in a railway train near Lucknow. She gets thrown, she gets crushed by a non-running train from the opposite side. She gets a pelvic injury on one side, monomelic polytrauma on one side, a fracture of the femur on the other, multiple facial and chest and abdominal injuries. This lady is looking at disgust, defeat, disability, and death. Her name, Arunima Sinha. What does she do? Well, she fights for life, and she's taken from Lucknow to Delhi for further treatment. This happened in 2011. 2 years down the line, 21st of May, 2013, Arunima Sinha summits Mount Everest. How many of you have summited Mount Everest? Less than 2 years later, she started training after all these multiple injuries, and she summits Mount Everest. Is she made of something different? Or is she made exactly the way that we are? Well, we are all made of the same thing. What is it that makes her different? Well, for her, no mountain is too high. She's born again to summit any height that you can look at. She climbs it, and because of that amputation and that prosthetic limb, today the government of India on 3rd of December celebrates an international day for persons with disabilities. This is created by one woman. A woman who walks better than you and I. We've seen her recently, despite that prosthetic limb and besides all those fractures that she had. How many has she summited? All the 7 summits, highest. She's now looking at Arctic and Antarctica. This is her future plan. Isn't it time to pause, time to reconsider, time to think, where are we going? How am I doing? What am I doing? Where am I really going? Is it not time that we sit down and think? We are all here like thermometers. We only change with the temperature. It's time that we become thermostats. It's time that we change the environment by making an effort and being proactive. Don't remain thermometers. It's time to become thermostats. Try to dream so big that it should scare you. You should be vulnerable. And why should you be that way? Because you need to perform. Anybody been to Australia? Anybody seen this place called the Cliff Young Park? If you have not, it's time to go there. And in the center, there is this huge statue of a gumboot. Why the hell would they have a gumboot? Well, it's by a gentleman called Cliff Young. He's no more. What did he do? In 1983, age 61, Cliff won the inaugural 875 Westfield, Sydney to Melbourne ultra marathon in 5 days, 15 hours and 4 minutes, becoming a national hero. He trained on his farm chasing cattle in gumboots and started the race wearing the unusual footwear which became part of his national image. Cliff's peculiar style, called the Cliff Young Shuffle, has since been adopted by other ultra marathon runners. For many years, Cliff was a familiar sight around the district as he trained and shuffled. What is it that brought him there? Well, Cliff Young was not a marathoner. He was just a potato farmer. He did not know that you could run this race for a particular number of hours and then rest for 8 hours and run again after that. He just kept running from start to finish 875 kilometers. This is what that man did. He broke all records. He had no formal training. He ran without sleep. He beat all the sponsored young athletes. And when he was asked how the race was, all he said, it wasn't easy. Gentlemen, the difficult is what takes a little time. The impossible is what takes a little longer. Fridtjof Nansen, 1921 Nobel Prize, Norwegian explorer. He helped millions of people survive 100 years back when people were stuck and there was COVID happening elsewhere. Not COVID, but the previous pandemic, 100 years back. He knocked off the INM from the impossible. And I share this journey of mine from the day that I entered orthopedics as house surgeon in Dr. Nandulad's unit till today when I stand before you making this presentation in memory of Dr. Dinubhai Patel. And I have certain short take-homes from here. We can discuss difficulty, disability, and deaths with a little bit of dedication, determination, discipline, and devotion into success. And how do we do that? We have to only expect more from ourselves. Who is this? We all know this is Sergey Bubka. What is he famous for? Well, he's famous for not the 6 world medals that he got in the World Championship for breaking the world record. He broke his own world record 35 times in the pole vault. Sergey Bubka was the uncrowned king for years at end. And what did he achieve? Well, he achieved all this because he looked beyond the imaginary finishing line. He literally raised the bar. Quitters never win, winners never quit. It's not that they do things differently. It's things that they imagine they can do, which they execute, and their body follows. They have trust in themselves. They compete not with anybody else, but with themselves. They don't believe in proving, but in improving themselves. And a short line. It's just these 10 words of 2 letters each which matter in life. If it is to be, it is up to me. Gentlemen, if you take home something, it is this, because it's in you and you have to be both the pathfinder and the path breaker. How is it that you become that? Well, if you want to achieve something that you've never done in life, you have to step out of your comfort zone. If you have to do something that you've never done, you today have to jump out and do something that you've never even imagined doing and go beyond. You believe in yourself. It's hope, belief, trust. That's all that I keep talking of. Time and again. Try the untried, learn to unlearn. Go back, go through the abdomen. People are speaking about how people get ejaculation issues. Find a solution for it, even if it's a youngster. It's not that we stop doing anterior approaches. There is a way. Don't change the destination. Take a new path. You can salvage it. The sacral plexus will not be hurt. Use a different path. Move from conventional to contemporary. Always inspire till you expire. Well, this man did it, who bit into the apple, but a lady did it much earlier. She was a heartthrob of many. And yes, in the year 1976, when we just had this black and white TV, Montreal Olympics. And what did this lady do? Look at that slide, rock bottom next to Bharat Dave. That's the slide which says that she got 1.00. No, gentlemen, she got 10 out of 10. The digital counter did not have a facility to show 10.00. It had 9.99. They never believed that a human being could achieve a 10 out of 10. Zero defect, precision, and sustained excellence is possible and proven by Nadia Comaneci from Romania in the year 1976 at the Montreal Olympics. Please understand, how do we achieve this excellence? Whenever we don't achieve it, we should feel hurt. It will instruct us. It will create that zeal, that zest to excel. It's only when we can excel ourselves that we'll achieve this excellence. Please understand, aspire to inspire in silence. Let your work speak for you. Listen, be silent. These are anagrams. SILENTLISTEN. Silently listen. Despite this, nobody wins all the time. Nobody loses all the time. We've had the greatest Muhammad Ali. We've had Pele. We've had Michael Jordan. And what do these people say? And I quote Jordan here, who says, I've missed more than 9,000 shots in my career. I've lost almost 300 games. 26 times I have been trusted to take the game-winning shot and missed. I've failed over and over and over and over again. That is why I succeed. Ladies and gentlemen, we shall fail, maybe by helplessness, maybe by negligence. We must look at short-term setbacks as maturity gained and short-term successes as motivation. Good results come from experience. Experience comes from bad results. I said this in Gujarat in 1986 and got blamed for it. Failure is not the opposite of success. It's a part of success. Defeat is not when you fall down, but refuse to get up. And I quote Samuel Beckett, ever tried, ever failed, no matter, try again, fail better. Who better than Yana Novotná? 1993 Wimbledon final. She's playing Steffi Graf, who's the reigning champion. Yana Novotná 6-7 down first set. Second set, she wins 6-1. It's a three-setter ladies final. 4-1. She's serving 40-30. All our money is on Yana Novotná. She double faults. She was a few points away from lifting the Wimbledon title. She loses the game, the set, and the match. Yana Novotná choked. She came again in the final next year, lost again, Martina Hingis. 1998, she comes again into the final. She's playing Natalia Tozzi at this time, and she wins Wimbledon. Having been so close to it, she lost it. She choked. She wept on the Duchess of Kent's shoulder. When presented with the runner's trophy, Novotná was crying and the Duchess of Kent comforted her. She said to Yana, I believe you will do it. 3 years down the line, she did it. What made her do that and why did she choke? We have an explicit, a neocortex, explicit brain, and we have an implicit mind, which is our limbic cortex. Explicit brain talks of tactics and strategy. Implicit is basically technique and execution. When we start spending the money that we have not yet earned, that's when we fail. Work towards doing what you want. Don't look at what you'll achieve when you operated on that patient. Do the best for that patient and believe that he will be good for the rest of his life. Despite all this, you have to follow one mantra, that this too will pass. Another line which my father told me and I repeated every time. He said, Beta, remember, nothing lasts forever. Say it to a man who's very happy, he'll become very unhappy. Say the same 3 words to a man who's very sad, he'll start smiling at you. The same sentence means different to what you are, to your mindset at that time. And I now quote finally, the greatest pride is growing in your own eyes. The greatest unfortunate situation is falling in your own eyes. I look at Sachin Tendulkar and Sehwag. 2003, Sehwag was almost out of the team, but Sachin was there, his mentor, his role model, and he got him in and they opened the innings again. And there came a stage where on 29th of March 2004, he was facing Saqlain Mushtaq. And he said, 294 पाकिस्तान के खिलाफ मुल्तान में जब मैं खेल रहा था, तब मैं सचिन के पास गया और मैंने कहा अगर सकलेन मुश्ताक अभी आके गेंद डालेगा तो मैं पहली गेंद पर छक्का मारूंगा. No Indian has scored 300 till that day. Sehwag walks up, converts his subconscious doubt into subconscious belief and hits Saqlain Mushtaq in Multan for a 6 and goes from 294 to 300. He crosses 300 twice and almost touches it a third time. The greatest pride is to grow in your own eyes. The greatest setback is to fall in your own eyes. Avoid using words like always and never. Make few commitments, live up to them. Reduce your subconscious doubt, increase your subconscious belief. Do what you say and then you will achieve what you can dream. Always remember, be a part of the solution, never a part of the problem. Ratan Tata has said this so many times. He went and he almost sold his nano division and the car division, Indica division, which had failed, to Ford Motors, 1998. But then what did he be faced with? He was faced with Bill Ford saying it will be a favor if we buy this business from you. In Detroit, he had to face that. He got up, took the flight from Detroit to New York, New York to London, London to Bombay, came back to his Bombay house and sat down in Tata House. 10 years later, Bill Ford comes to his office and is now selling Jaguar Land Rover. And what does Bill Ford say? You are doing a big favor to us by buying Jaguar Land Rover. Ladies and gentlemen, courage to continue, that counts. Always remember that. He said, I don't believe in taking right decisions. I take decisions and make them right. Take them decisions, take them, have the guts to take them and follow them up. Always be a part of the solution. If not, you're a part of the problem. Success is not how or somehow. You have to plan the details, just like Dr. Tharadhara does it. Plan the details, and then you will be successful. And remember, each one of you is born to lead. We have to lead, and we have to go past what is set as a gold standard. Reno Levellini broke Sergi Bubka's 21-year-old record and went to 6.16 and broke it. The first person to congratulate him was Sergi Bubka. 21 years later, today, last week, if you read the paper, this same record has been broken 5 times again, right up to 6.21 by Armand Duplantis on 24th of July, 2022. They're all raising the bar. They were all born to lead. What one man can do, another man can do better. And why is that so? Because each one of you is the leading sperm. You are here because you were the leading sperm many, many years back. You have to live up to your reputation. You were never a follower. You have to live up to it. Always remember that when you are being pushed, there is some higher force that is delighting in that. What is this? We've done it in biology. We've learned it. It's a caterpillar transforming into a butterfly. The cocoon will break and the butterfly will come out. Just when the caterpillar thought it was the end of the world, it became a butterfly. We have to go through those aches, pains, challenges. Someone somewhere is delighting. The caterpillar is being pushed, but the butterfly is being born. Man is being pushed. The creator is delighting. Instincts just give us pain and pleasure. That's limbic cortex. The conscious, which is the neocortex, tells us what is right and wrong. So there is a horizontal exposure, but there's a vertical expertise that is pushing us up. And we have to do that. You are only an instrument of a much higher force. That's the last thing that I have to say. Please remember that. Who is this? Hari Prasad Chaurasya. What is he playing? The flute. We can all get that flute. Music comes through the flute, but not from the flute. He is just an instrument of a much larger, higher force. Remember that. Have a belief system. You must have it. You can call him whatever you want. You can call him God, good, something, somebody. You don't have to prove it. You don't have to justify it. You don't have the world to follow it. You don't want people to convert to it. No, just surrender to it, give into it. Meditation is in nothing. The belief system is in everything around you. It could be Om Bhur Bhuva Swa Tat Savitur Varenyam Bhargo Devasya Dhimahi. It may be Inshallah. It may be Jo Bole Soniyal. It may be Our Father in heaven, holy be thy name, thy kingdom come, thy will be done on earth as in heaven. They all believe and say the same thing. You can give it any face, any name. You can respect it the way you want. I have my face, my belief system, and that's my Father. And I know without him, I cannot. Without me, he will not. And he and I, anything is possible. Have that belief system. Maintain balance, create trust. Create that balance. Get over that Duryodhana's predicament. What is Duryodhana's predicament? You remember that Krishna Bhagavan was approached both by Arjun and by Duryodhan. And what did Duryodhan tell Krishna Bhagavan at that time? He says, don't tell me. I know what is right, but I cannot indulge in it. I know what is wrong. I cannot avoid it. Ladies and gentlemen, we all have a Duryodhan in us. If we can reduce that Duryodhan in us, life will become much simpler, much shorter. There'll be more balance. Let go, let your ego. What is EGO? EGO is ejecting God out. Just let it go. Have those aha moments. Stop using cuss words. Quit smoking if you can. Quit breaking signals. Very small thing that I'm asking you. We all stop at the signal, look left, look right, there's a red light. I smile at the next driver, he smiles at me, and both of us wink and we drive across the red light. No, sir, this is majority honesty. It's pristine honesty. 3 a.m., there is nobody on the road. If there's a red light, I will stop. I won't move ahead. That is what we need to do. If you do that, you will leave behind a legacy. When you were born, you cried and the world rejoiced. When you die, the world should cry and you should rejoice. Gentlemen, start unknown, but finish unforgettable. always remember, I've spent almost half an hour. At the end of this, you may love me, you may hate me. If you love me, I shall be in your heart forever. But if you hate me, I shall be on your mind for much, much longer. Gentlemen, it's time that we get our glasses out, change the color of the glasses, make a decision to wear clear glasses and see the true color of the world. Forever, I was evidence-based and I thought seeing is believing. Now, I've turned it the way around. I'm convinced believing is seeing. Think about these words. मैं अकेला ही चला था जानबे मंजिल मगर लोग साथ आते गए और कारवां बनता गया. Gentlemen, as I've always said, you will be served what you deserve, not what you need, not what you want. So always bring and carry the change that you need or you want. Success is not final. Failure is not fatal. It is the courage to continue that matters. Thank you all for a very patient hearing.
Thank you. Thank you, Dr. Ram Chandra. Thank you. Thank you very much for such an novel, exciting, motivational talk. And that's why I said you have imbibed the spine, you are humble and immaculate, clean, spotless. Thank you. Thank you. Thank you very much.
Thank you. After a mesmerizing talk, may I request Dr. Prabhakar sir to hand over a memento to our invited speaker.
Now, as we are a little late, I would like to invite Dr. Hitesh Modi to talk about the Backbone Journal. Would like to introduce Dr. Hitesh Modi in just 2 minutes. I know him since 22 years plus. When I went to his home at Baroda, he may remember that day I met his parents, and from that day the journey started. And he was at Stavia, and we worked together for 3 years. And after that, he just carried on in his journey. 2 Modis to remember. I'm sure the Modi who is at Delhi and who has changed probably the India, and another Modi who is at Marriott, who has changed SAG as well. And the only word which I want to talk about him is a consistency. I think he has been consistent in all his actions, all his movements, all his moves. That's what he has done. And that is at the end result, what we have is the Backbone Journal. Over to you, Hitesh. Thank you.
Thank you, sir, for kind words. Okay, greetings and many thanks to allocate me the time to present our SAG academic activities as an editor of Backbone Journal. I think everybody knows that necessity is the mother of all inventions. However, I would say that the crisis is the best management scenario, as spoken by many management and strategic gurus like Professor Michael Porter from Harvard Business School. Similarly, we have taken the same opportunity to launch our own peer-reviewed open access journal, Backbone, the Spine Journal, during the peak of COVID crisis in 2020, with the first publication of the first issue in October 2020. I would like to thank Dr. Ajay Krishnan and Dr. Amit Jala who has nurtured this idea even before the COVID crisis and give me the responsibility for the journal as well as recognition. I sincerely thank both of them as a secretary and president of SAG at that time for this wonderful idea. I give full credit to Dr. Ajay for the designing, graphics and color combination of the journal as you can see here. I would like to sincerely thank Dr. Bharat Dave, Dr. Tharadra sir, Dr. Neeraj, Dr. Subir Jhaveri, Professor Prabhakar sir, Professor Pankaj Patel to shower their blessings, and nonetheless our KP Pathak sir having the first article published during the launch of this journal. I would like to extend my thanks and gratitude to all my associate editors as well as national and international international board members for the journal that has gradually expanded over a period of time from first to fourth issue, as we can see here. Nonetheless, I would like to extend my specific and special thanks to all authors who have supported wholeheartedly by their academic submissions, and without them, this journal would not have reached to its destination. And I am sure that all authors who has published and would publish will be ultimately listed in PubMed once we get ISSN number followed by the PubMed listing in coming year. This journal is being published and managed in association with Indian Orthopedic Research Group IORG, led by Dr. Ashok Shyam and Mr. Saurabh Phulewar, who are working really hard. Like a feather in cap, Intas Pharma needs a 3 round of applause as they have taken the full responsibility of printing and delivering the journals to all our members. And I am sorry if anyone did not get the copy of the journal, they may request directly to me on my phone number as well. Coming to the purpose of our journal, as we are committed to all our authors and we want that authors' academic research should not go unpublished, and we want to publish as many as publications in the journal as far as it is in the scientific content, whether it may be review article, it may be meta-analysis, case reports, case series, letter to editor, general articles related with the spine, innovative techniques, or editorial articles. We welcome all sort of articles related with the spine. The process of once the article is submitted through online process and online portal, the editor will go through the primary check for the suitability of the article in the journal and send for further peer review process. Once the article has been reviewed, the decision for acceptance, revision, or resubmission or rejection are informed to the corresponding author. And if any query arises, authors can directly write to email at editor_backbonejournal@gmail.com. The entire process is quite smooth, and we wish to increase the frequency of issue from twice a year at the moment to quarterly in short-term target and bi-monthly in coming next 5 years as a long-term strategy. We had applied for the registration number ISSN for once. However, due to some issue of plagiarism, means more than 20% of the similarity in one article, it was rejected. However, upon further correspondence with the corresponding author, we have corrected and rectified that issue in online archives. I would take full responsibility for this initial failure and apologize for the same. We would resubmit our application, and once we publish our 5th issue in October, we will do ISSN process and followed by PubMed listing in coming year. And on this occasion, I would like to thank you all from the bottom of my heart to support this journal backbone, the Spine Journal, and requesting to shower further blessings to make the journal to a success with aim of most referred journal. I would like to request SAG in GBM to take further call regarding the appointment of editor as well as further office bearers according to the policy. And in the end, I would reiterate our mission is together we stay and together we grow academically in the field of spine. Thanks a lot for patient hearing. Thank you.
Thank you, Hitesh. May I thank the chairman, and we conclude the plenary session, and I will hand over the further proceeding to Dr. Kushal.
So our next session is on adults. Next session is on the congenital neuromuscular scoliosis. I would like to call upon Dr. Srivastava sir, Dr. Amit Jala sir, Dr. Vishal KUNDNANI. I think he's not there. APPAJI sir, can please, if you can join on the panel. Dr. Rakesh Luhana sir and Dr. Rohit Delat. Please come on the stage. And the session would be conducted by, the first lecture is by Dr. Anil Solanki. He will be talking about rationale and challenges in management for congenital neuromuscular scoliosis.
Good afternoon all. Now coming back to the academic part, my topic is congenital and neuromuscular scoliosis, rationale and management. Basically, this idea is to differentiate between these two cases and how the management differs between the two cases. So topics, this is the topics I am going to cover. Coming to the early diagnosis, which is important to prevent and minimize the natural history of the disease, and it can be done as early as prenatal scan, genetic testing, or after birth X-ray or MRI. Sometimes these children have associated systemic anomalies. Vectoral is one of the important one, and it is important to have chest X-ray, USG abdomen, 2D echo, and MRI whenever they present to you for the first time. Sometimes these children have intraspinal anomalies such as Chiari malformation, Syrinx, split cord, or tethered. This may or may not have cutaneous features or symptoms, but sometimes you may find abnormalities or difference in the superficial abdominal reflex. Whether to go for surgery or whether to conserve for these anomalies is a matter of debate, but as far as traditional teaching is concerned, you should always consider surgery of these anomalies first before going for the deformity correction. This is the classification: defect of formation and defect of the segmentation, which we say is either hemivertebra or a bar or block vertebra. Progression of this scoliosis depends on type of vertebral anomaly, site of the anomaly, and age of the patient. Non-operative treatment is important for short and flexible cows, but the casts and braces are not very useful for large cows, which are rigid ones, but sometimes it helps to limit the progression of the secondary cows. Cast application and tolerance in our setup, it's a bit questionable. When we talk of the operative part, your goal should be to achieve the correction, whatever is safe to achieve, to get the balanced spine and arrest the cow progression. As we discussed, prior neurosurgical procedure should be carried out. And nowadays, intraoperative neural monitoring is must. Coming to the next surgical part, in situ fusion can be done for 4 to 5 vertebrae when the deformity is minimal and not associated with other cows. Fully segmented hemi at junctional level can be operated either posterior, anterior, or combined approach. This is one case example. And as we all are using rigid pedicle screws, there is very less chance of crankshaft phenomena. The convex hemiepiphysiodesis or tethering, in which we inhibit the growth on the convex side by either staples or pedicle screws. I am sure Dr. SAJAN HEGDE will cover whenever he presents his talk. Hemivertebrae excision is one of the most commonly done procedures, and it can be done at early age, even at 5 years, because spinal canal has already grown about 95% its definitive size, and it is commonly performed at thoracolumbar or lumbar level for fully segmented vertebrae, short angular cows, and it can sometimes be associated with major deformity correction or a growing rod technique. This is one case example. You can see hemivertebra at thoracolumbar level is excised, and this is the correction you achieve. Growing rod can be done when the child presents at less than 10 years of the age and there is a long scoliotic curve. Definitely double rods are preferable, and if you are using a magnetic rod, you can avoid repetitive surgeries for lengthening. And whenever there is a failure of formation at the apex, hemivertebra at the apex, you should do a fusion at apex before going for growing rod or at the simultaneously. Coming to the next part, osteotomies are very well covered by Dr. Ajay. And this is just one case example and few tips. You should always consider pre-operative or intraoperative traction whenever you feel the curve is rigid one. Anterior release should be considered when there is a rigid curve. Assess the blood loss and stage it whenever necessary. And you should have your competent colleagues when the deformity is severe and rigid. This is 130° of the curve, operated by anterior release and halo, and then corrected posteriorly. You can see the clinical pictures. Coming to the neuromuscular part, these are the collapsible spines. Whenever this child try to stand or sit, you can see the deformity exaggerates. Whenever this child present at early age, you can consider growing constructs, but whenever they present late, you should consider fusion to pelvis to get the sitting balance. This is another case of neuromuscular scoliosis operated by fusion to pelvis, and you can see the clinical corrections. Thank you.
Thank you, Dr. Anil. Now I would like to welcome upon Dr. Gururaj Sangodimath. He is from Delhi. He is from Institute of Spinal Injuries, Delhi. He's a senior consultant spine surgeon with a lot of experience in spine. He is an ex-community development officer for AO Spine. He is a committee member for nominees at AO Spine, and he is a committee member for alumni of NBI. Please, Dr. Gururaj. Thank you. I would also like to call upon Dr. Vishal KUNDNANI on stage. He is now over here, so we'll just put up a chair for him. Thank you.
So more the merrier. Excuse me. At the outset, I would like to thank Spine Association of Gujarat and its committee members for inviting me here. This is a mainly a case-based discussion, and in first case, we'd like to cover as much as possible the issues with the neuromuscular scoliosis. Yeah. Okay. So that's my first case. 16-year-old boy. He was a known case of meningomyelocele, operated at the early age of 1 to 2 years, exactly not known. And he had a hydrocephalus for which VP shunt was done at 13 years of age. And he had a weakness at the time of birth, and he was progressively paraparetic, and the paraparesis is progressive. And normal mental status and bowel bladder, he has a partial control over the bowel bladder. So that's his clinical pictures. That's the front and from the back. Let's start with Rakesh. Rakesh, when you see such kind of patient in your OPD, first thing what comes to your mind, and what is the striking thing in these patients?
So the difficulty with meningomyelocele with paraparetic, there already neurological deficit sets in with asymmetric trunk imbalance, causing him progressive worsening of the curve plus severe deficit. These are kids which are very, very difficult cases to tackle.
Okay, Vishal, when you see this picture, what are you actually striking features in this patient?
So I think clinically, few things that immediately strike to me is that one, this is a severely hypokyphotic curve.
Yes.
The truncal imbalance is such severe thing that the patient sitting is getting compromised. The pulmonary things are surely at a compromise.
Yes.
So all these things are going to make your surgical maneuver challenging. The scar there is going to be a big challenge, requiring some kind of plastic reconstruction as a primary thing instead of as a secondary thing, because anything you correct, you're going to make a situation worse there. And in this particular case scenario where you already have a VP shunt there, any deformity that you correct, you are already posing the VP shunt at risk. And so the chances of this patient developing a decompensated hydrocephalus secondarily is always there. So unless until all these things are taken into consideration, any kind of correction that we maneuver, the kyphosis has to be taken care of, the plastic surgeon team has to be around, the VP shunt has to be taken care of, and truncal imbalance has to be corrected only to achieve a good sitting balance for this patient. So the goals of surgery are pretty defined. You are not
So
going to
we'll discuss it later. So that's correctly pointed out. So this was his examination. Like, he was non-ambulatory. He had a pain while sitting because of the costopelvic impingement which he had, and he could shift from bed to wheelchair by himself because he had power in his upper limbs, and he needed hand support for sitting. So that's again important, which actually is one of the main important factors when we decide. And he had like grade 1 or 2 power. He could he had some flickering at his quadriceps, and he could move his toes a bit, and perianal sensation and voluntary anal contraction was decreased. So he was not completely like paraplegic, but he had a significant neurological deficits. So again, this is from behind. We can all see that there is a remnant hairy patch there. There is a old operative scar. So he had a hyperlordotic lumbar spine, something like a duckling back, where actually the very high pelvic incidence with pelvic obliquity, which is significant, which we can see, which is causing costopelvic impingement, and he needed a hand support for sitting. So that's his X-ray. Srivastava sir.
Yeah, these children, they come with a significant problem, as already discussed. So as a surgeon, we must be very, very clear what is the purpose of treatment. That should come as a first line in your mind. Now, as per the clinical examination finding, as I understand, here the purpose is that he should be able to sit and it should be painless, because here at present he is having pain while sitting. Okay, so that should be the purpose. I don't know, because we don't have any comparative neurological status known in this patient. What happened after meningos or meningomyelocele surgery? What was the grade that? Whether that grade only had persisted, because you had mentioned now there is a progressive neurological deficit. Now the type of the deficit also important. Whether it has gone to the dorsal spine, also it is spastic, or it is a lower
It's
motor.
a flaccid kind of.
Flaccid.
It's lower motor neuron
Yeah.
kind of.
So in such situation at root level, if you find significant compression, then it might improve. It is at root level. So that will also come to our mind. So here the purpose of surgery is making him sit, and that sitting should be painless. So that thing is the actually known as a indication of surgery in this case. Now, how to do it? Actually summarized by Vishal very nicely.
So we'll come to that. So we'll come to that.
Yeah.
Appaji, so we have this sitting AP and lateral X-rays. So we all can see there is a gross scoliotic deformity at both thoracic and lumbar level. There is a pelvic obliquity. There is hip dislocation, and in lateral there is a hyperlordotic spine. So what other images you would do, like which are very important, not like cover everything, but what is the most important image will you do?
Two things before that
Yep.
about the sensations. If sensations
Sensations are
present,
intact.
so that's what. So he's not complete neurology. So his sensations are intact. So anything you plan, you should include MRI scan first.
Yes.
To see for retethering, because lipomeningocele excisions in the very young age can go in for an addition and causing a tethering at that level.
Yes.
Yeah. So MRI is very, very important in this
And-
situation.
and
Second thing is MRI of the brain too, to
Mhm.
look into the VP shunt and why they've done a VP shunt. Is there a hydrocephalus still persistent?
Yes.
Then we'll go for a CT scan also to look into the defects at the posterior elements.
Yeah.
These two, MRI and CT, I will
And
do.
what other X-rays which actually help you in deciding your management? Vishal? Yep.
I think to begin with, one thing we must understand, this is not a case to be done on a regular basis in a smaller setup. This is an institutional case. It's a multidisciplinary team requiring case. It is a high risk case. It is going to require a prolonged hospitalization. It is going to require critical care management. It is going to require a neurosurgeon in-house. It is going to require a plastic surgeon. And it's also going to require a critical care analysis of patient's status to really be survive that kind of surgery. So to have so many teams, I think just summing up few investigations may not be enough. Fitness assessment being the first thing.
Yeah,
Because no
we'll
matter-
come to that. We'll come to that. I was just concentrating on the images.
Sir, are you asking for X-rays in which you
So,
the pelvis and
yeah,
everything.
take the X-ray or traction X-ray?
I think
So what I actually wanted to stress upon here is like, because these are neuromuscular scolies with this kind of meningomyelocele, they're usually collapsing type of deformities. So you need basically a supine X-ray or a traction view, which actually helps you in deciding your plan. So that's the CT scan. So unfortunately, I think I didn't put the MRI images here. Dr. Jala. So ultimately, after seeing all this, where do you classify this deformity and how do you approach
I
this?
just want to add one thing, that before even we diagnose or we go for investigations like all these CT scans and everything, I think I would, when the patient comes to me for the first, I think it's very, very important to counsel the patient and the parent
Yes.
that actually what do you want? Because the patient for last 16 years with the paraplegia, with all these things. And you have to counsel that, as Vishal rightly pointed out, that it's not going to be an easy curve to manage. It requires a multidisciplinary approach. So having said all these things and all the negatives explained to the patient of the surgery, then if still he wants to go further, then we require all this MRI and the CT scan, and otherwise this workup is of
Sure.
no use. So that's first, counseling is very, very important. That's what I would do for this patient.
Yeah,
initially.
actually, yeah, Shailesh. Can we have the mic for Shailesh? Careful.
Yeah. I would like to check the hips also, because whether they are subluxating.
They are dislocated. Both are
Yeah, they are
dislocated.
dislocating. The pediatric orthopedic opinion is very important in this before we plan.
Okay, so we'll come to that. I'll come back to you only when we come to the management for that. So we all know that it's a neuromuscular kind of scoliosis, because this is we have to cover. I'll just brush up with the theory part of that a bit. So this was a neuromuscular lordoscoliosis with paraparesis, with costopelvic impingement, with bilateral hip dislocation, kind of a windblown pelvis there. So we all know that what is neuromuscular scoliosis. We'll just and then it can be neuropathic, it can be myopathic, and then it can be due to myeloid dysplasias like this. It can be due to ACM, syringomyelia, and congenital diastomatomyelias. So incidence is basically, if your cerebral palsy with all four limbs involved, very, very high chances.
I think, can we just skip the literature and just go to the case?
Yes.
That would be fine.
Then basically this is all we had this windblown type of deformity in these patients. What are the basically red flags to see to differentiate from AIS when actually they present like AIS is these are the factors with that. So that's the scenario right now. And one reason why do we want to operate here, or one or two reasons, Dr. Rohit?
Basically, patient is having difficulty in sitting. He's in pain and truncal instability.
So we think in any scoliosis, the main reason to operate is because we think it's progressive and it can cause progressively
progressive
more
neurological
problems,
weakness or
whatever
ambulatory
problems we have already. So it can lead on to more progress. So we all know that neuromuscular scolies actually are known to progress very fast because of various reasons and causing various problems, including respiratory and cardiac and GI symptoms. So anybody would like to brace this patient at this point? Anybody in the panel? Up, sir.
Actually, I would brace the patient and tell him that this is what you will get it. If you get a partial correction and then brace, and you can just tell them that you can get a pain relief of this type after the surgery, because bracing is going to help in sitting also, because it's not ambulatory.
Okay.
Right,
Appaji,
so-
you were nodding. Why you would not like to brace this patient?
So two things. One is the compliance. So most of these neuromuscular patients do not comply well with bracing because their muscles are acting against the braces. Your brace is actually trying to pull the muscle which is actually overacting, the other muscle is not acting. So they have too much of pain in bracing. Second thing, which is a lower lumbar curve, which usually is not very amenable to bracing.
So do we think actually we can brace, sir? I come back to you. Will we be able to take away that costopelvic impingement with the brace?
No, my main purpose of bracing was a temporary.
Okay, temporary.
To tell the patient this is what your pain relief can be.
Okay.
Before we go for a true surgery.
So there's some slides. Basically, bracing has a very limited role when it comes to severe progressive curves in neuromuscular scoliosis. Smaller balanced curves to postpone your surgery or to build up the patient's nutrition or build up the patient's general condition, you can use bracing for some time. So again, indications for surgery, we all know this: progressive deformities which lead on to whatever problem they already have if we think they're going to worsen. Okay. So Vishal, let's come to here. We have decided to operate this patient. What all things we need to address in this patient?
No, I think Dr. Amit mentioned very clearly that what to achieve cannot be decided by surgeon per se in this particular case.
What is the cause of pain?
Okay.
We have seen the case because the patient has come here for the pain. Right? See, he's 14, 15 years. He's living with this curve and the scoliosis and the deformity. Why the pain is there? So if we can correct that pain, then we plan the treatment.
I already told that it's mainly pain was mainly due to costopelvic impingement. Pain was mainly due to costopelvic impingement. So we already know that. Vishal.
Yeah, I think the goal of surgery cannot be defined per se by clinical team. It has to be in conjunction with a shared decision making with family.
Yep.
What are their expectations? Pain relief is one thing that patient wants primarily, but at the same time, while the pain can be coming from costo impingement also, and also from the lower nerve roots, LMN kind of thing, which also happens because of a severely progressive lumbar scoliosis happening there, and also because of hyperlordotic situation caused by thoracic hypokyphosis. So all these things, of course, many such factors. And we will never be able to point out that this is the single factor, which is the most important factor. So if we are addressing all that, we will have to address all that together. However, again, the goals of surgery have to be defined in conjunction with shared decision making with the family. And unless until you match the demands of the patient, no amount of surgery is going to help. And that's why what is your supply, whether it is actually going to be able to meet the demands of the patient, will decide the goal of surgery here. Now, say, suppose we are able to do a surgery for pain relief and sitting, because that's the only two things that we'll be able to achieve: painless ability to sit for long hours. Other than that, if you are trying to achieve anything else, the surgery is not going to be of any help to this patient. So for me, we are probably going to address sitting ability for this patient, preserving the sensations of this patient, and of course, trying to get a good pelvic balance so that patient can sit for a long period of time. Other than this, I think anything else, whether you correct a scoliosis to straighter spine or a curved spine, it hardly really is going to make a difference to a non-ambulatory patient.
Okay, Dr. Rohit, we heard why are we doing this surgery. So how do you like to achieve all these goals?
Sir, one more thing I wanted to ask is, how is the movement at hip joint, like abduction, adduction?
So it's
Was
a
there any problem with personal hygiene, like urination?
It's a kind of flail hip. Both hips are dislocated. It's freely mobile hip, so you can move hip in any direction you want. Actually, there is no contractures. There are no contractures at the hip. So how do you like to achieve whatever we have spoken till now? So what surgery would like to do, from where to where, and what would you like to do?
Sir, can you have the X-ray, please?
So I'll come back to X-ray. So before that, we'll just, do we, in our practice, like Appaji, Dr. Srivastava, sir, do you have any checklist for such kind of patients? These are complicated patients, neuromuscular scoliosis.
Yes. It is very important. Now, in this patient, whatever you do, the first important thing is nutrition.
Yes.
He is significantly malnourished. Okay. So by the time you discuss all those things, he should be put on that chart.
Yes.
That his nutrition, his weight should increase, whatever the part of the osteoporosis, he has not been using his muscles. So sarcopenia and osteopenia both are going to be detrimental. Even if you fix it, it is going to come out. Wound problem, if nutrition is not there, his soft tissue coverage is going to be a real challenge.
Okay, so well said. Actually, neuromuscular scoliosis can be due to different etiologies. So according to etiologies, you will have different kind of things to look at: cardiopulmonary, respiratory, nutrition, sometimes malignant hyperthermia. So that's one of the most dangerous things. So you have to look at those, and there are defined checklists, defined things where actually you can end up with more complications. There's one of these tables, especially PFT with vital capacity less than 40%, and then kyphosis or hypolordotic thoracic spine, which are more. Vishal, you want to say something? No. Okay. Okay. So
even they have poor hygiene.
Poor hygiene, yes.
And that's why there is a high infection rate.
Yeah. So Dr. Rohit, I'll come back to you. Surgical plan.
In this case, definitely we have to go till pelvis.
Yes.
And somewhere around D9-10.
D9-10. Okay. Appaji, you're nodding.
Neuromuscular never short.
Yeah.
Okay. Neuromuscular is always long segment fixation. Most of the time, if they are non-walkers, fixed to the pelvis.
Yep.
So I will include pelvis, whichever way you are trained with, either a iliac screw or a S2 iliac screw. And I will go up to T4 or.
Okay.
Yeah.
So actually, we'll just complete that discussion about walker and non-walker. Because he is a non-walker, there is no brainer here. We all will go to pelvis with such kind of pelvic obliquity. But then if this patient, hypothetically, if we see the hips were normal and he is a walker, still you would go out to pelvis or you would go to pelvis?
I would try to avoid SA joint in these patients.
Okay.
May include S1 sometimes, if it is required, if the L5 is completely tilted. And if the traction film makes me look into that, that there are like S1, L5, L4 are in straight line, and there is an obliquity, then I can stop at L4 or in these patients. If he's a strict walker, that gives him a
L4 or L5?
Depends. That's what. So I look at this. This is most important in CP children. You see if they are using their pelvis to walk. If they are like pushing their body under the hip, using the pelvis, then do not fix the pelvis. If you fix the pelvis, they become non-walkers.
Point well taken. So especially neuromuscular scoliosis, I think L5 is better because you can control the pelvis with L5 better than L4. And you made a rightly said that in a traction X-ray, the pelvic obliquity is actually in sitting, it is almost like 45 degrees and it is coming down to almost like 20 degrees in a traction X-ray. Then you can actually err stopping at L5. So surgical plan, again, like Appaji said, we can't stop in the middle of the thoracic spine. We have to go to D2 or D3 or at least to D4. And then whenever we position, we have to be careful because they can have hip and knee contractures. So you have to plan your positioning beforehand. Otherwise, you will have surprises in on the table. So we all discussed this again. So pelvic fixation also we discussed. So that what was done. So any comments, Dr. Srivastava?
Yeah, so actually, how much he got the benefit in his clinical scenario
so I
is
will
most
show the
important.
clinical pictures. Yeah.
So if he has become painless, he is sitting for long hours. Otherwise, also his hips are dislocated. He's not going to walk.
Yeah.
So in that way, if you see, the balance is quite good, but it is quite acceptable. Okay, there is no problem. Slightly he is tilted on one side, but still it is a good correction the way it was there in pre-op.
Vishal, if you do this surgery, what challenges do you expect intraoperatively?
Plenty. As I discussed few of them in the beginning. But before that, I think we need to understand this, that the easier they correct, the easier they fall. So pseudoarthrosis, implant failure is something that is lurking on my face on day one.
Yes, yes.
And even before pseudoarthrosis happens, few things that we may understand is that multiple factors have to be taken into consideration when you plan these surgeries, including the plastic surgery and the neurosurgical part that you would want to have as a team. But the foremost thing that you want to see is whether we are going to be making him able to sit straight or not.
Yeah.
With a pelvic obliquity present there, if you are not able to get a pelvis which is parallel to the sitting ground, you have probably converted a non-ambulatory straight sitter because of flexibility of lumbar spine into a obliquely sitting patient now. So this pelvic obliquity part has to be taken into consideration, even if it comes to a point that you would want to add an osteotomy there to correct the pelvis becoming parallel. That's the first thing that has to be paid into attention, that the pelvis has to become parallel to the ground. Now, unless until that happens, no matter if you use long, if you use short, whether you centralize the head on the pelvis or not. Like in this case, my concern is his head is not centered on the pelvis. You may still get him, you're lucky that his hips are dislocated here. So he'll be able to compensate that on his hips. But you have to understand this, that these few things have to be taken to consideration in beginning. And that's why neuromuscular scoliosis, one, never short, two, never be sure of what you're going to achieve. They are the most unpredictable ones in terms of outcome. Most unpredictable ones.
Thank you. Thank you. You brought up that point. That's where I come back to Rakesh. How aggressive you will be in these patients? You know, they are respiratory compromised, cardiopulmonary compromisation, nutritionally compromised, wound healing is a problem. How aggressive you will be in these patients to achieve whatever you have thought in your mind?
So two things. One, I'm in a private setup and I'm not expert in deformity. So this is basically being a neurosurgeon. I would be there in a team, but I would take those people who are expert into deformities, and this kind of cases should be reserved to institutes. So
okay, I'll come to Dr. Srivastava, sir. Yeah. He is from institute. So
no, here as Vishal rightly pointed out, you know, if you wish to really correct the deformity, and here at some point you can do like a lumbar area, okay, lower limb area, you can do the osteotomy and correct it. It will come, but thinking all those things in view of keeping those, you know, skin condition, hairy patch there. So this is going to be a nightmare, you know, unless you have tackled all those things. Otherwise, see, correcting it is not a problem. See, you do severe correction, you know, severe deformities, making an osteotomy, it is going to come back. There is no problem. But sometimes you find that you are not able to close the skin over your implant. So that worry is going to be there.
Actually, the main problem which we faced was, sir, you want to comment?
Yeah, I just wanted to have a thought on this. This patient was having a spinal dysraphism.
Yes, sir.
Yeah, right. So
already operated, scarring was there.
So particularly if there is spinal dysraphism,
yes,
the chances of pseudoarthrosis are very, very high.
Yes.
So this is one of the indications where you can go anterior.
Okay.
Where you can just do the anterior 3-level fusions. You will get even better correction than this. You will get a better fusion than this, and you may be able to do better. That's just a thought from my side.
I'll add, to Amit's thing. Initially, when we were doing folios and CPs, we used to do an anterior short segment in the lumbar, derotate them fully, and then go in and do a posterior. But off late, Amit, we have stopped doing that because you are able to do the fusion and everything all posterior. So you don't have to do. But initially, 2002 to 2007-8, we used to do most of this short anterior, only the lumbar segment anteriorly, derotate them, and then go behind like long segments.
In this case, actually, because of the skin condition, you will prefer to go and, isn't it?
So I think few things that I would do little differently. It is very easy to comment now retrospectively of what you have done and find mistakes. But pre-operatively, what I would have done little differently is, one, this patient is surely a candidate for halopelvic traction at least a couple of weeks before his surgery comes up. Number one. Number two, you are probably going to add upon multiple osteotomies intraoperatively, trying to get more lumbar correction rather than the thoracic part. Implant part, I think I would also agree, we will have to go from D4 to pelvis. But how to get the lumbar spine parallel and the pelvic obliquity corrected will be my targets, and to which I think halopelvic traction, intraoperative traction, multiple osteotomies, release at that junction, asymmetric osteotomies in the lumbar spine are things that will come very handy in this case.
Shailesh, after that, I can just comment.
As routinely talked about in neuromuscular, most of them say कि हाँ easily आ जाएगा. So it's not like that. It's not easily आ जाएगा. There are certain cases which will come easily, but a lot of time, if you see the age, that's also very important. This boy is almost mature, boy or girl, boy, 16 years. So he's almost like an adult. We looking at the deformity, we feel we should do this and that. It's not that easy at times because you're trying to just correct it at that level, but it doesn't come. Despite of putting the screws, you try to do various maneuvers, cantilever, derotation, it doesn't come. And that is the challenge where probably we need multi-level anterior plus posterior. From posterior release that is what I feel 4 to 5 levels at apical level is important. But I think you've done a very good job.
No,
Go back to the traction film. The traction film.
Yeah,
you
yeah.
show. Yeah. So if you can achieve that pelvis slightly more, you said 20 degrees, it has corrected to 20 degrees. If you can achieve it slightly 15 degrees and get this trunk balance where the shoulder is sitting on the pelvis, that should have been, that's where you should plan your.
So we'll come there. Ranjith.
So the question, which in a case of costopelvic impingement, does a pre-op bracing give us any information?
No, the halopelvics, bracing, everything.
The bracing was only for a temporary purpose. It was not for correction or anything, so that the patient understands that what we are going to do before doing this a major surgery.
And
That's the only thing.
Second, Guru, in these patients who are a non-ambulator, essentially sitter, the worst thing is to have a post-op coronal imbalance. Because if you are doing it to make them sit straight, you have to make them straight. Because they are worse off with a stiff bent spine than a mobile bent spine. Third, in these patients, we routinely, our protocol is to take a convex pelvis bending X-ray because you cannot do a fulcrum bending in there. So a traction seldom adds anything to the rigid part of the curve. Because like what Dr. SHAILESH mentioned, these don't come off very soon as they say it's very mobile. So you do a pelvic, physically you have to go and like you do adduction, abduction, deformity. You abduct completely and get them to see how much it stretches out. At that point of time, I make my decision, should I do an osteotomy or not? Because whatever I do, I have to achieve a level head with a level pelvis. If I cannot do it, I will not touch it. So if this is sensory intact patient and all these dystrophisms with hip dislocated, neurology, you cannot worsen much because they are already lost. They just want to sit straight. And the pain is because of the course of impingement. So even if you go in and you release a bit of it, you worsen a bit, like I don't use neuromotor in these patients.
But I don't agree with your comment that they just want to sit straight, because if you lose sensation and bowel bladder control in these patients, you are making them worse.
This patient already
So
lost
you
bowel
have to be
bladder, right?
careful there. Other points I totally agree with you.
So those bending, and if I don't get my thing leveled, I'll not hesitate first, because the osteotomy thing is that if you want to do the front, you have to do the front first. You cannot do the back, then do the front.
Yep.
So that decision is taken before you plan your intervention. Do you want to do a front release and then do a back correction? So if I don't get it leveled, I'll not hesitate to go from the front, release, not fuse. Release that is completely and come back, because at that point of time, a pontis or whatever will get me fully derotated and get the pelvis straight. That's
Okay,
my take.
so we
I think we have a. We just move to the next case. I think we
So,
have one
we
more.
were just-
It's almost over. 1 o'clock. It's the time.
Sir, we have another 20 minutes to go. We'll have one more case. So actually, we went with the same plan and had the same issues. But then, if you see here in the apex, basically these vertebrae were so rotated, and there was, because of the prior operation and all, there was scarring. So it was, anatomy was itself was so distorted there. It was very difficult to decide anything, to do some releases or anything. But still, I could do any bone which I could see. I cut it, because there was no way I could put pedicle screws, because the vertebrae were looking like that, and there was no way I could put screws in the apex. So that is why osteotomy was not done, because I didn't have a good hold there. So I couldn't destabilize spine more. And then the next thing was the duckling deformity which he had. The pelvis was completely seeing you like that. So negotiating a rod after doing osteotomy, that is why I had to use this 3-rod construct to negotiate that duckling kind of deformity on the basically concave side. So that was lateral X-ray, and that's his clinical. So even though X-ray looked a little here and there, clinically he could sit straight. I think, as Vishal rightly pointed out, because his hips are dislocated, they compensate. So he could sit straight without hand support. So that was the aim of the surgery, and we did this, and this was done like around 4 years back, and he has not come back. That means everything is good. But no, 1 minute. No, let me complete. Because this patient is from outside, and if at all something has to happen, they have to come back to me. He has not come back, means it has to be good. But then again, I would like to caution, neuromuscular scoliosis, complication is bound to happen. So if you want to do surgery, you have to bear the complications also. Okay, so case 2, adolescent girl, 15-year-old, deformity go back since almost noted since 7 years. Difficulty in breathing since last 3-4 months. She was on BiPAP and oxygen support. She went to multiple hospitals, discharged from everywhere, saying that she is unfit for anesthesia because she had a type 2 respiratory failure, and they said just nurse her at home. So she came to us. That was her basically X-rays. We'll come to the X-rays. We just note on that. Basically, she had a type 2 respiratory failure with PaCO2 of almost 60% and 70% and PaO2 of 60%. So severe type 2 respiratory failure on BiPAP support. So we'll just skip that. So that's the X-rays. Let me come to Appaji. So Appaji, what do you see here, and basically what makes you really frightened here?
There is a severe lot scoliosis. Two things. One is, I think there is some congenital bar on the concave
that's
side. Yeah,
great. You pointed it out.
Yeah. So, and second thing, did you do an echo?
Echo was done. Echo was
want
done.
to-
Echo
I
was,
want to
echo was normal.
No pH.
No pH. No
So
pH.
it's a reversible respiratory
Yes,
failure.
yes,
season.
yes, no pH.
So second thing is the thoracic volume. Have you done a CT scan mentioning the thoracic volume?
We have done the CT scan.
Thoracic volume.
I'll show you. I'll show you
Yeah.
that.
So, and the third thing, how old is she? You said
15-year-old.
15-year-old. So she's already completed growth.
Yes.
And the lung expansion, if at all you're expecting after surgery in this girl, is not going to. It is going to be atelectatic, or it can be emphysematous, rather than you are having a growth lung.
So Appaji, I take your point. Let's come back to that. If she would have an atelectatic lung, whether it would have been a type 1 or a type 2 respiratory failure. So atelectatic lung, you will have a type 1 respiratory failure where PaCO2 retention is not there.
No. I'm not talking about pre-op.
Pre-operatively, that's what I'm saying.
Pre-operatively, she has a restrictive lung disease.
So that is what I wanted to different. Vishal.
What is the cause of scoliosis here?
So it's a.
Is it a congenital one?
Congenital one.
So there are some cases where we can't help much.
Yep.
You do any surgery in this case, the cardiopulmonary reserve is not going to improve.
Okay.
If it's a congenital in a 15-year-old girl with a respiratory failure, the cardiopulmonary reserve is not going to improve. You will at the most be able to achieve a good truncal balance for this girl.
So that is what
More
everybody
than that,
told.
I think
That is what
sometimes you have to
everybody
call
told
it a day. You have to discuss with the relatives that if at all, we'll give you a straight spine, but the cardiopulmonary reserve is not going to improve, and the surgical risk of having you on a ventilator dependent kind of situation is very high, whether you really want to do a surgery for this kind of situation or not. For me, I will probably not do a surgery in this way.
Another thing is she has a tuft of hair, which is a telltale sign of a split cord malformation. So getting an MRI and see how bad is that,
Actually,
if
you can-
associated serings or associated
You
split cord.
can see a big diastema. You can see on the X-ray also. You can see on the X-ray also.
There
There's a
in the
long segment of diastema. bonish
Diastema.
per-
No,
the
I
line.
beg to differ with Vishal. So if the patient has not developed PAH and no right heart failure, doing surgery will be helpful in these patients. Actually, if they have developed irreversible PAH, they are goners. They are, even if you do surgery.
Quickly, we'll move on to Dr. Srivastava sir and Dr. Amit Chala. Then
Yeah,
we'll see what
so
we did.
MRI, there is a diastematomylia, so that border. So in this case, somehow I'm feeling that we can still try, and halo is one thing which will help. And many a times we have found the halo improves the lung function.
Yep.
It has been actually reported also. So I think this is one addition I would like to make. now.
Slowly, I think we are moving on to the right direction. Vishal said, I won't operate. Appaji said, will, Vishal, stop. Dr. Amit Chala.
Yeah, I also agree partly with Dr. Vishal that you see with a patient in a respiratory problem with a PaO2 not maintaining at 90, and the surgery requires, it's a long surgery again, without an osteotomy, you are not able to achieve this thing with a lot of bleeding. I would counsel them of
Actually, she was not fit for anesthesia at all.
Yeah, so that's
In
what
the
I'm
first
saying. I
place,
would
she was
just
not
counsel
fit for
them
anesthesia
for
at all.
not doing a surgery
So-
rather than doing a
So
surgery.
what we did is I'll just
Theoretically,
show-
you can do anything, but
No.
that's what my
So
choice.
practically, I'll show what we did. So this was the issues which we had to address. Basically, lordotic thoracic spine. It was a rigid scoli. Diastema. She was not fit for anesthesia. Excising such a long diastema from D11 to L3 was not of a question. And there was a severe pelvic obliquity, and she was ambulatory. She could walk with BiPAP machine. So what we did is we started her with halofemoral traction. So that's what we did for 2 weeks, initial 2 weeks. With this halopelvic traction, the deformity reduced to up to almost like 60 degrees. And her respiratory status improved remarkably. ABG levels started showing improvement. PaO2 from 60 to almost like 80s, in 80s. So it actually showed a tremendous improvement at that level. And then what we did is halopelvic. So then we started her mobilizing with the gradual distraction for another 4 to 5 weeks. Gradually, we distracted her and we did a first surgery. I'll just skip this theory part. So we'll just, yeah. With the halopelvic on, we went in and did some releases and a kind of a asymmetrical half-hearted PSO because she was not really fit for a long duration of anesthesia, and did some posterior facetectomies and releases, whatever we could do. We didn't touch the diastema because ultimately the plan was to do a column shortening, not lengthening. And whatever lengthening we were doing awake lengthening with the gradual distraction. So we didn't touch the diastema. So that's what we did in the first surgery. And then again, we distracted her with the basically halopelvic traction. You can see now how beautifully it is corrected. It's corrected beautifully, and her respiratory status improved tremendously. She went off BiPAP actually with this distraction. So sometimes we tend to think that, but I won't say this is a good result. Like you won't achieve the same kind of result every time, but for this patient, that was a hope. So it involved a lot of planning, lot of discussions, even till like what Vishal said, going on ventilator forever. So it involved everything. So ultimately we went in and then did again, I would say a kind of a half-hearted job where we wanted to fix her in situ. And because she was ambulatory, we went till L5 and fixed her from L4, D3 to L5. So this was done. And this is how it looked. And this is how she is standing. Even though I won't say completely balanced and everything, but she is off BiPAP. She is able to move around and she is able to stand and walk. So that is what we could achieve.
In second surgery, did you manage that split cord or no?
No. We didn't touch it. Appaji.
Actually, split cord is not need not be addressed each time. That is also a reported thing, because patient comes to you at 15 years of age, split cord doesn't matter. Yeah, shortening. So no
column
problem.
shortening. Appaji.
So good job, Guru. But what I was trying to say again here, that you intervened at the right time before there was a right heart failure.
Yeah.
So we had two patients, same time. I have a photograph of those two boys. One boy we lost 3rd day of surgery. One boy we lost 8th month of surgery. But both had carpulmonal, irreversible PAH. PAH was 96 in one boy, 101 in another boy.
So
they never
really
recovered.
severe. Those are really
They
severe.
never recovered, and we lost both of them. But that's what I want to point out to Vishal also. If you can interfere before they develop that PAH, that is when you are going to help them.
In fact, I would, yeah, such an august audience, and I'm sure we're all going to be seeing more scolios of this type in future. There is always a tendency to push away patients. कि अभी सही समय नहीं है surgery का. So many of our patients come and tell us, even idiopathic ones, there is no bad age to operate or intervene. There are so many options available, right from growth rod to tethering surgeries to detethering of the cords, or for that matter, just stabilizing, lengthening cord distraction surgeries. Please intervene at the right time. If you are not operating or if you are not able to do that, I'm sure I would send it to one of my best friends, cases like this at early age.
So I think a last takeaway message from this case is, I think halo pelvic traction or a halo gravity traction really it is helpful. So we have seen in we must at least have 10 to 15 patients who had respiratory compromise with only halo pelvic or a halo basically gravity traction. Their respiratory status improves until unless they have raised pH. Otherwise, you can intervene and you can give a good result to them. Last comment from
No,
Chala.
that's okay. I think it's very well managed. And the message of Vishal is also very important. I would absolutely agree that don't wait, because the patients come with the serial x-rays of not doing anything till 15 or 16 years of age. I think that's very important message from this. And as far as this case, as he said, that you are lucky that you got out of these things, but sometimes you can also be in a trouble and a problem.
Sir, I have two cases where one case is still on tracheostomy. He is a neuromuscular scoli. Basically, he is a Duchenne muscular dystrophy, but he was like this, he was not able to sit. But now, at least with tracheostomy, he is on room air, but he is able to sit. So that's what you can achieve sometimes, whatever. It's not always that whatever you have thought out to achieve, you won't be able to achieve that. But I think the main aim of surgery in neuromuscular scoliosis is to give a better quality of life, not a good quality, whatever quality of life they have, to improve that quality of life. That is the aim of surgery in neuromuscular scoliosis.
I think, can you...
No, this case we had not done, and we don't do any pre-operative tracheostomies because even if we think that his respiratory compromise might not improve in post-operative period, sometimes we have seen it has improved. And I think I had one case, one patient who was on BiPAP is able to run 5-kilometer marathon today. 5-kilometer marathon today. And so we have examples like that. So we don't do any pre-operative tracheostomies. But then I have two patients who are on tracheostomy. But then that's part and parcel of yes, post-op. Post-op we had to do it. It's a part and parcel of the job.
I think we have two excellent cases, and we can have a summary statement so that we can go to the next session.
Yes, sir. That's nothing much. So I had one more case, but then for want of time, we can just skip that. So we have discussed all this. Basically, it needs a multidisciplinary approach, like Dr. Luhana said. Maybe at single center or a smaller nursing home, it might be difficult to do. But then if the patient doesn't have anybody other than you, or if you don't have any referral centers, you can always give some quality of life to these patients. And you need to address all these issues which I have actually mentioned here. So that's all. Thank you.
Yeah, excellent presentation. Both the cases were very difficult, excellent. So yeah, so time for lunch now, and we'll be back by sharp.
1:45.
Yeah, 1:45. Yeah, we reconvene at 1:45. Yeah.
We are proceeding for the lunch now, and we will again come here at 1:45 for the next session. बंद करता हूँ।
check, hello, check, hello, check, hello, check, hello, 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 check, hello, check, check, hello, hello, check, check, hello, 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 check, check one, hello, hello, check, check, hello, 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 check, check one, hello, check one, hello, 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 check, hello, 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 check, check, hello, 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 check one, two, three, hello, 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 check one, two, three, hello, check one, two, three, four, hello, hello, check one, two, three, hello, 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 check, hello, 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 check, hello, 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 check one, hello, 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 check, hello, check, hello, 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 check, check, hello, 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 one, two, three, hello, 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 check, check, hello,
Hello, hello, mic testing, check. Hello, check. Hello, check. Hello.
Hello, good afternoon all. Now after the lunch, we are starting next session. That's on early onset scoliosis. And as a panelist, I would like to invite Dr. Bharat Dave sir, Dr. Ranjith Unnikrishnan, Dr. Hari Menon sir, Dr. Deepak Shah. I think Dr. Ram CHADDHA sir has to leave for some work. And Dr. VISHAL KUNDNANI sir, please may take a seat. And I will invite Dr. Hardik Suthar for the first talk on rationale on management. And then after Dr. SHAILESH HADGOANKAR will take over for case panel discussion.
नहीं देखाय એવું છે દેખાય છે દેખાય છે સર I think this is convenient.
अच्छा adolescent इसका तो Oh, अच्छा ऐसा है क्या? 5 minutes rational challenges. Then 1 hour. Slide. So there is no someone is in the 5 minutes.
Good afternoon, all of you. I know we all had a heavy lunch, but with this is very interesting topic. We have a big panelist here on the dais. So we'll have a great discussion on the early onset scoliosis. That is very huge topic. I'm just going to brief it about the rationale and management. So any curve more than 10 degree in the child under the age of 10 years, we consider it as an early onset scoliosis, whether it is a idiopathic variety, congenital, syndromic, or neuromuscular variety. So it is very important to note why it is important to discuss about the early onset scoliosis. Here we have to see for the lung development. At the birth, around 20 millions of alveoli are there, which become to adult number, that is of 300 millions by the age of 5 to 8 years. So it is very important to have enough space for the lung to develop during that period of time. So we have at least good amount of alveoli to develop so the lung can function properly. So we have problems of this early onset scoliosis, which are of severe and rigid variety that can cause delayed development and underdevelopment of the lungs, and that can cause a serious pulmonary and cardiac complication that sometimes can be fatal also. So to discuss about the progression of the curve in the infantile variety, it is a rib vertebral angle difference of mean meta, that is of more than 20 degree, and in the phase 2 of vertebral rotation, where the rib is overlapping to the vertebral body, that has a higher chances of curve progression in infantile variety. When we talk about the congenital scoliosis, it's a unsegmented bar with the contralateral hemivertebra that has highest possibility of progression than that of the wedge vertebrae. Also, the site of the curve in the thoracic and thoracolumbar area that has a high propensity to progression. Early age of the diagnosis has a higher possibility of progression. So goals of the treatment, as we are discussing from the morning, it is to have a balance, deformity correction, along with to prevent the progression of the deformity, that helps to allow development of the spine along with the lung and the thoracic cavity, and to achieve an adequate height of the trunk. And that's how we can provide the better quality of life to the patient. And also very important, with our treatment, we should have a less complication during the lifespan of the treatment. So we have a conservative treatment in the form of brace, cast, or combination therapy. And also in the operative, we have a distraction-based system, guided growth system, and the tension-based system. So when we talk about the sitting height, why it is important? Because that's how we can measure the actual thoracic height that is required for the thoracic cavity to develop. So it is 30% of the thoracic height, which is correspond to the sitting height. So we have to calculate it accordingly, and we have to plan our management according to that. So we should have at least 18 centimeters of height by the age of 5 years, and around 22 centimeters of the height of the thoracic portion of the spine by the age, before puberty. So in the non-operative treatment, as we all know, we should always start with that, with the bracing, and it should be continued till the maturity. I would stress on this casting technique, as even being a young surgeon, we are lacking this practice. There is a very wonderful practice of casting, and it should be like it should be showed in a old wine in new bottle, that we should have a program to learn this art of casting technique, so we can have a complete resolution of infantile variety with the conservative management itself, and we can reduce the curve magnitude in the severe deformity and delay the fusion until the pulmonary maturity attains. So it is very important how to apply and how to prevent the complication associated with the casting technique. And the major issue what we face in India, that is our humid atmosphere, the parental dissatisfaction with the treatment along with the serial general anesthesia. That is one of the major drawback what I think we as a surgeon facing with the casting technique. When we talk about the surgery, as we all know, these kids are very small. Many times these are malnourished and with the low weight. So anesthesia is of very crucial, and the size of the implant is big. So sometimes it becomes prominent, and the hold of the implant is also questionable. So we have a growth rod distraction system. I'm not going to talk in detail because we have a wonderful panel discussion on the treatment plan. So here is the dual rod is far better than the single rod system, where we have a proximal and distal foundation of the screw, and in between we have a rod distraction system. We gradually distract it to achieve the required height. So many complications, almost around 50% we face during the lifespan of the treatment, require regular lengthening procedure, unplanned return to OR, mostly because of the implant issues. And there is a low of diminished return of the expected distraction, and the development of proximal junction kyphosis along with wound and infection issues, and implant is a major issue. It become loose and break. So to overcome this repeated lengthening, the magic rod came into picture, but it is very costly, and sometimes it fails. Then we have to reopen it. So another system is the Vaptor, where it is applied on the rib and the proximally and distally to the pelvis, spine, or the ribs. It is mainly useful in the thoracic insufficiency syndrome. This is the case of a type 2 variety of thoracic insufficiency syndrome, where the Vaptor is applied, and we have a very good growth of the trunk by the 3 years follow-up. As we have a similar rate of complications with this Vaptor system also. The growth guided system, it's basically what we see. It's we direct the growth. We provide a scaffold for the spine over which the spine grows. So we have a apical fusion with the correction of the deformity, and distal growing screw, where we put the rod without tightening it, and along with the growth, it continuously guide the spinal growth in the precise manner. So the last one is the tension based system. It is very experimental in early onset scoliosis. It is mainly used in the adolescent variety of the group. So do we have a gold standard option for this EOS? That we will have a wonderful discussion on the panel. But as I know, we have to make a tailor-made plan for each and every patient. And with this, I am inviting Dr. SHAILESH HADGOANKAR to have a wonderful panel discussion on the EOS.
Thank you, Hardik. And at the outset, I would like to thank the Gujarat Association of Spine Surgeons and the esteemed dignitaries present today, and Dr. Neeraj Vasavada for a wonderful show of deformity post-COVID. And I'm sure every one of us are learning. And Neeraj has given me a very interesting task of demystifying the early onset scoliosis, which is ongoing for 60, 70, 80 odd years. And still we do not have the answer. As Dr. Hardik was talking about the magic rod, or he was talking about the Sheila, the recent publication in 2015 by the inventor spoke about 69 to 70% of failures in Sheila. The magic rod, yes, you can use it. It's very costly. The problem is you do not have a sagittal contour because it's the rod and it's the magnet. You cannot have a angulation or sagittal profile with magic, and that's a big disadvantage of magic rod. Now, where do we stand when we are talking about patients who are coming to us where we want to spare time, where we want to give the spine a growth? And it's always a challenging when such 6-7-year-old child comes to the clinic, whether we should fuse, what will happen if you fuse, if we brace, whether the patient will have compliance to the bracing. These are the very difficult challenges when the patients are coming. And as one of the greatest pioneer in early onset scoliosis is Min Mehta, the Indian lady. She's a Persian and she was in Calcutta, who went to England and The rib vertebral angle of RVAD is described, and a lot of bracing techniques in the 60s and 70s were described by Mehta and team. So let's proceed with the case-based discussion first, as we have a esteemed panel here. This is a 7-year-old female child, nil neuro, and this is the X-ray. The major curve is 78. Apex is at D9, and it's reasonably flexible. Push prone X-ray, and it's a progressive deformity. I would like to ask Dr. Vishal, how will you proceed?
So first and foremost, kids, whenever we see any deformity where the deformity has started less than 8 years, I mean, my antennas just rise up, and I would actually try to find out the cause of scoliosis and rule out all the secondary causes before I consider this as to be an idiopathic one. And so investigations, number one, starting with MRI, of course, to see any neuraxis abnormalities, including the CV junction screening, which often gets missed out on MRIs, because just a Arnold Chiari can be a cause of this kind of deformity, which is progressive and present early. C1, C2 dislocations with a mild syrinx can also be one of the causes. Tethered cord can be another cause. So neuraxis abnormalities, MRI. And of course, then trying to find out if they have anything else to preclude them as a syndromic kind of curve, like a 2D echo is absolute must to find them, a USG to rule out if there is any single kidney, and if there is any congenital variant to this scoliosis, because very often we see that the scoliosis, though it seems big, but at the apex you may find an unsegmented bar or something. So investigations to rule out those things are on the card, and all these investigations are absolute must whenever a child is less than 8 years, or whenever you see a component of kyphosis like it is seen in this particular case scenario. So investigate to rule out things.
Perfect, Dr. Kundnani. I would like to ask Ranjit, a lot of time we see these patients are seen by various different doctors, and they come with CT scan. Will you advocate CT scan in this particular kids?
In this particular patient, what information I need is enough from the X-ray.
Okay.
So I'm not planning any surgery, anything at this point of time before I have an MRI. So MRI is what is required primarily. And to add to Dr. Vishal, I'd also look at the entire systemic investigation, not examination. Look at the renal anomalies, cardiac anomalies, apart from the neurological anomalies.
Perfect.
Because we know that in EOS, there are no rules. There are only principles.
Correct.
Each patient is a unique challenge. So principle wise, we have to go this 1, 2, 3, 4, 5.
I would like to ask Dr. Dave, sir, how important is counseling in these patients who are coming to the clinic?
I think I would go with the family history first. I think that is very, very important. And I think we need to really look at the background of the family and whether they are compliant, they're going to compliant. So whatever has been discussed, it is certainly related to diagnosis, but certainly related to the other issues. We have to keep them in mind as well.
Yeah, because a lot of expectations are there, and yeah, well said. We'll just proceed, and this is the traction film, and the RVAD difference is 40. And again, as I was talking, this was done. We just had to screen the X-rays, and this is the MRI. Yes, Dr. Hari. No intraspinal anomaly, and this is the clinical picture. How will you proceed with this child?
Obviously, she is going to progress, and the age being 7 years, I would be a bit reluctant considering her lung maturity to intervene at this stage. I would consider a bracing or a cast and wait for some more time, get her pulmonary functions evaluated at this stage, and evaluate her at a later time.
In this lung does not look that bad.
It is the idea is to have at least 18 centimeter of thoracic height before you go for any definitive pulmonary fusion. So even though the lung looks okay, the curve is not bad. If you're going to fuse her now, you will fuse her short. So the summary statement, you know, from all that Campbell studies, which says that at least achieve 18 centimeter of thoracic height. That is T2 to T12.
The age you mentioned,
7.
7, yeah.
So I think we need to understand that EOS, it's a deformity. It requires a definitive correction.
She was going for 2 years elsewhere under treatment when
So
she was presented to
it
us.
surely requires corrective maneuver. And someday you are looking at a definitive fusion surgery, which is also going to be a corrective surgery. That's principle number 1. So at the end point is a definitive fusion corrective surgery. The question is how delayed you can do. How much can you delay it and what are the means to delay it? To me, in a 7-year-old child, I think they are not very compliant to casting, but they are very compliant to bracing a well-fitting, nice orthosis. If they are compliant, you should surely try. Even if you can delay for 6 months, you can actually delay 1 full surgery of elongation for them. And maybe after 6 months, you can, or a year.
She was braced, she was casted.
Yes, of course. So yes, it may not work.
So it was already done, exhausted.
First dose part is over. She's before her second dose part. So now the progression will be delayed with respect to cough. But still, at 78, your push prone shows correction to 60, right? Traction.
No. Not correcting well.
I think the principles and challenges both have been very well highlighted. It requires a surgery to do a definitive correction fusion surgery. How can you delay it? The option should be very clear. And how can you delay that surgery with minimal number of problems to this patient till the definitive surgery comes in?
Correct.
And for that, there are various options, of course, Vector, Magic Rod, Growth Rods, Sheila procedures, or Indian variants of hybrid distraction systems are available. Which works the best in your hands? Be ready that whichever you do, the complication rates are to the tune of 100% within a year. Reoperation within a year. And even if the rod doesn't break, even if it's not a complication, the reoperation to elongate and distract is surely going to be required.
Yeah.
So unless you counsel the patient about this,
reoperation is not failure. It is a procedure. You know, it's.
I'm talking that it's not a complication, but the reoperation rate is 100%. You are surely going to require to distract it.
Correct.
Even if you do a simple Indian hybrid rod or you do a vector, there is surely going to be a requirement for distract. The principle is same. You have to delay the definitive corrective fusion surgery to as delayed as you can.
So I think the point is well taken and very clear that delay it as much as possible. Simple casting, bracing is important. And when you want to go ahead for any procedure after exhausting all these options, we can consider.
Shailesh, one quick point to this.
Yeah.
Delaying the definitive corrective surgery does not mean delaying the treatment. Unfortunately, many of our orthopedic colleagues, what they do is, you are too small for a surgery, and I have heard in a conference that a definitive surgery can only or should only be done after 12 years of age.
Yeah.
That does not mean that we delay the overall treatment. The idea is delay the definitive corrective surgery of fusion. However, the treatment should be initiated as early as possible. Like Ranjit mentioned, if this girl had come to me at 30 degrees, 35 degrees, if she was picked up at the age of 5 years with 35 degrees.
That's the best time to do
That
it.
was the best time to do bracing, casting. And you could have actually prevented this grotesque deformity to you. So start the treatment
She
as
was
early as
still
possible.
not a compliant girl. Yeah. Any inputs, Dr. Shah?
I think the bracing and casting options are exhausted, as you say. So at this point, I think growing rod with apical fusion, what I have seen with my mentors,
so
that will be a good option.
So among all the options you mentioned or Vishal mentioned for growth rods, magic rod should not be done right now, because now prima facie, if you take a magic rod, the company makes you sign a consent that you will take it out within 18 months, 2 years. They'll make you sign a consent because of international rules that you take it out, which by every means she's only 7. You want to get to 12, 18 centimeters, when they graduate.
Absolutely.
You have to wait. So magic rods
That's
are
not
out.
an option.
Not an option.
Sheila is also out of it.
Yeah.
Still people are doing that continually for more than 2 years. I won't say it's out of.
But today you have to write a consent.
But if there is
the
a
moment you use a
kyphosis,
magic rod, you write a consent that you will remove it.
Also.
2 years, and any complication arising because of not removal is the surgeon's responsibility, not the patient. Surgeon's responsibility.
There's something called labeled or off-labeled. Off-labeled, it's been.
Yes, Neeraj. Is a speaker, please.
Years also, 5 years also, because there are good enough reports for them. I have declared to them. Let's see what happens.
Yeah, all these have come out. This is the recent guide. All the earlier was kept for 8 years, 12 years.
So it is because of the corrosive material.
Okay, let's proceed.
They are changing it.
Yeah.
Company itself.
Out of fashion.
One of the main reasons behind that is the reason why the company makes you sign the 1 to 1.5, 2 year declarative. Because after that point, the metallosis starts to get really bad. And then because you have got 2 tracks, where you've got significant metallosis, even if you leave it or you try to do corrective surgery at that point, you tend to have a very unhealthy bed to put your metal work in. And the fact that the metallosis causes scarring. So the scar tissue that you have is so stiff that your corrective surgery, you're fighting against the scar tissue as well as the deformity. So purely because of the metallosis issue that happens with the magic, that they've gone completely out of fashion. So
And no control of the apex.
no, you don't have
You have the APC system, APC method today, the anterior posterior control, where you have a control over the apex along with elongation.
That's right. So you only have unidirectional control over the deformity with the magic rods, which in this particular case, I would never do anyway, because you've got a kyphotic deformity.
Yeah.
That kyphotic deformity.
I tell you, the moment you plan a growth rod, please remember that growth rods have their own problems, which are magnanimous if a patient has kyphosis. You are distracting the spine and you are further adding kyphosis to the upper thoracic junction, which is not only a recipe of failure, but also you are creating a disastrous situation for the patient for definitive future
The
surgery.
CEOS classification is very, very useful. And now we are left with very less options, single rod versus double rod, and that's a growth rod. And we'll proceed with what we did.
I think the goal of surgery, Shailesh,
Yeah.
like we are discussing, the aim of surgery is to delay the definitive
Yeah,
corrective
that's
fusion.
what,
On
yeah.
the other hand,
Yeah.
the goal of surgery should be how you can manage that till the day of maturity, if you can keep the curve under 60 degrees. So if that you can
much as
achieve today.
Centralize, yeah. And this is what we did. And there are 2 types of rods which we can use. Parallel and uniplanar. The problem with uniplanar is you can't get more than 4 centimeters, and the parallel rod with the dominoes you can get slightly more height if someone is growing faster. These are the 2 constructs. And this was the post-operative X-ray. It's only fused at the end vertebrae. And this is the correction. If you see, the main thoracic came down to 42. Kyphosis also got significant correction. And these are the clinical pictures. How she was pre-op and how she is. Completely balanced, and we will be monitoring her for next 3 to 5 years. Yeah.
One quick thing. I mean, it's a wonderful thing that you're distracted in. Only one concern that I have, if you can go back to the X-ray.
Yeah.
Choosing the distal anchor point. I mean, now because we have committed ourselves to L4, your final fusion is going to be ending at L4. So choosing, in this case, probably it was required, I'm not sure. But choosing the distal anchor point is very important, because whichever anchor you choose, you are going to be making it a definitive fusion point. And that is why the traction one. In this case, I would probably choose a slightly higher one because I know that I'm any which way is going to do a definitive surgery at a later date, which I can extend at a later date.
See,
no, I think
see,
L2 maybe.
if it decompensates, then again it's a problem. It's safer to go on end plate, neutral vertebra plus.
You, please allow me. So, Shailesh, what you say is that if she decompensates, what is the worst thing that you will do? You will probably in 6 months go one level down, which you are any which way is going to distract. You are calling these patients 6 monthly. They are under close follow-up.
Yeah.
So if it decompensates or there is a further addition, which never happens, why?
It
Because
never
you're
happens.
distracting. Because you're distracting
If you fall
continuously.
short, then you will have problem. If you go at appropriate level, you will not have that problem. That's
That's what I'm trying to say, Shailesh. I agree that you have chosen a definitive point on day one. What I'm trying to say is that.
But better, avoid. Yeah.
Try to have a proximal anchor point, which can be revised to a distal anchor point at a later date also. But now, once you have chosen a distal anchor point, you cannot revise and make it a proximal anchor point.
Yeah, see, that can be now there is more and more support of the active apex control.
Yeah.
So active apex control will solve a lot of these issues which Dr. Vishal mentioned, because in that it's a Schiller technique, but you put convex screw, you put 2 screws, it's the epiphyseal effect.
Yeah.
You put the convex screw, compress it there, and you let the rest of the segment to grow.
Yeah, but if the person who is described is talking about 70% complications.
Not Schiller, I'm saying active apex control.
Okay, APR. Yeah. Okay.
Active apex control is a modification of Schiller.
That Turkey surgeon who is, the one who is doing
active
it.
apex control.
Al-Azmi. So
Yes,
he's
the
still in
APC
experimental
group
stage. He's
mentioned.
mixing both the techniques.
Exactly.
Yeah.
Exactly.
But we
So
will
you
wait for the
distract on the
literature.
concave side,
we
which
will wait for the
continues.
literature because we don't know. He just is an independent surgeon who is doing it on his own.
So this is a wonderful thing.
Yeah.
What we have done. Yeah.
How to do the correction during the primary surgery? It is the rod distraction or whether we give the traction to the body while fixing the initial correction.
Correct. As rightly said, you need apical pressure.
Apical pressure.
And subtle traction if needed, if it is not getting good on table.
Okay, because many times when we distract, it sometimes loses the
Not
anchor
only,
point.
not only with the rod, not only with the rod.
Yes.
And again, a lot of literature is coming against single rod, but a lot of time it's like a mix and match. A lot of time single.
Child, you cannot put in at times 2 rods.
Correct.
So most important thing in these patients are to have solid anchors. So in patients like say 5 years where you have to go in at times 4 years, it's a good idea not to do the surgery in one stage. So you go first, put 4 screws down, put 4 screws up, leave them like that. After 3 months, come back, then do your rod, because at that time it is firm enough to take your distraction force. If you do it because all these failures happens at the junction.
And again, there are various different things like a lot of people do only above and below openings. But there is a case report, case which happened where they tried to put the rod, it went into the heart and patient succumbed on table. So all these things are very important. Whether you have to be very comfortable, whether you're using the chest drain tube and getting the rod parallelly, because it's a very long segment. At the same time, you can open up complete spine and do only, we'll say at and that's it. That also you can do. So you have to be very careful when you are planning. So I think it's not a very easy situation when we are doing this.
I think this temptation of correcting on day one should be avoided, even if it is getting corrected.
Yeah.
The more force you apply and get primary correction, the higher is the chances of rod breakage. And remember, once the rod breaks, it is extremely difficult to get the rod out and get the same track of the secondary rod that you're putting in, which may actually force you to convert it into a primary early view.
That's what we're seeing. Chest tube.
Yeah. So, as the Dixon coined this term of early onset, and nowadays the Global Spine Deformity Group, the Children's Spine Deformity Group, and SRS have collaborated, and anything below 10, the onset below 10 is early onset. Yeah. And maybe it is neuromuscular, neurofibromatosis, idiopathic, congenital, anything, it is EOS.
Even in that, each of them behave separately. So you have an EOS because of congenital, and EOS because of NF. They're totally different.
Totally different. Yeah, they are totally different ones.
So
yeah.
no rules, only
no
principles.
rules for this. Absolutely. So again, this is an interesting case. 9-year-old girl, progressive.
Shall we have the post-op protocols?
Yeah, in this particular patients, normally we do not prefer to use any brace, but brace can be used. There is no any it's additional support till the time the child matures. But you can start mobilizing the patient next day.
I always use brace. Very snug fitting, plastic molded with a Velcro brace in these kids. At least for me, always. And every 6 months when the child, because the first part is counseling these patients that you have to come in every 3 months.
Yeah.
However, the surgical distraction will happen every 6 months.
Yeah.
Your brace change also will happen every 6 months. So whenever the patient is coming, the brace, even before the patient is taken up for surgery, the brace is sent to the orthotic because it will require a change after this distraction that you do every time.
Yeah. What
so these
Vishal
are molded
is,
braces.
yeah, what Vishal is saying is
Yeah, so
yeah.
So I don't use a brace. We have no brace. EOS patient, second day they walk and they go home.
Yeah, they walk. And like what Vishal is talking, in the 80s, when they were doing only plasters, Nash and Moe, the Moe guy started doing the distraction of Harrington's along with the plasters. And things are coming back, in this EOS, everything is rattling back and forth. So we are not moving ahead, we are just moving there and there, original principles of Harrington. So this is a 9-year-old girl, head shifted but central, asymmetry at waist, left loin creases, right loin fullness, left PSIS was at a higher level, apparent limb shortening, no skin markers and no upper motor signs. This is the X-ray. And these are the clinical pictures. Costovertebral impingement. Yeah. No, there was. Yeah. 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 This probably we'll come to that because it is there in the subsequent, because it's a very interesting case. Yeah. So we'll start with Ranjith.
So for me, unless I know what geology it is, I will not proceed.
So I'm asking what all things you will do.
So MRI definitely, in this case CT.
In this case, definitely, apart from all the history, all that is taken, MRI definitely with all what Vishal mentioned first, CVJ, brain screen, then also look at the kidneys and also get a CT done to see for what are the congenital anomalies there. In that CT, it should be very, very, these kids require repeated imaging. So you should make sure that whichever center you work or you get a CT done, that they should get true actual images. Most of the time, a random run will give you nonsense, will not find anything. So to make sure that you get the true actuals through the plane of the pedicle, that should be done, and then get the reformatting done, because we cannot keep repeating them. And also there's a low dose CT protocol in our hospital, which we are using for these patients, because they get CTs done probably after 3 years or 6 or sometimes after 6 months. That's one. And for me, before having a diagnosis, I will not even think of planning for this patient anything.
Perfect, Ranjit. Yes, Vishal.
Just echo in the previous session what we spoke about. Atypical curve, this apparent limb shortening, I am little skeptical to hear it is apparent.
We can see the hip also.
Yeah, it is. Yeah, so it is probably not apparent. There is a component of true limb shortening plus short, acute C-shaped curves. That's the alarm that there is some neurological entity there. There is some neuromuscular, and a small tiny examination of sensations will tell you whether this patient actually has a spinal muscular. Just 4 days ago, I have seen a patient, spinal muscular atrophy. everything is normal, only EMG NCV is the only diagnostic test. And you do whatever surgery in these patients, they are bound to come back to you every year. Whatever you do a definitive fusion, they are going to have completely different set of problems. So I would agree to what Ranjit said, that please try to find out what is the exact cause of this scoliosis. Even if the MRI is normal, hypotonia, if it is suspected, please try to find out if we are dealing with a spinal muscular atrophy, neuromuscular cause to it, of course, congenital with a CT scan, and limb-length discrepancy. There are so many secondary things to be taken care of. And then the principle of delaying the definitive corrective surgery still remains intact. You delay the definitive surgery till you can and fuse it long as
Yes,
well.
Ranjit.
And in these patients now, it's a catch. So now you have the hip subluxating, you have the spine. The spine deformation is adding to the hip pathology eventually. So the question you will think in your mind, you know that this spine has to be tackled. She's 9, premenarchal. You also know that the hip has to be tackled. Now, since she's 9, whatever you do in the spine will not help the hip to remodel. Right? So when you plan your spine, day one, you should tell the family that in future, she will need a hip procedure.
Do you have the corrective length scanogram?
Maybe this patient may have a contracture at hip, adduction contracture.
That's what this patient was referred to me by a pediatric orthopedic surgeon.
But there is lower limb
Yeah, and he said, ki, right now I don't think anything I need to do.
Yeah, but primarily the spine, especially lumbar deformity with hip pelvic obliquity.
Yeah.
There is a suprapelvic and an infrapelvic cause. So like what Dr. Shah mentioned, you have to make sure there's no infrapelvic cause like a contracture or anything.
Yeah.
That's what you have to see for that. Is there any contracture? Because that is the only thing which you'll do along with the spine in this
I
patient.
think what Shailesh has very brilliantly brought forward is by getting us into a fighting discussion mode, is by waking you up from the post-lunch prenatal hyperglycemia, is that these kids with EOS are not the normal scoliotics which drive complete attention to the X-ray. You have to completely think out of the X-ray. These are cases where neuraxis abnormalities, abdominal syndromic associations, anomalies of renal or GI tract or cardiac anomalies take a precedence of treatment rather than definitive corrective surgery, which is the last thing to be thought of.
Let's see. Yes, sir. Yes.
Sir, halopelvic traction. Sir, before that, we should know, we should evaluate the deformity.
Yeah.
That's
So we'll-
correct.
yeah,
Give a traction
we'll
image. Traction image.
Yeah, we'll just proceed with the investigations, the bending. filling.
Bending. Bending don't give anything.
Yeah.
But why it's a question is that?
And now you see,
What is the CT
MR
showing?
was showing there is something happening at L3. Yeah, so we ruled out all these things, and yeah, she was a walker, and probably it was a old, long-standing, and that's as Vishal said, neuromuscular. It's mentioned as last in the list. These are the traumatic, old trauma or something, and it was not. We were worried. We thought of some tumor or anything, So we did a PET CT, and the PET CT also revealed the L3 collapse. And we were really taken aback because we were thinking something else, just need to do something small at that place so that we will be safe, nothing needs to be done. But it was not like that. It was a neuromuscular, high-grade thoracolumbar scoliosis with pelvic tilt. Yes.
Eosinophilic granuloma, which has all blood tests normal, just a solitary vertebral collapse in a 7 to 10-year-old child, which was the initiating factor, has led to a structural thing associated with a neuromuscular scoliosis.
Yeah.
So this is what we are telling. I mean, you have to investigate them no matter what you do. You must be looking at a beginning of a neurological deficit at this time. This child may be just in the beginning, the early part of neurological deficit, which may be coming across.
Why should you have fracture?
Yeah, it took almost 7-8 days for us to even just think. MRI? Yeah.
It's most likely, as you quite rightly said, Vishal, The vertebra plana is the onset. You may not find any neurological or syndromic neuromuscular abnormality with this guy. I'm not
but
seen the
it is
investigation,
described
but just looking
in
at that.
neuromuscular.
Even in neurofibromatosis, scalloping is described. Pathological
rare,
collapses, hemivertebrae, which are not congenital in nature, have been described with neurofibromatosis. Even with a tiny fibroma sitting there, it is described that a wedge-shaped vertebrae caused because of a neurofibroma pressurizing on the developing vertebrae. So this could easily be a structural effect of a neurofibroma. Osteomalacia, solitary vertebral collapse of this nature.
9 years old, only one vertebra involved.
Perhaps it turned out to be nothing.
And all myelo.
Yes, sir.
Perhaps he was negative.
Yeah.
Eosinophilic granulomas are known to be like that. They happen spontaneously. They heal spontaneously. They don't need any chemotherapy. And their biopsies after healing turn out to be absolutely normal, and they resolve and become normal vertebrae also.
Now the patient is here with a deformity.
Yes. So now you deal deformity. If biopsy is done, your oncologist chemotherapist reference is done. They know that there is no myeloproliferative disease.
Now
if you look at it.
That question which Dr. Shailesh is asking is that number one, would you fuse primarily?
Yeah.
Number two, if you want to growth guide, what will you do? Number three, how long or how short will you go? Next, will you take the pelvis? Yes, Shailesh?
Yes.
These are your questions. Will you take the pelvis? Because this is a lumbar curve. The lumbar curve. So lumbar curve, when you get them to growth guide, do you take the pelvis? Because like Vishal mentioned, you take the pelvis, you finally fuse to the pelvis.
Which are your end vertebrae?
Which you don't want. Yeah, that's it. Getting the lower.
So again, I would again think of not taking the pelvis, being a little more proximal than distal. But do we have a scanogram of both lower limb or a pelvis paralyzing X-ray like what Ranjith mentioned earlier, bending the pelvis and
We
bringing
have
it
done
parallel?
all the investigations. Right now, what I have shown, I got only important.
The distal anchors in these syndromic kids. One point, if you want to take up from this discussion, how do we define the distal anchor in syndromic kids? Do that kind of X-ray where your pelvis is parallel to the plate, and whichever vertebrae is getting parallel to the pelvis, that is your distal anchor. Be it a neuromuscular, be it a kid with pelvis involvement or pelvic obligate.
But high lumbar with neuromuscular, or you will not get that parallel thing.
I will no. I mean, it's surely possible.
I will avoid going to the pelvis at any cost. Because I know,
Because this child is going to go for a pelvic osteotomy later. I will try to limit my lowest in LIV to L5.
Okay.
At the most, if possible, L4. But I will try never to go to the pelvis.
Yes.
Your pelvis is here.
Yes.
The sacrum is sitting parallel. The L5 is sitting parallel. To
Yes.
The so if you can even L4, but let's say L5, if you can get an X-ray where you can show us a pelvis, you just have to correct the curve above rather than going to the pelvis as a corrective.
Okay. Point noted. See, we always, as I was talking, we always feel, वो आ जाएगा, ऐसा नहीं आता है. It's not.
No, with lumbar EOS. So what will be LIV?
It doesn't come like that.
It's very important, as you said, that you require a bending film. Unless we have a bending film, we don't know how much parallel the L5 or L4 is. So that is what is very, very important. There is no point discussing without we have that
It is there.
bending film.
It is there.
There seems to be some second pathology as well, not just a collapse.
And when this is a traction, it's bending. So whenever we have lumbar EOS, roughly rule of thumb, you end up in L5. And you should always avoid going to S1 or taking the pelvis. Because if you do that, you'll end up with a pelvic fusion, which you don't want.
And with L4, controlling the pelvis is difficult. With L5.
SK sir, your sirs.
Yes.
Sir, what will be your take on this?
Yeah, actually try to save, if the child is young, it is better to have one motion segment lower down. Okay. So I think that is important.
So you will go to L5.
L4. Yeah, L5. So 5S1 is open.
So this kind of fracture in a situation.
No.
Have you seen this?
No, I have not seen, unless child is very osteoporotic, and sometimes you get patients who are having real other metabolic problem, though not very obvious. You get their vitamin D and all these things, they are very low. So in that case, I think that factor is to be corrected.
On table X-ray.
But I would also say that even if it's bending, means that it is L5.
Let's move.
Sometimes this will become a per-operative decision also, because if per-operatively, if you don't able to horizontalize it, then you might have to think of pelvis. So L5 is the last thing because you want one mobile segment. But if it does not, pelvic oblique doesn't correct it, then you have to think.
Especially, sir, will you be happy doing there with a child who's going to need a future pelvic osteotomy? Because if she was 5, fine, we know that the pelvis might
try
remodel.
to avoid it, but if it doesn't come, then you will leave it.
I would leave it.
This might have to be a staged.
Let's move.
Staged procedure.
If intraoperatively, like Dr. Amit mentioned, if this curve is intraoperatively under anesthesia, my gut feeling says that the apex of the curve at the fracture may just open up, resulting into a shorter fusion possible in such case.
See, it
If
looks,
that is possible.
yeah, I always talk, we do a lot of this kind of different deformities, and it looks very easy when we talk and we see, it never comes like that. So it is very easy for theory and, but it is difficult when we are actually there. You just give traction, it moves a little. Though it looks like, open ho jayega fracture, it doesn't open up like that.
Totally.
You have to give a lot of traction. You have to just see what maneuver and where we will stop, whether you will consider anterior plus posterior or only posterior.
This is something that might be suitable for a staged. So you start with a vector because there is a costopelvic impingement that will stop any correction that you do with your growing rods. Start with the vector, stretch the thing out, and then you'll have a better idea of where your LIV for a growing rod will be.
Okay.
So right now, if you go for a LIV and put growing rods, you will stretch so far, and then the costopelvic impingement, the tightening of the tissues, soft tissues, will stop you from going after a further point.
Correct.
You've already impinged the L4, L5 pedicles.
Correct.
Why not just stretch it out as much as you possibly can with the vector?
Correct.
Leave it, relax. Then you might see that the pelvic obliquity is improving.
Correct.
Because the sagittal balance, the coronal balance is improved. Once the pelvic obliquity improves, then you will know whether to stop at L3 or L4. Well, L3 is
fracture,
involved.
we can't stop at
L3 is involved. So L4 or L5 or involve the pelvis.
In such a big curve, whether we just stop at just apex at L4, just to save the level, you can't. Yeah.
I think still it's a fair idea. I completely agree that maybe we can start with the first stage of distracting of the concave side between the ribs and pelvis and see as a second stage thing what definitive distal anchor could be. That is one way of looking at it.
Shailesh?
Yes.
Yeah?
Yes, Sandeep.
So I think in this case, although the X-ray looks very bad, I would agree with Vishal that we could consider this sort of an insufficiency fracture also. Because if you look at the rotation in the lumbar vertebrae, they are not rotated. There's hardly any rotation. And in a congenital deformity, we expect some amount of rotation in the lumbar spine also. So look at the pedicles, proximal and distal, and there's no rotation at all. So it's not a bad option considering that this could be an insufficiency sort of a fracture.
Yeah. The oblique takeoff is quite significant. Bharat sir.
That's what I'm saying. So I think we are missing something. I think there should be some second pathology. I have that feeling. I don't know.
No, we thought, but
so let's move forward.
Yeah, let's move forward. And we did a lot of discussions, and we planned for a posterior surgery.
Your plan for definitive fusion?
Yeah. And recent SRS guidelines at 9 or 10, in such cases, you can consider definitive fusion, which was not there earlier. Yeah. Because the options are significantly limited. And this is the lateral. And this is the post-op X-ray. We did a couple of osteotomies. Yeah.
So we are going with the working diagnosis that it is neuromuscular.
Yeah.
As many as
What was the biopsy?
Nothing.
Nothing.
Nothing. Yeah.
Second time biopsy done.
Yeah. On table also. Yeah.
Can you go back to flat section post-op?
Did not do anterior construction.
No anterior. We had to
Maximum correction happened at L3 level?
Yeah, at L2 to 4.
L2, L3 level.
Yeah.
Was the bone very soft when it was metabolic or was it?
It was not very soft, Ranjit. Yeah, not very soft. No. Yeah, but this is a very challenging thing, and yeah, we will have a lot of cases. That's yeah.
So if you really want to get this to correct, you can fuse the lumbar part. Yes, that's and get the thoracic to grow.
Means modification.
See, because this question, if you see the Carol.
We can only address L3 deformity and use a vector from rib to ilium.
As the guideline which was mentioned by Louis Carroll way back in the JPO article in early 2000s said that we have to achieve 18 centimeter thoracic height before you go for a fusion. In 2022, she wrote a review article studying all those cases and she's questioning, is it the right answer? Yeah. This is the right answer after 22 years. So he's not wrong in actually going and fixing it.
Yeah,
means her own article.
See, why to just try something which is significantly failed? We are just trying to modify Sheila by doing something which is not experienced by anybody. Yeah, and this is what is the latest guideline. Now they are straight away telling that this situation you should fuse it 9 or 10.
You see, my standard statement to all EOS, to all scoliosis is that you are a child with scoliosis. After surgery, you will be a child with corrected scoliosis. You are a child with corrected scoliosis. With EOS, I tell them you are a child with a scoliosis. After surgery, you are a child with a correct scoliosis, which will further need surgeries. So I don't know the answer when. You don't know the answer when. If you are prepared, let us travel together.
Yeah.
Pre-operative, the hips were normal.
Please.
Because
yes.
the hips.
Just comment on this. Still, there is a pelvic obliquity. Yeah. So, can we have one other option like a kickstand rod, where you can have one of the pelvis screws and distract on the concave
Sir, kickstand for pediatric age group?
No. This is just similar. I'm not putting it.
Jugaad.
Get a jugaad. So you can just distract it. Once you get that correction of the pelvis down, then you can put and stand.
Probably when he gets the pelvis, when the hip,
just a jugaad, it's not a kickstand.
when you get the pelvis correct, and now it might correct. When you have the hip is still non-contained, do you have a post-op pelvis X-ray? So over time, if the pelvis corrects or you contain the pelvis, that obliquity might correct, sir. Because the L5 he has left the L5 mobile. We will get 5-degree mobility there in the coronal plane. That will correct that pelvic obliquity. Yeah, kickstand is burning
Temporary.
bridges. I will not think of
temporary.
Yeah, kickstand is burning
You
bridges.
rightly said this
Temporary.
avoided pelvis.
Yeah. I think after this, if we give time and look at the pelvis, if the hip in this, mostly the pelvis will not remodel because she's 9. After 6 to 8, it doesn't remodel. So when you go for the pelvic containment procedure, this hip will
Patient
correct.
is from outside. She is stuck, and because of COVID, they didn't follow. But she's walking and.
At any possibility, I want to leave the abdomen in a young girl virgin. It has got better purpose than going for my anterior surgery. So I will not think of any anterior surgery in any, especially females.
Agree.
Shailesh sir, have you done the sickling test in her this patient?
No, but still.
Yeah. So I want to leave anything there, Virgin.
Yes.
Let's move now. I think.
Shailesh sir.
Yeah.
No, but you don't agree.
We have time for, or we'll just.
Shailesh sir,
summary.
have you done the
have
sickling test in this patient? Sickling test in this patient?
Every possible investigation was done. Each,
Because I have-
in Pune, each possible specialist visited this patient.
I have operated 11 years old lady with the same lumbar apex L3 pathological fracture and biopsy found to be a avascular necrosis due to the sickle. And yeah, that's
So it was diagnosed in retrospection.
yes.
That's a good point.
I think.
Yes, sir.
Shailesh, I'm told that we need to finish by 3, so we need to conclude now.
Yeah, so
Okay.
we have 10 minutes.
Summary statement, yeah. Or one quick case.
One more case. This is a young boy, 7-year-old. We have seen his video and progressive deformity. Head not centered, shoulder imbalance, right thoracic structural curve, rebump, cafe au lait spots. Now, this is just for quick. I kept it for discussion. We have not yet operated him. MRI is no intraspinal anomaly. I would like to ask 7, yeah.
Dave sir.
Yes, Dave sir.
Yeah, I think we would like to have the corrective film. Is there any corrective film?
Traction film.
Traction film, please.
Oh, I just got this much now.
MRI.
Everything
MRI,
is done.
MRI is normal. That's
No
what we said.
intraspinal neurofibromas.
No.
But there's a cutaneous neurofibroma. Large.
Yeah, cutaneous, yeah.
The large one is there.
Yeah.
There is no intra-abdominal neurofibroma either.
No.
Because
no.
we need to really.
No, that is because of the deformity, Ranjit.
Yeah.
That is not a neurofibroma. That is
There's
because.
no NF there. Only you can know by the
Yeah.
exam. There's too much thing hanging here.
Yes.
Seeing the clinically abdomen, it is not deformity.
It is not deformity. It is a
It
there
is
is
not
an NF there.
deformity.
Yeah.
There's a
There is
fibroma
some
there.
problem in the muscle, abdominal muscle. I
Lax.
think in such situation now, we should see the abdominal reflex. Unilateral absence of abdominal reflex tells you many things. Though you have,
Yeah.
you are going to do the MRI and all those things. But usually you don't get abdomen like this in even the lumbar curve.
So I have his video. I think I have shown it. I'll just play the video because we'll get a live relay of him. अरे चालू कर चलना.
Shailesh, we need to conclude. If you can have.
I will just take a quick note from one of you, Ranjith, Vishal, how you will proceed this boy.
Investigate in detail.
Yeah.
So, of course.
That is, of course, yes.
I think
Now,
all the
yeah,
decisions,
that's been concluded.
all the decisions based about EOS are whether you are dealing with a syndromic child, a neurological child, a fit child, an unfit child, has pulmonary reserves or not, has got renal cardiac functions intact or not, whether he is at the beginning phase of a neurological deficit, like very classically happens in spinal muscular atrophy. My seniors in my fellowship days have burned their fingers when they never were able to diagnose a spinal muscular atrophy, operated, no neurodeficit on day 1, in 3 months patient is para. How would you explain that? Because spinal muscular atrophy was missed diagnosis.
Yeah.
So despite a good surgery,
how
you
you
will
will
have a
plan
bad
for
result.
this?
This patient investigate. You don't have investigations. I can't
Everything.
comment here.
All is done MF. This
Yeah.
NF1.
Now, other things.
NF2.
One thing, yeah. So one thing very important is that these kids very often have on the concavities extra spinal neurofibromas, which are not only responsible for a teether at the apex of the curve, resulting into a short, acute C-shaped curve,
Yeah.
but are also responsible for spontaneous progression of deformity despite good correction. post-operatively, and also a responsible reason for implant failure and pseudoarthrosis.
Yes.
So you do a good anchor there, and the bone will be eaten in 1 year's time. That bone where your screws are there today will be eaten by the neurofibroma. So you have to excise those neurofibromas if they are present there or not.
And
And
what
this
will be the plan?
Is there a neurofibroma there on concave side?
No.
So it is just a NF1 with dystrophic curve with no neurofibroma on the concave side, no limb length.
CT showing no bar.
We have not done
Recent
CT.
pedicles, recent pedicles.
And traction film show any amount of correction?
Some amount of movement is there.
If it is only some amount of correction, the target will be to get the deformity to less than 60 degrees before maturity, and that can only be achieved by osteotomy. This is a case of definitive fusion as early as possible, and with the kind of deformity, I don't think any kind of you will want to delay the surgery, definitive surgery.
Yeah, but
Exactly.
Before I even plan anything, this guy goes on a halo curve. And in NF,
All curves, all EOS curves, try whatever you can.
in NF, the halo should be for 3 months, not 3 weeks or 6 weeks. 3 months of halo in NF. 3 months halo, get it to stretch out, then plan your surgery. Repeat your imaging then.
Agree. Completely agree on that. Yeah.
And with the rib cage.
So you in these cases, if they are rigid, severe curves, you have to do chevron osteotomies of the ribs. You have to do a oblique chevron osteotomy of the ribs at the apical levels, at least 3 or 4. In this case, because the apex is at D10 and below, the ribs are floating. You can actually excise the whole ribs there, and only 1 or 2 ribs may require excision there. They bleed like it. So they stretch out. I mean, in kids may the concave side may problem nahi aayega. Yeah. Closure, are you worried about the closure after correction? Abdominal thoracolumbar area, I don't think there will be a problem, sir. Unless it is thoracic spine, contractures in thoracolumbar spine, they just stretch out, sir.
I kept a couple of cases of plaster and all, but we'll just go with. So finally, just to conclude, delay surgery as much as possible. That's the most important thing. Document progression, and the CEOS classification is very, very useful in APR ratio. We should always follow that. Workup for associated anomalies. It's a race between deformity, progression, and growth. Balance and centralization should be our aim. Case selection, short versus wherever possible, growth rod is one important aspect. In congenital, we can go along with this. If there is a hemivertebra, we can do a short fusions. Double rods better than single rods. Keep sagittal profile in mind while dealing with the coronal deformity. Remember the law of diminishing returns for GR, and complications are a rule. So we have to be having all the possible things in mind. Counseling of the family is at most important, because this patient is not going to go anywhere. He's going to come back to you again and again, and he will not let you sit peacefully if you're not explain them on paper and in one-to-one discussions. It should have a good team approach. Take all possible investigations and any possible additional opinions if you want. Do not hesitate in shying away if you want help for these cases, because they are not routine standard scoliosis AIS. So I think, thank you very much everyone for a patient hearing and a great discussion with all panel. Thank you.
Thank you all panelists for the wonderful discussion. Thank you, Dr. Shailesh sir.
Thank you very much to all the previous speakers. Now would like to call on the stage for the panel Dr. Subir Jhaveri, Dr. Navneet Saraiya, Dr. SAILESH HADGOANKAR, Dr. CHIRAYU PAMECHA, and Dr. Jolan Patel. Please come on the dais. I would like to call Dr. Mayur Vala to talk on the rationale and challenges in management of adolescent idiopathic scoliosis.
Good afternoon, all. I think we are all listening all the things since the morning, and probably almost all the things has been covered in our talk or other. Still, I would like to go with some of the things which we should be considering in the treatment of the adolescent scoliosis. As the name suggests, it's a disease of a child of age of 10 to 18. It is more in the female than the male. 0.5 to 5% is the prevalence of the disease, and 80% of the scoliosis are of adolescent idiopathic. The management options available for the idiopathic scoliosis are the observation only, bracing, physiotherapy, and the surgery. The things which one would like to consider in the management of the scoliosis would be the diagnosis, the perfect diagnosis, the severity of curve, the type of curve, and the skeletal maturity at the time. As we go in detail one by one, the diagnosis of AIS is very much important to differentiate it from whether it is a congenital one or neuromuscular one, because as we know, the congenital is very rapidly progressing, the surgical management is always inevitable, and it is earlier better. And neuromuscular is very already gone through the thing, like it might require the consideration of the pelvis to take into the fusion part or not. Where in the AIS, the progression and management depends upon the type of the curve, the magnitude, the skeletal maturity, and many of the other things. Severity of curve, like as we all know, is like less than 20% of curve is on a lower breakout side. We might have to consider on the observation, and no active management would be required in AIS of less than 25 degrees. And 45 degrees is taken as an upper cutoff point, where the AIS above that would be required to consider for a surgical management. Type of curve, one has to know many other things before we go into the classification, like where is the apical vertebra, where is the end vertebra, what is CLVS, what is the plumb line, what is the neutral vertebra, what would be the stable vertebra, the rotation of the vertebra, and rib hump, whether it's there or not, whether the curve is structural or not, on the bending film or not. That is also one of the things to be required. Classification, we all know King and Mo and the Lenke are the classification we usually follow up to them. And most of these classifications are useful in academics and more of the communication rather than deciding any plan of the treatment according to that. We all know this. Lenke has classified into 6 variants with the lumbar modifier and the thoracic kyphotic modifier. Skeletal maturity, we take Tanner Whitehouse staging and the research sign to assess the maturity of the child at the time of the identification of the curve. And we know that 0 to 1 research is like having a good amount of potential of further progression of the curve. And where the research with the 4 or 5 is like we are almost near the maturity, and the progression of the curve would not be there. The challenges one would get in the treatment of the adolescent idiopathic scoliosis would be like how much we can predict the progression of the curve. Whether if the curve is of a milder variety, where the degree of curvature is less than 30 degrees with the research 0 to 1, whether we have to just go with the bracing and observation. If we want to go with the bracing, then how long we should continue with the bracing, and then what is the time we are into we go into intervene in that. Whether if the curve is moderate one, where is the degree is between 30 to 45 and the research is 2 and 3, we need to continue with the conservative treatment, or we go for a primary operative treatment. And again, if we are going to conservative, where to convert into an operative one. Is there any role of physiotherapy in the management of AIS? Only selective anterior fusion is good in that, or whether it would require end-to-end posterior fusion with the correction. And if we are planning for surgery, then what would be the LIV, what will be the UIV, what number of levels we are likely to go and fusion into that, and type of the osteotomies would be required to correct the cause. These all challenges would be probably one would face while treating the patient in the of AIS. And we hope that we're going to get answer of all these challenging questions in the proceeding lecture, and the case-based discussion by Dr. Kundnani sir. I would like Kundnani sir to come and then go ahead with the case-based discussion for that.
So probably the commonest of the scolies that we are going to ever see, 9 out of 10 scolies that you will see in, you will have to follow the principles that you're going to learn in next 1 hour. So since morning what you have learned, you probably better unlearn and you can leave those 10 cases and refer to the seniors out there. Yeah, neuromuscular, I mean, it comes to me, I send it to Shailesh, Tukar. Yeah, thank you, man. So whenever a curve comes like this to your clinic, I am sure all these questions run into everybody's mind. What kind of curve is this? Parents will ask only one question. Will this progress? If yes, how can I stop the progression? And as a surgeon, it starts tickling in your brain. What surgery, anterior, posterior, and what levels of fusion? So let us summarize everything that we are going to talk about only in these 5 questions that we are going to be talking about, the basic principles in AIS. And even before we start, I think these are the messages that are going to come forward in the next 55 odd minutes. Not all scoliosis are AIS. We have already seen some case examples. Not all AIS scolies progress. So just don't get tickled because you're seeing a scolio of 30-35 degrees. You may want to go and fuse. No, not all of them progress, and you can actually halt the progression if you catch them early. So try to catch these scolies early, start treatment as early as possible because bracing, casting does have some role to play. Type of AIS curves, I think there are only 3 types of AIS curves. Only 3 types. Whatever Lenky says, whatever King says, there are only 3 types of curves. One is there are thoracic curves. Second is there are thoracolumbar curves. And third is there are double or triple curves. Simple. And the principles of treatment are also according to that. Thoracic curves fuse the thoracic curve. Thoracolumbar or lumbar curve fuse the thoracolumbar lumbar curve. And when it comes to mixed double or triple, they are the dilemmas which we are going to be tackling today, which are purely based upon the knowledge of modifiers, which ones to fuse, which ones to leave. That's what is the principle of selective fusion. And remember, nothing surpasses the surgical technique, which has to be meticulous. Implantation has to be precise. CHIRAYU emphasized upon how to cannulate these screws. And also reduction maneuvers has to be learned precisely well. Release maneuvers in rigid and severe scoliosis has to be mastered well. Let's start with our first case scenario. Over to you, Dr. Shailesh. We are seeing a 14-year-old male child with a right-sided curve and has noticed recent progression 6 months, has got a right-sided hump. All the other parameters are normal, no obvious neurology, some skin patches there. Scolio of 90 degrees in the upper thoracic spine. What are the first thoughts that run into your mind?
I think these patients, when they come to us, they are already seen and treated locally. They already have given some exercise, physiotherapy, and when it's see, most important in such cases, when the patient comes to us, X-ray will be secondary. First is that visual impression, whether this patient really looks deformed. If he's looking deformed, sometimes we have patients where there is significant deformity, but the curve is not much. And there are some cases where there is, clinically you don't see much, but the deformity looks quite significant. So in this, both the things are, there is a deformity clinically as well as on X-rays. So I need to understand better by doing a couple of X-rays, the bending films, the traction films, and maybe an MRI.
Yeah, so Shailesh has heard me very, very clearly. Investigate. Investigate every case of scoliosis to the greatest possible detail. Don't just assume कि ये scoli है, मेरे को करना आता है, मैं करूँगा. No, you cannot do it unless you are investigated to the finest detail of every deformity. Subir bhai, what are the primary thoughts? What kind of curve this is? How would you want to classify this case in Lenky or King's? What is the best classification you follow for such cases? CHIRAYU, meanwhile, while your mic works. Yeah, sir. Lenky. So for this case, you would use a Lenky curve or you would use a right thoracic?
It's a right thoracic, definitely. But somehow I'm not able to see clearly. Is there a regular curve or is there something, some other sort of a bony bar there? Is it the same sternum coming there?
Yeah, abhi yahi hai, sir. Patient aaya first time clinic.
But then there is a mismatch. Is that the AP standing X-ray?
Yeah, it's a AP standing, PA standing X-ray.
Because there's a lot of truncal shift on the patient, which is not visible on the X-ray.
Yeah, yes, you're right, sir. All this is there. Kaun sa classification, sir?
So, fir bhi Lenky. I will still go with the Lenky classification.
Jwalan, you are raising your hand. What kind of classification?
Can you go to the first slide, please, sir?
Sorry?
On the first slide.
Yeah.
So my first thought is, first thought process start with the first sentence of the slide. He is a male patient, so it is unusual. Second thing is the right side curve. Third is the pain in the mid back since 6 to 8 months. That is the third striking feature. Fourth is the some skin patches on the chest and the back.
What does
So
it
these
allow
are
you?
the 4 striking features on the first slide only that you should worry that it is not a idiopathic curve. So you should first think about the non-idiopathic reasons first.
Very important. I think we must understand that not all curves seemingly idiopathic are idiopathic. There is a secondary cause more often than not. And remember, idiopathic is a diagnosis of exclusion. Unless and until there is a primary cause totally absent on your detailed evaluation, clinical and radiological, it is not a idiopathic curve. And remember, Lenke and King's classification are applicable to only idiopathic curves. Only idiopathic curves, that also adolescent idiopathic curves, not EOS, not neurofibromatosis, not congenital, not syndromic. King's and Lenke's principles of management and classification and communication is primarily meant for adolescent idiopathic curves, and adolescent idiopathic scoliosis is a diagnosis of exclusion. Not every curve is a AIS. So Chirayu, now we are dealing with a neurofibromatosis.
Yeah, it
type
looks
of
like a
curve?
neurofibromatosis.
Yes.
I think what he said was right side. Usually most of the AIS are right side. So
Yeah.
right is a positive feature.
True.
But then there is a proximal thoracic curve also, and looks like a bar. And then on the clinical picture, he has some spots which looks like cafe
So
au lait spots.
basically it is not idiopathic curve.
It doesn't look like.
So it is a case where SHAILESH principles will come.
No, your principal, investigate.
Investigate. Why is it important, Shailesh? Why this fuss? I've been shouting about this: investigate, rule out if it is AIS or non-AIS. Why this fuss about differentiating them? What is the difference clinically or management protocol wise?
A lot of things are important, like in congenital, if you see, there is a rapid progression. If neuromuscular, there are other factors like sarcopenia or muscle or bone quality. Everything changes. If it is standard AIS, then we have a different bone parameter. So all these things are very, very important to understand what pathologies that child is having.
Why?
For treatment.
Exactly. Ranjit, would you like to highlight why for all of us it is paramount to differentiate whether this curve is idiopathic or not? Simple, one single line answer.
Idiopathic behaves in one pattern. All the others behave differently.
The principles and guidelines, whatever we know today, are purely predictable natural history for idiopathic ones. For all the non-idiopathic ones, there are no rules which are fixed. There are no guidelines which are fixed. They are all case-to-case based challenges. And all since morning, what case-to-case based challenges we saw, we were almost fighting on the earlier case because none of us had a single line answer ki isme ye karna chahiye, because every case is different. Whereas in AIS, the guidelines are laid down absolutely clear. They are written in rules. What are the upper instrumented level? What is the lower instrumented level? How much correction will you get? Whether it will progress or not? How much progression do you expect? What are the growth parameters? Which are the ones which will progress and which are the ones which will not progress? So it is differentiating paramount feature that you should find out whether it is AIS or not. Dr. Amit, can you please tell us what are the typical features on clinical? Like this patient, Jwalant caught upon by clinical examination, कि इसको skin patches hai, he's got right-sided or congenital bar was seen, and so we came to conclusion it is atypical non-idiopathic curve. What are the clinical features of a typical idiopathic curve?
So typical idiopathic curve, if it is a thoracic, there will be a thoracic round simple hump with apex at E9. You will have a right shoulder up, left shoulder down, which is typical thoracic. And you will have a hump which is seen there. The lumbar curves on both the sides will be seen nicely. Maybe on one side it is more, one side less. And the pelvis maybe depending on where the curve ends. So
very
that's,
important. So round slopy curves which are not acute, not C-shaped, have no skin parameters which are abnormal, no limb length discrepancy, no kyphosis, no skin patches, AIS is level, no pelvic obliquity, only then they are AIS typical curves. Navneet, can you please highlight about when does it raises your antenna that this is not AIS, boss, clinically and radiologically, features which raise your alarm that this is not AIS?
So the first thing that comes to mind is when the patient walks in, how old is the patient? So when the curve is picked up quite early in the age group, then it is more leaning towards being either congenital, neuromuscular, or syndromic, less towards the AIS. The AIS are generally picked up between 10 and 12 when they start to grow. When the growth spurt happens, that's when parents or teachers start to notice, oh, there's something wrong. They do a scoliogram.
Very important. When was the curve noticed? A simple question to the parents and you'll get to know whether it's a EOS or a AIS. It's a neurofibromatosis or something else. Yes, Dr. Shailesh, please add on.
Yeah, the first growth spurt is up to 5, and then in juvenile, it's slightly slow up to 9 or 10. And then again, as rightly said, 10 onwards, they suddenly start rapidly progressing.
Right. Dr. Subir, would you like to add upon some radiological features that on X-ray, oh, no, this is not AIS. Any X-ray finding that alarms you know this is not idiopathic?
So typically the bilateral rib you need to see.
Yes, rib cage, if there is a gross asymmetry.
If there is any significant acute angulation, which does
acute C-shaped curves are a rarity in AIS. So if you see a 6 vertebra curve of 90 degrees, you know a acute C-shaped curve is not a typical AIS. Yes. Penciling of the ribs, scalloping of the vertebrae, kyphosis. If you see a kyphosis, all idiopathic curves are known to be hypokyphotic. They are lordotic curves. So if you see a kyphosis, either a thoracolumbar junction, and Lenke has picked it up, that any curve which is more than 10 degrees at a segmental level kyphosis is probably not dealing with AIS. You have to give a different modifier for them, and the principles of management completely differ in them. So
just to interrupt you, yes. I'm sorry to interrupt you, Vishal. Majority of the times you can pick up that this is not an AIS even before you come to an X-ray.
X-ray.
Right? So when you take a thorough medical history, birth history, developmental history, do a neurological examination, do a functional assessment, 95% of patients with syndromic or neuromuscular, you've written everything there. You can pick them up. And then all you have to do is to just confirm that with an X-ray, just to quantify what the problem you're dealing with, and then do any additional investigation, even if you have slightest of the doubts. If I have slightest of the doubts, my first port of call after the conversation with the patient would be a pediatrician. I'll get the pediatrician involved, because it's very important that once they start to get down the road of non-AIS curves, they're likely to need pediatric input one way or the other, gastrointestinal, neuromuscular, etc. So up until the point of X-ray, I've sort of ascertained that this is not AIS.
Very important point. This is what is highlighted all about good history taking, meticulous clinical examination. To be a scoliosis treating team member, you do not necessarily have to be a scoliosis surgeon. Whether you operate on scoliosis or not, but treating them well in time, picking them early when they actually require surgery. ASSI has actually started scoliosis screening program to pick up these cases early, purely based on the principle that if treated or caught early, many surgeries can be averted. The morbidity of bigger surgeries can be averted. You may actually can treat these patients with either simple bracing, or you can pick up grotesque deformities from happening in future. And this is easily possible in your clinic if you see a tiny curve or asymptomatic curve, or someone who's got pain in a male patient, kyphotic curve, skin patches, neurological examinations abnormal, limb length discrepancies there, or a simple arm span being bigger, or a tall patient with long fingers, you know you're dealing with a syndromic kind of scoliosis there. So these tiny pictures in your clinical examination will tell you what kind of curve are you dealing with. And it is very important because atypical curves progress rapidly, have no principles to follow. Koi iman dharam nahi hota hai. They don't follow any classification. They don't follow any guidelines. They are bound to come back to you. And the counseling of the patient regarding your complication rates. I spoke about a spinal muscular atrophy patient, neurofibromatosis patient. We saw EOS patient of 10 years old child. All these patients are bound to have far more number of complications and unpredictable course, even when you're treating them properly. So it is very important to rule this out. And remember, your clinical examination can really find out 90% of cases, like Dr. Navneet just highlighted. So to summarize, MRI is again very important and absolutely a rule whenever there is any atypical sign or symptom present. In my practice, so Dr. Suveer, when do you do MRIs? Do you do it as a blanket investigation in all scoli curves, or you wait for atypical signs?
Well, typically, I would not do as a blanket. If there is a slightest of possibility that there could be a congenital anomaly, if there is a slightly altered neurology, if I see a skin patch or maybe a hair tuft, something like that, that alarms my mind that this probably is not an AIS, then probably I would want an MRI.
Chirayu, what kind of investigations do you propose to these patients who have come to you? And
No,
when
I
MRI?
would do a screening MRI for all patients.
All patients.
Yeah.
Yeah. Any specific reason for that? I think you
There
have
are
published some
sometimes
paper.
syringe, there are sometimes spinal cord abnormalities, even in AIS. I would do that.
Shailesh.
Yeah, traditionally it is said ki why you need MRI, but I think nowadays it's different now, and we cannot later say ki I should have done that at that time.
Right. Dr.
So-
Srivastava, you come from KEM, and what are your indications for MRI, or do you do as a blanket treatment?
Yeah. So I'll be very honest with you. Earlier, we did not use this modality and we used to do just plain X-ray. But if you think now recent literature, it is worldwide proven that incidence of neural anomaly in AIS is almost 13 to 20%. Some of the centers, they are putting even 27%. So I think there is no harm in getting one MRI.
Right.
You are
let
not
me
going
take a-
repeatedly,
Yes.
but you
Very
have to
important
do
thing.
one.
Let me take a poll here. How many of us do MRI as a regular measure of AIS, proven clinical AIS patient? So I think the thumb rule has been made clear. Any patient with a deformity, do a MRI screening at least. Neuraxis abnormalities can be picked up early. However, in an atypical case, how many of us would do MRI? Let me have a show of hand. 100% of them. Atypical cases, the chances of having neuroaxis abnormality is 50-50. So if you're not doing MRI, you're missing upon something gross. And that's why rule out what kind of scoliosis are you treating, what kind of principles will apply to them, what kind of investigations you are supposed to do, what kind of counseling you have to do, what kind of progression you're going to look at. And all this will come purely by, like Navneet highlighted, clinical examination and early radiological pickup on a X-ray, and you will be able to know what patient are you treating with.
Yeah, Vishal, I just want to interrupt here. A lot of people, patients ask whether 1.5 or 3 Tesla. What's your answer?
जो घर के सबसे बाजू में हो, जो सबसे सस्ता करे और जो स्क्रीनिंग जल्दी करके दे. And remember, I'll again bring this fact to you. Tethered cord syndrome, what we often as spine surgeons miss out, is a very common entity, also a cause of atypical scoliosis, can easily be missed on a screening examination. So whenever for scoliosis I am doing an MRI, I'll always say T1 axial images of lumbosacral spine area. Why? Yes, Dr. Bharat. Yeah. So T1 axial images of lumbosacral area. Dr. Luhana will highlight. Dr. Luhana, when you look at a tethered cord, why T1 axial images?
Yeah, T1 is very important. The fatty phylum is one of the very common cause of.
This
and
is a
fat would be
simple,
differentiated.
small finding which all orthopedicians can pick up, that in a MRI scan of T1 axial image, if you see a fatty dot on T1 axial, you know you are dealing with a fat inside the dural sac. And a fat inside the dural sac is not a normal finding. You are looking at a tethered cord due to fatty phylum, right? Dr. Luhana?
Yeah, yeah,
Okay,
perfect.
Dr. Bharat.
Just to add to Dr. Shailesh's comment, if those who are not married, find the spouse who is radiologist. So we are to be honest, you know, we have Ajay's wife. She's radiologist. And
Ajay,
we honestly,
does your wife have sister?
Yeah.
Is she a radiologist?
And honestly, it has made the difference in the practice.
Oh, can you adopt me?
It has made the difference in the OT. In the,
I think it is very important. A lot of
Yeah.
patients, they ask, you know, because of various financial constraints or someone is giving them some concession somewhere. So I don't think 1.5 Tesla MR does a bad job. So
Absolutely
that is
not.
what I feel. It's a good 1.5 MR is. Yeah, 1.5. So don't keep it in mind. Nahi, nahi. I've seen 3 Tesla hi karna hai. Some orthopedic colleague, because they need it for them.
Okay. I have some very, very interesting case coming up,
For
which
the
is mixing up
shoulder
with
and
Shailesh ka
knee.
second case. It's a 9-year-old female with a reserve
Yeah.
1. And this time, ASSI, Association of Spine Surgeons of India, has started a scoliosis screening program. And this kid of 9-year-old female, 9.5 actually, going to be 10 very soon, was picked up during incidental screening by a small rib hump, went and did a X-ray. And there was no obvious hump found there, but on Adam's test, there was a slight hump with a scoliometer showing almost 16 degrees of tilt to the left with right-sided hump. No secondary features are present. Now, from here on, we take it granted that all of us clinically will be able to differentiate a typical from a atypical curve. So this is a typical curve, 36 degree from T5 to T11, right-sided curve in a 9-year-old female. Jwalant, what is your take on the question number 1? Will this curve progress or no?
Yes, sir. She is definitely in her early growth phase. She has not reached up to the peak height velocity. So this curve might progress.
Are there any specific markers to know whether this curve is going to progress or not? As a father, I am asking you, Doctor Saab, मेरी बेटी का क्या होएगा?
Yes, sir. She is rises 0, 9-year-old female, 36 degree. She has not reached up to the menarche also. So
right.
2 to 3 years still pending.
And now I am super panicky. As a parent, you have told me that this deformity is going to increase. Dr. Subir, I have come to you for a second opinion. Can you stop the progression? Dr. Jwalant says it is going to progress.
So there is no way to halt the progression, but it can be slowed down, or at least we can try and brace it till we get her to at least her menarche, at which time we may have to consider and actually keep it under observation.
Even
every
in
6
idiopathic
months.
curves, thank you, Dr. Subir. Even in idiopathic curves of mild to moderate nature, you have to still follow the principle of delay the definitive surgical fusion to as late as you can till the skeletal maturity. Is that right? Is that the principle we all follow?
Absolutely. We try and
Delay the surgical definitive fusion surgery as late as possible because of multiple points. Cor pulmonale was one among them. Development of lung is another. Trunk limb asymmetry. The earlier in the life you do surgery, trunk limb asymmetry may still be bothersome for the kids, and so delay it. So Chirayu, what would you do here? Bracing?
Yeah, bracing.
What kind of brace?
I'll do a TLSO, a thoracolumbar sacral orthosis, and a corrective one.
Right. So bracing is one option. Is it effective, doctor?
Yes, it works. Yes. Definitely.
What is your bracing protocol? My daughter wants to know about it.
So the bracing ideal protocol will be to make the child wear it for at least 22 hours in a day. But usually that doesn't happen practically. But even if they wear it for 15 to 16, and if the child is very cooperative, then you can actually go for a night brace. And it actually gives 12 hours of bracing in the night.
Right.
So I think that's a...
So TLSO brace, 16 ghanta Dr. Saab ne bola, but my daughter is a basketball player. She cannot wear it for more than 10 hours. She has to go to school. How do I manage this? Can we not do physiotherapy over Ramdev Baba wala?
At this stage, at the angle of 36 degrees, physiotherapy alone is unlikely to stop it from progressing, particularly if she's a reserve 1.
Right.
So that is to be told very clearly that physiotherapy itself is unlikely to arrest the progression of these curve.
Physiotherapy alone may not halt the progression of the curve. Bracing is known to be effective. However, there are rules to it. You cannot just give it in a casual manner. Either you use it in a particular manner or you please don't use it. Half-hearted use of bracing is a pseudo-confidence. Please don't give it to the parents.
In terms of practical problems, I have not much of experience of putting braces in India, but generally it's a custom-made brace.
Custom-made brace, very important.
Because TLSO sizing-wise, one is very difficult to fit every child to a standard TLSO brace.
Right.
So a custom-made brace with Velcro, which the patient herself or himself can take on and off,
right,
is important. For the first week or two, get them to do a brace diary. What time was it put on? What time was it taken out? For a week, just for you to see what the compliance is. And then after the first X-ray, you see the progression. If the brace has arrested the progression, then you can give a trial of night bracing. So you asked about basketball girl who wants to play. I would say for 2 months, you'll have to give me 2 months in brace.
Right.
After that, I'll tell you whether you can take it off at school or not. But night bracing has been known. There's been a randomized study that it is almost as effective as day bracing when there's a compliance issue.
Very, very important point to take, Navneet. Thank you for bringing it up. Shailesh, quick comment.
Yeah, I think, again, one important aspect in this is both the things. Normally, we prefer the Scoliosis exercises where it's normally sent it to the physiotherapist and they do that combination of derotation, elongation and stability. So that is important. Chest exercises for these patients. These are the very, very important things which they should do. That's number one. Second is the brace. We prefer that at night time. We have tried, but it's very cumbersome for the child to wear and sleep. And in Indian conditions, in the Western world, maybe in Europe or US, whether the weather condition is different, they really can be very comfortable wearing it. In country like India, it's not possible to wear 20-22 hours because you feel like removing your shirt in summertime. So it's practically not feasible in most of the situations. So I think a daytime well analyzed and explained to the child and the father or mother is very, very useful and important. And custom made, tailor made, like modified Boston brace can be a very good option for this.
So I, in my practice, use Boston brace. Thank you so much, Shailesh, for bringing it forward. There are protocols for bracing. There are specific indications for bracing, and there is a principle to bracing. Bracing is primarily meant to prevent the curve from reaching to 60 degrees before the skeletal maturity is observed. That is the principle. This is the counseling that you have to do the parents, that jab tak bacche ka skeletal maturity nahi aata, tab tak continue karna padega. You will have to wear it for at least 12 to 22 hours a day, ideally whole day long. At night times can be removed. However, night bracing, there is literature coming up. It only halts the progression, doesn't reverses the curve. And there are different type of braces. Boston is one of them. And nowadays there are these Spencer spine core braces that are available, which not only push the curve inside, correct the deformity and hump, but also allow mobility there. Okay, coming back to God's own land, Dr. Ranjith. In God's own land, there are these acupuncture and cupping methods and pinning and needling. A lot of my patients come and say, Doctor, udhar Jindal mein karke aaye kya God's own land mein? नहीं किधर जिधर भी उधर केरला में क्या है उधर ही
जब मसाज होता है मसाज स्कोलियोसिस जाता नहीं.
And non-ethical, non-scientific treatments must be condemned openly and with a wide mouth out there. You have to tell them this doesn't work, because the more time they delay in initiating the treatment, the more they are making themselves prone to a bigger surgery. Appaji, quick comment on, we have been hearing about some early MISS surgeries, non-fusion surgeries. What is the role in such early mild to moderate scolies 30-40 degrees?
So bracing till the child is mature.
Do not attempt a surgery in a child who's less than 45 degrees of curve. Please try to avoid any definitive corrective surgery. Yes, there is a growing evidence of non-fusion minimal invasive tethering surgery of such patients. However, it is not meant for AIS cases. Those are the cases where EOS comes into picture, and if you have diagnosed the EOS, only then non-fusion tethering has been proven to be of efficacy. In AIS cases, early cases, please don't attempt that. Now, quickly, Dr. Navneet or Ranjith, what is your bracing protocol? How do you follow these patients whom you have braced, and what kind of X-rays you do in follow-up? When do we know it is not working?
So the time is same, like 22 hours a day, 1 hour out of it. And my follow-up protocols are at least for the first month, I call them more frequently to reinforce that they wear the brace. Then I call them after 3 months, 6 months, X-ray only at 6 months.
Please do not repeat X-rays. These are poor kids, girl, child. I would hate my girl to be exposed to X-rays so often, particularly knowing that she is probably going to require far many more number of X-rays. Please don't do bending X-rays every time, apilateral X-rays every time, particularly when a child is on brace. Bending X-rays have meaning only when you are planning a surgery. Dr. Amit.
Yeah, so but one X-ray post brace is very, very important.
Very
sometimes, important. Yeah, because sometimes the brace will increase the deformity if it is not
in the opposite
properly,
direction and wrong place.
Yeah.
Very important.
Good question. Now, what do you say is a correct brace? So any brace, you should have at least 50% correction post bracing with brace standing X-ray.
Right. So Subir, when would you stop bracing treatment? So at 6 months, patient has come to you and has seen that despite a good bracing, which was well fitting, pressing on the hump at the apex, the degree of magnitude increase is almost 8 degrees in 6 months. Would you continue bracing for more or stop it now?
So first, I would like to evaluate whether the brace is really been worn.
Very important.
So compliance is very important.
Okay.
If there was good compliance by the child and still the brace has not worked, then I can give one more chance, maybe for 6 more months. We can continue the bracing and still observe it for 6 more months. If it continues to grow, then the child may have to undergo little early surgery than
Right.
what I would have otherwise planned.
Right. Shailesh, what are the other risk factors for bracing not working where you would not attempt bracing? Some of them I have highlighted, if you agree with them or want to add to them.
Yeah. No, I think that we are having very limited options. When the bracing is failure or patient is not compliant, then this is going to progress.
So for what is your cutoff point where you would want to depend upon surgery now? 45 degrees is.
Yeah, I think reasonably fair. 45 degrees is even my cutoff point. Sometimes I tell them to, again, additionally, simple thing as swimming, I advocate. I don't know, but in practice, I tell them to If they are not swimmers, they should do swimming, because that gives some kind of a balancing for these kids.
Right. Navneet, any idea what are the other options other than bracing in these early kids, 36-degree, 40-degree curves, not definitive 60-degree curves? You want to buy some time?
People have tried traction, which hasn't worked, intermittent traction, which hasn't worked, physiotherapy hasn't worked. And particularly with this case, if bracing has failed, I personally do not have a lot of experience of any other conservative measures than bracing. With this particular scenario, if the curve is increased by 8 degrees in 6 months, in spite of bracing, it's a rapidly progressive curve.
Right.
It is likely to progress.
So Chirayu, now you know that this is a rapidly progressing curve, but the child has yet to attain skeletal maturity. The curve is also not into the 50+ curves. Would you like to think about other options, or you want
definitely.
to wait?
I would rather operate a 70-degree curve at the age of 14 rather than operating a 40-degree curve at the age of 10 or 11 or a 45-degree. So I would buy time. So we've tried the conservative options. So then there are options like tethering, or as we do like growth rod, as was shown, can be really done for, and try and buy time, because a definitive surgery at 14 will be better.
Ranjit, quick question to you. Now we have a child whose bracing is not working. What is your threshold cutoff point, age-wise and magnitude of the curve-wise, where you will start thinking about a definitive surgery?
Brace has failed. Patient has got imbalance.
10 degree of progression.
Patient has got more than 10 degrees, 6 months, 5 degrees, 6 months, and there is significant spinal imbalance. Reserve 3 or 4. I go ahead and think about definitive fusion.
And any experience about detethering, minimal invasive thoracoscopic?
Zero.
Appaji, please highlight. I mean, this is something that is this is a stopgap arrangement. Yeah. So this is a stopgap arrangement between where bracing is not working versus a definitive surgery is still awaited. It is not yet come. That's where the role of non-fusion, tethering, selective curve correction is making its own place. Other than this, there is no evidence where they are really of any benefit. Quick comment and we move on.
One question regarding the skeletal maturity assessment. What do you think about the role of elbow X-rays above the pelvic X-rays regarding the
Shailesh? Yeah, you can do that. You can just check the wrist and elbow.
So the markers of progression are plenty. Triradiate cartilage, Reser are the most acceptable and usable ones. They are very objective to assess and more reproducible in a common population. But hands, Tarlow scores, elbow X-rays, and even other parameters come to us very handy to really predict markers of progression. Subhi, do you use any other markers of progression or the regular Reser?
Reser is good.
Yeah. Perfect. So I think the message is clear. There are definitive markers of progression. There are plenty of them. At least follow some. Try to catch these patients early. Start the treatment early. It necessarily doesn't have to be a surgery. Bracing is useful in these midterm, mild to moderate scoli curves. Only when it doesn't work, where the definitive surgery should be thought of. However, definitive surgery should be delayed as far as possible. And definitive role of growth modulation in AIS patient comes into picture when the definitive correction surgery is awaited. Now, moving on to my next.
I just wanted to talk, just go on the back previous. Yeah. So this is definitely a good option. This looks like the tethering, but so far the problems are if the tether breaks, how you will manage. So these are the things which are unanswered, and most of them are telling, no, it never happens. But there are cases which it is happened, and then you are in a little problem.
Yes.
So this is still in a experimental
Very
stage.
evolving phase.
Very few people are doing. Not too many.
True.
Yeah, as Appaji.
Yeah. Yes.
And
this is one thoracoscopic option. I just mentioned it to make a completion note here quickly, and then we move on to a very interesting case. I have zero experience on that. Okay, let me just bring in my another very interesting case. Now we are boys. We like to play with toys. Let me bring in some implant-related issues. How to choose the levels in a 13-year-old girl has attained menarche a year ago. Has got a right thoracic hump, gradual progression noted, right-sided rib hump. Mother and the child is more worried about the left-sided lumbar flank, and it's a idiopathic curve. It is not a atypical secondary curve with any other features, and all the other parameters proving that it's atypical are ruled out. Chirayu, starting with you. What kind of curve are you looking at? What are the primary thoughts in your mind? The questions remain the same.
And this is like a double curve. So there is a primary thoracic curve and a lumbar curve is, I think, almost as equal as, I haven't seen the measurement, but it looks almost equal. And the lumbar modifier is a type C modifier. And riser-wise, this is...
So can you please brief us, for all of us, what is lumbar C modifier and what is the importance in your planning?
So Lenke classification, although there are breakers, but still it is a useful classification to communicate and to decide. So there are three curves. There is a main thoracic curve, there is a proximal thoracic curve, and a lumbar curve. So in this, if the lumbar, when you draw a central sacral vertical line, the bigger one, the X-ray, yeah. So if you draw a central sacral vertical line, and if the apical lumbar curve, and yeah, exactly. So since the apical body is L3, I think.
Yes.
Yeah. So L3 is outside on the outside of the line. So this is a type C modifier. If it touches the pericle, then it is type B, and if it goes through the middle, then it is a type A curve.
But
so these are the lumbar modifiers.
Subir, what is the importance of this? Why is this so important? Chirayu is obsessed about.
If you want to do selective thoracic or something like that, then you may not be able to, because you need to get this curve into the zone of stability.
Right. Wonderful. So I think this one simple line helps you to decide what kind of surgery you are planning already, whether selective or not. We'll come to it. Neeraj Vasavada is here. Neeraj is here. Yeah, Neeraj, what is your cutoff for doing a surgery in a scoliosis patient, whether it is magnitude, whether it is age, whether it is decompensation of the child, or a combination of all?
I think combination of all.
So, okay, would you like to highlight like a hypothetical?
Anybody who is have imbalance, significantly truncal imbalance, shoulder imbalance, cosmetic, because adolescent idiopathic scoliosis is mainly purely is a cosmetic deformity. So any disturbed cosmesis, you require surgery. So it is not the angle. Sometimes angle is more, but patient is quite balanced. So,
compensated.
So you need to take parents into account whether you really want to straighten the X-ray or you want to straighten the child. So
very important point. Shailesh, I'll put a hypothetical situation. That's the case that we have up there. 80-degree deformity, but a compensated child. Whereas this is the curve here where only 60-degree deformity, but the child is decompensated. Which one will you operate first? Which one is more likely to progress faster?
I think the one which is with a 60 degrees deformity.
The decompensation happens with a lower deformity if it is in lumbar lower area, and those are the curves which tend to progress more, are cosmetically completely unacceptable, and those are the curves. And that's why only magnitude, only age, remaining growth potential is not an alone factor in deciding the indication for surgery. The indication of surgery is multitude of such factors. Subir Bhai just mentioned that you have to take into consideration all these factors while you're planning for a surgery in such patients. Now, what are the principles? Jwalant, would you like to highlight? What are you trying to achieve in this child? This is the 80-degree curve in a child with double kind of curve. What are the goals that you would want to achieve? Is it correction of the surgery, or is it stable sound fusion, or you would want to correct the deformity straighter from a cosmetic perspective?
So, sir, the goal of any scoliosis spine surgery is to have a balanced spine, well balanced, the optimum correction with the level shoulder and the level pelvis.
Very nice. Dr. Subir Bhai, what is your aim? What is the expectation? How much degrees would you want to correct? Because we as surgeons are aggressive. We can correct it to 0 degrees.
But typically, the aim of correction and what we can achieve with smooth and safe surgery is to achieve a 50% and a balanced curve, the proximal thoracic and the lumbar and the main thoracic and the thoracolumbar should be well balanced.
This is one of the most important message we should carry home from here. The aim or the goal of surgery is not to have a straight spine. It is to have a compensated body from outside and a stable spine where the head is centered on pelvis. The shoulders are parallel to the pelvis. There is no pelvic obliquity and the shoulders are absolutely level when you see it from the front. This is the goal, and that can be achieved by 50 to 60% correction, and that is the goal that you must achieve. Chirayu, what do you think when you plan a surgery? How much do you pre-operatively plan that I want to correct 60%, 70%, 80%?
I think when you mentioned that the mother was more concerned about the lumbar prominence. So still I would be more towards giving a mobile lumbar spine than a fused thoracolumbar spine and a stiff spine. You may undercorrect the thoracic curve, but there are criteria, and if this child with counseling, then it will be better to do a selective surgery and have a more tilt towards selective surgery, other than, because this is a C-shaped curve. I mean, a S-shaped curve. Okay, if there's a long C or another one, then it's different. But in a S-shaped curve, I would definitely have more weight towards going for a
Navneet, what is your take on, as a father, I want ki hump thoda andar jana chahiye. Doctor, I have read about thoracoplasty. Would you not push the hump inside completely to make it a flat back there?
So I would tell the patient, parent, that pushing the hump is not going to correct the hump. What is going to correct the hump during surgery is my derotation of the vertebra. So long as I derotate at the apex, the hump will correct itself. So you may notice after the surgery that there's a little bit of hump remaining, but if I have been able to derotate the vertebra properly, that hump will disappear in about 6 months to a year's time when the girl will grow. Because the other side, which is going to then come up and balance out the rib hump, is going to be the more driving factor.
Very important points. Please don't try to correct the spine absolutely straight and try to correct everything cosmetically from outside, because there is growth remaining of these kids. There are curves which are known to correct spontaneously. That is the principle of selective fusion, and same applies to the ribs also. You just correct by derotation and correction of the deformity, which is reasonable, rational, and safe. So it is very important to have a safe correction, which is 60 to 70%. Anything more can put the child into danger, even on neuromonitoring. And that is why correction of safe deformity correction is very important. Shailesh bhai, anything
Just one
else?
more point, if I may add, Vishal. It's important to tell the parents how much is the minimum you're going to achieve.
Exactly.
So it is well known that lumbar curves, non-instrumented curves, self-correct more than the thoracic curves. So you have a bit more leeway in the lumbar curve. So principle of surgery here is to achieve a balanced spine. I would like to add to that with the least number of fusion levels.
Very important. So that's one of the goals to achieve. Preserve the lumbar spine as far as you can, but also remember that type C modifiers put you into a fix, that a type C modifier can actually lead to a addition or a decompensation of the spine, and that's why we're very skeptical in ordering a selective fusion. We'll discuss about it. Let us just move on.
And one further final point to that, there's a research which has come out that if you achieve correction more up to 60 degrees, so 60% rather, patient will be pain-free in the future. Anything less than 60% and there will be pain.
Right. What other factors comes into your mind, Shailesh bhai? Do you do it with neuromonitoring? What is the inventory pre-operatively that you keep? What are the implants that you keep?
Yeah, nowadays neuromonitoring is a must, and the implant, the reduction set which you like to use, and in these cases, what I personally feel, the level of selection of derotation, where you should derotate. So normally it's not like putting two screw about one level chhod ke dusra. It's not like that we just put it and then put the rods. I think concavity is very, very important for derotation. So first address the concavity, preferably have a good hold in the apex for derotation. And then you can have less number of screws, because on convexity, a lot of times you see that I myself have done 30 screws, 32 screws, but it's a very, very rigid construct. In such cases, I think it's not required. Up to 70% metal is really good. You can skip levels on the convexity, derotate, and then angulate. Then again, do the same thing for your lower spine. This is very, very important for getting a balanced, centered.
I think yes, very well summarized. I think the goals of surgery are safe surgery, balanced spine, balanced level shoulder, and pelvic obliquity has to be taken into consideration. Save lumbar levels, have a sound fusion, and try not to have overcorrection to put the child under geopolitical situation. Now, what kind of curve is this? Shailesh, let me start with you. What kind of curve? We know 60% correction we are expecting. We are going to use all correction maneuvers. We are going to use CHIRAYU's technique of putting in screws there, where iPad, I have learned it from him today, that every patient I would want to do a screw in that manner. Shailesh bhai, what type of curve is this? What classification do you follow? And what are your UIV and LIV in this case? Quick one.
It's a double major, and my
T5 L4 or T5 L3? Let's answer in this manner.
T4 to L3.
T4 to L3, screws at all level or hybrid?
Hybrid.
Hybrid. Navneet, quick answer. Selective thoracic fusion or both curves involved?
Bending films, please, before that.
Bending films here, you are. What are you looking in bending films?
If the lumbar curve corrects, I'm going to leave it alone. So it will be a...
It is correcting quite well. However, there is a rotation of grade 3 plus till L3. You see that?
Yes. Sorry, can I go back there? There's a rotation, but the rotation is starting from the pelvis itself. So I'm not sure how
L4.
orthogonal those X-rays are. Answer T3 to L3. So, but I'll use T3.
T3 to L3. Chirayu.
I mean, I would counsel the parents for a selective one.
Selective one.
Yes.
Okay.
And
what is your counseling selective and what is your plan in selective?
so I have to counsel them about mobility, that you will achieve mobility by doing a selective one. And if at all the correction is not so much, I mean, if there is a progression, then we may extend down to L3. But first, definitely, with this flexibility of the curve, I would go for a, and the lumbar prominence is not so significant when the child is bending.
Right. Subir bhai, fuse both curves or fuse only thoracic curve?
I prefer to do both the curves.
Both curves.
T5
What is
to
your
L4.
upper instrumented and lower
L4.
instrumented?
T5 to L4.
T5 to L4. Jwalant, any difference you would want to add to this?
So, sir, there are certain clinical and radiological criteria which we should follow, described by the Lanke classification, Lanke group. So we have to check the cob angle of the thoracic lumbar. We have to check clinically also the deformity. We have to also see the AVT, apical vertebral translation, and the AVR ratio also. All these factors have to be taken into the consideration before selecting the fusion levels.
Right.
And
So
the
this
patient's
curve-
concern was the loin
Lumbar bolster also.
so that
And
was
also the
most
activity of the
important,
patient is
thing.
very, very important. Whether patient is athlete,
Patient may
dancer, or
compensate later.
I think it all sums it up here that all the questions that we are looking answers for, what are the expectations of the patient have to be taken into consideration? What kind of correction maneuvers will it require? Screw density that you can use, UIV, LIV, whether to do selective thoracic or birth curves. It all comes from one single answer, which was given by Majid Holt in 2003. Team. It's called team. Team approach means the type of curve, the end vertebrae of both the curves. What are the attributes of the curve? That means stable, neutral, rotation, apex, apical, vertebral translation, etc. What is the motive of your curve and whether you are doing a safe surgery or a shitty surgery? And these teams classification has its own attributes, which involves a knowledge about terminology. You must know exactly what is the end vertebrae, because if you end up being into a second curve while doing a selective thoracic fusion, you are going to create a mess out of it. So a selective fusion is end to end, and that's why knowledge about end to end is very important. Shailesh wanted to go to T3. That means he's looking at a stable vertebrae, right, Shailesh? You are looking at a fusion of the whole construct in stable zone, and that's why knowledge about stable zone is very important. Jwalant mentioned about the role of apical vertebral translation, and Navneet mentioned about the rotation of apical vertebrae. Again, if you are stopping at apical vertebrae of the lower curve in an attempt to save lumbar levels, you are again creating a disaster. And that's why a knowledge about all these attributes is very, very important. The simple rule is know your terminology. Rule number 2, all spines have 3 curves. Even if it is seen 1, there are 3 curves: proximal thoracic, main thoracic, and thoracolumbar oblique lumbar. Even if it may be as small as 0, it may not be a structural curve, but it's your duty to measure all these curves, because in an attempt to fuse one curve, you may actually miss upon the proximal thoracic, resulting into an unbalanced shoulder in an attempt to correct the thoracic curve. So it's very important, rule number 2, before you plan surgery, whether you've seen all the curves important or not, and ascertain whether the other curves are structural or not. Like in our case, a structural curve is one which bends in bending films is more than 25 degrees. So let us go there, because all structural curves have to be primarily fused, particularly when there is a lumbar crease or a cosmetic effect to it. So in this case, the deformity of main thoracic is 78 bending to 52, lumbar is 58 bending to 28, and proximal thoracic is 24 bending to 14. So now, Shailesh, what kind of curve are we looking at here? So this is double structural, double major, King's type 2, Lanky type 3, C, with a lumbar modifier which is C. Yes, our case is this, that falls into this criteria. And our case falls into structural double major curve with a Lanky modifier C. So we are looking at a Lanky 3CN. Rule number 4, mentioned wrongly as 3, is that you must understand what is the principle of CSVL. Shailesh just highlighted. Shailesh, can you tell us what is stable zone and why is it important? Shailesh.
See, basically, when you understand that end to end, so it's always that you should always stop at the end vertebra and you should know the end and neutral vertebra. The stable zone is the lowermost part where your lower end will stop. If you see the apical vertebra and the neutral, the rotation of this is stopping at L2, L3, and the lower one is into the center. The L3 is probably a stable vertebra.
Yep.
Yeah, in the stable zone of
So basically 2 lines drawn from the pedicles of S1 going upward, whichever vertebrae completely falls into these 2 lines is called the stable vertebrae, or a vertebrae which is closely bisected by the central sacral vertebral line is the stable vertebrae, and that should be usually a safe zone to be the lower instrumented vertebrae. This principle stands right from Harrington days 1983 until today. I think this principle can never be bypassed, that all your instrumentation above that should rest on the stable vertebrae of the lowermost instrumented curve. I repeat, all the above implanted zone of the spine should rest on the stable vertebrae, and the construct must lie in the stable zone. Dr. Subir, why do you think it is important to have a construct on stable zone? What happens if
you do not end at the LIV, then there is a likelihood of decomposition of the curve, and there is a significant decomposition that can be seen, and people have shown that in the past as well. So you always must follow into the Harrington's stable zone.
Exactly. So safely, if you want to stop somewhere, the lower instrumented vertebrae should fall in the stable zone. Ideally should be a stable vertebrae, and that can easily be ascertained pre-operatively on bending films and also on the standing PA views also, right? So this is one case where we plan to do, quickly summing up. So selective fusion, we were talking about. We will not go into the details of selective fusion because here, okay. Yes. What kind of maneuvers would you use, Shailesh bhai, to correct this curve? Are you going to use release maneuvers, or you're going to do facetal osteotomies? You're going to use screws, Subir bhai?
Yeah, so for this patient, I would definitely need the rotation techniques, and I'll do the facet joint releases, and that will probably give me a good correction in this case itself.
Yes, Dr. Zolan, what other? I mean, you are going to use rod rotation. You will get a rod bent to the normal contours of the curve. You'll put in there and you'll rotate it.
So before any correction maneuvers, meticulous soft tissue release is where we are.
Soft tissue release.
Then the concave side rod rotation. Then convex side pushing and the simultaneous applying of the cantilever on the convex.
Right. Chirayu, what are your sequence of right from exposure? Screws are in. Now, what are your corrective maneuvers?
So screws are in means on the thoracic side, all the concave vertebrae, I would prefer to put screws. And the convex side, we can, of course, skip some levels. And the same will go on the lumbar side, that all the concave ones. And the lumbar curve will require, because there is a lot of rotation. So if we are including that, then we can use DVR at the lumbar side.
Right.
And the sequence wise, it will be always the concave thoracic first, connecting to the lumbar curve, and then the reverse from the other, cantilever from the other side.
Right. So Shailesh, anything more you would do? Like we have so far summarized, remember, all screw construct is not mandatory in all cases. You can have hybrid. Remember that apical hold is very important. Anchors, upper anchor and lower anchor should be at least 4 screws below, 4 screws above, and 4 screws in the apex. And then try to spare and throw screws, 1 in each vertebrae. One can be on the left side, one can be on the right side, but try to have solid anchors, solid apical hold, and the others can be spared apart.
See,
Yes.
in these kind of cases, it's very important to use mix and match. You need a couple of maneuvers, not only one. Most important is a good release, concave screws, cantilever for thoracic first,
Cantilever means pushing the rod to the lumbar spine.
where
So
you will get some amount of correction to the lumbar screws also. Put your rod over that, and then again concave screws in the lumbar, and subtle distraction. I personally don't prefer distraction. I use rod derotation.
Right. So once your rod is engaged on all the screws, that's when you do rotation of the curve, converting the scoliosis into the kyphosis of the curve and achieving sagittal line. Navneet, what else would you do?
Just one last point here. We have put the screws, the rods are almost ready. We think we're at the end of the operation. This is the most critical part of the operation now. And this is the time when you have to take as much time as possible. and use the very important orthopedic principle of stress relaxation. So it is a gradual correction. Scoliosis corrects by concavity. So correct a little, stop for a minute or two, let the tissues relax, correct again, stop, let the tissues relax, then correct again, stop, till your next stop. When you cannot correct anymore, that means that curve is not going to correct. But you have to wait for a minute or two for the ligaments, for the soft tissues to relax, for you to have said that you have done enough. If you do the first correction, fine, finish it, tighten it.
This is one of the most precise messages we must carry home intraoperatively. No one maneuver is good enough to have complete correction, and one maneuver, sudden correction, is also not recommended. Try to get all your screws safely inside. It's a long surgery. Be patient. After your screws are in, try to get the rod bent in a normal contour. Try to engage it by cantilever forces. Hold on. And before doing all that, good soft tissue release. Subir bhai mentioned about facetectomies. It's a good idea to do apical facetectomies to release it and make it a loose kind of bone. Once your cantilever comes in, do a primary rod rotation, wait a while, do a secondary rod rotation, do a third rod rotation until your rod has already rotated good enough. And after that comes the DVR. After that comes the further in situ bending if required, and also compression distraction at the end at the apical areas. So this is a combination of methods that you have to achieve to get good correction out there. And this is something that will help you to achieve a correction, something like this. We exactly followed the principles laid down by all our faculty members. We chose the upper instrumented vertebrae to be in T5 and the lower instrumented vertebrae to be in L3. Now, the lower instrumented vertebrae has multiple other principles to follow. Some very simple principles that selective fusion can be done in patients, in selective patients. And the criteria for selective fusions are very clearly laid down. Dr. Navneet, can you help us about quickly selective fusion when not to do, when not to attempt a selective fusion in double curves? We know primary major thoracic curve do thoracic fixation, thoracolumbar curve do thoracolumbar fusion. But when there are two curves, when not to do selective fusion, before we summarize the statement here?
So thoracic curves have to be fused because thoracic curves do not have a tendency to autocorrect. Secondly, in my experience, any of the curves that are approaching 90 degrees have to be corrected, even if they are coming to 50% on table. So any curve that is approaching 90 degrees have to be fixed. Then you can, although you have done bending films, what is a more practical way of knowing how flexible a curve it is on-table push-pull maneuver. So on-table push-pull maneuver, if you're able to get the curve within the stable zone, then you can selectively non-fuse it. But if on-table push-pull maneuver, it's not coming within the stable zone, then you've got to fix it.
Important. Yes, Ranjit, quick ones. Please.
No level is changed intraoperative. Everything is decided pre-operative strategies.
I have to totally
I think
disagree.
we have a coffee time after this to fight it out. But the primary two principles that I think everybody wants to know when choosing a lower instrumented vertebrae, whether when not to do selective fusion, what are the rules of selective fusion, and if it is L3 versus L4 dilemma in mind, how to decide whether L3 to stop or L4 to stop. I'll take the liberty to sum up the principles taught to me by the panelists in 2 slides. That selective fusion is it is meant primarily to save the lumbar spine. However, it has certain rules to follow, cannot be done in every patient. It has to be done in only patients who are RESER 4 or above. That is rule number 1. Rule number 2, if there is a major lumbar bolster, do not attempt selective fusion. If there is a C modifier where the apical translation of lumbar is too far away, do not attempt a selective fusion. Also, whenever you are overcorrecting the thoracic curve, do not attempt the selective thoracic fusion. And whenever you feel that you have to forcefully stop at the apex of lower one, it is not a selective fusion. So selective fusion, please don't attempt in C modifiers or a clinical lumbar bolster. And very simple answer. And patient doesn't. Very important, because decompensation is known to happen in 20% cases in a meticulously chosen selective fusion patient. Last but not the least, when to stop at L3 or L4. If there is a dilemma in L3, L4, just remember these simple rules that please don't stop at L3 if the L3 intraoperatively is tilted by 15 degree or more. or the disc L3-4 is not becoming parallel on pre-operative bending films. Please try to go to L4, otherwise your patient may actually have a post-operative tilt causing decompensation in these patients. With this, I would like to summarize this whole session here. Yeah, I have. Three. So this has got corrected. Unfortunately, I have not shown you this because I have gone below the apex of the curve, and L4 is a stable vertebra. As you can see the rotation there. It's a neutral, it's a stable, and I have stopped just short of it. Now again, I'll just quickly say that we often, in an attempt to correct the scoliosis, forget about correction of thoracic kyphosis, which is one of the most paramount features in scoliosis correction. If you see thoracic kyphosis correction and restoration of lumbar lordosis is another very important thing which happens by rod rotation only. Yes, Ajay, we just close this session then.
I will go by a non-pure science wording here because selective fusion would be decided. One reason is that she's a plump girl. There is a old saying, and many may agree. You can look at the mother, how this child is going to progress. If she is plump and we are seeing the mother is also plump, it's likely that she will maintain this body.
Selective fusion is not meant for obese kids also.
So in this case, it is very less apparent. It is very flexible. I can very well stop at L1 and 2, and I can take into confidence.
Yes, counseling. The role of counseling very well highlighted by Ajay, that if you are stopping anything short of the principle that we discussed, please counsel your patient that you are taking a chance. To summarize, not all scoliosis cases are AIS. AIS is a diagnosis of exclusion. Please investigate them in detail, find out the exact cause of scoliosis. Not all scolies progress. Mild to moderate ones can actually be treated by bracing. Try to find them early, start treatment early, necessarily, which may not necessarily be a fusion. Try to delay the surgery as far near to the maturity as you can. There are various type of scoliosis curves, and the principles of them are laid down in various classification systems. Try to buy hard those classifications. There are modifiers which help you in determining whether selection of fusion levels can be done in selective manner, or you will have to go to L3 or L4. And remember, meticulous surgical technique and neuromonitoring is the current gold standard. Thank you so much, Chairperson. Thank you everyone for being around.
We have PG quiz after the best cases presentation, but along with that there is audience quiz as well, and in that we will be giving goodies to the person who gives the correct answer from the audience. So I want you all to be present in that quiz as well. So it's not just a PG quiz, but along with that it's an audience participation as well. Thank you.
Thank you all the speakers. Now we'll take a short break of 10 minutes for the coffee. Thank you.
please get back to the seats. So now we'll start with the next session of my best case presentations. So now moving on to the young Turks of SAG, I would like to invite Dr. Tharadra sir as a panelist and Dr. Mayur Wala sir on the dais, please. And we'll quickly start. Come, sir. Ayaz, ha. Now we'll start with the first case presenter, Dr. Prateek sir.
Hello. Minute. Good evening, everybody. I'll start my case. A 30-year female presented to us with severe backache since 1 year. The VAS was 8. There was inability to sit, difficulty in breathing, difficulty in eating. There was no bowel and bladder involvement. Neurology was normal, and she was operated twice for spine surgery elsewhere. She had a costopelvic impingement kind of picture. This was the pre-op X-rays, which showed a kyphoscoliotic deformity that was extending from T5 to L5 with a convexity towards the left side. And the apex of the scoliosis was at D11, D12. This was the scanogram, which showed kyphoscoliotic deformity, and the corpse angle was 56 degrees pre-op. She was operated twice elsewhere 10 years back. The first surgery was done for the correction of the deformity, and the implants were removed 8 months post-surgery. So this was the picture. So we could not classify this curve as we don't have any pre-op X-rays as such. So this was the thing, and we had corpse angle was 56 degrees pre-op. This was the MRI, which did not show any significant neurocompression. There was no cord abnormalities. There was neither an hemivertebra, a wedge vertebra, or a fused vertebra. This was the axial scans of the MRI, which showed rotations. This was the CT scan, where you can see there's a fusion mass that has been seen from D8 to L1. There was a fused mass, which was seen from D8 to L1 already. This was the 3D CT, which was reconstructed. As we did not have a 3D navigation in our system, we had a 2D navigation. So we created a 3D model that would help us in the selection of fusion levels and also in the surgery. So this was a 3D model that was created with the help of a CT scan. And this was the fusion mass you can see that was seen. And this was sterilized and used in the surgery to help us in the correction of the deformity also. So what were the challenges what we faced was, a case like this, we always require an OARM or a 3D navigation that would be much more useful. There was a fusion mass which was seen extending from D8 to L1. So what we did in the surgery is we first removed the fusion mass from D8 to L1. We did a Pontes osteotomy, was done at all the levels. We did a bilateral discectomy from L1 to L5 at all the levels. And we then did a derotation. This was the post-op X-ray, where the corpse was reduced from 56 degrees to 9 degrees. And this was the X-ray at 15th month, which showed no evidence of implant loosening or implant failure. And this was the X-ray at CT at 15th month, which showed a fusion levels also.
Yeah, thank you, Prateek. Yes, sir. What was your power of findings for why the screw were removed? Is there any infection findings?
Sir, the patient gave us the history that the first surgery was done 10 years back. They had removed in first surgery, they had put the implant and they had done a correction of deformity. Post 6 months, she started developing severe back pain and there was an implant prominence. And when they went inside, they had to remove the implants because of the infection, what the patient told us. But she did not have any definitive papers or what was exactly done. This was the thing which doctor had informed her. After that, she was having back pain for around 5 to 6 years, but that was still tolerable. from the last surgery was just the last surgery was done 10 years back, and she started developing severe back pain since last 1 to 1.5 years. And the main problem was costopelvic impingement. So she was not able to sit properly, not able to breathe, and even not able to eat properly. So this was her main complaints and severe back pain. So she had presented to us with that.
Have you done any pre-operative specific investigation for activeness of anything?
We only did, sir, pre-op X-rays, MRIs and all. We did not do anything else than that. specific.
Post-operative status, your case?
Sir, post-operative static, when we got a CT scan done, and when we went inside, there was a fusion mass that was extending from.
That's okay. Yeah, after surgery,
Yes, sir.
What is the follow-up?
Yeah, sir.
Is
Follow-up
any-
patient had a specifically pain relief. We can say that she was better in VAS score from 8, the VAS score reduced to 3. And at 15 months follow-up, her VAS was at least 2. She is now presently very much stable. There is no complaints. She can breathe, she can sit, even she is able to do her regular activities well. Okay, so these are the things.
Any questions from audience? Yeah, thank you.
Thank you, sir. Thank you.
Ronin Shangvi, please be here for the second place.
Good evening, everyone. My case is a 75-year female. She has back pain since 4 to 5 years and with left lower limb pain since 2 years, but she was pulling on and was doing well with medicines and physio and brace. Gradually, the pain had increased and she was homebound since last 1 year. However, since last 6 months, she was not able to come out of bed or even sit to stand, and go to washroom was an issue. Wearing a sari was also a difficulty for her, and she was not able to stand more than 2 to 3 minutes. Walking distance was just 20 to 30 feet. She had more of her back pain than a leg pain. VAS was around 8 for back and 7 for leg pain. And sit to stand, turning in bed was really difficult and very severe pain for her. Sitting, she was able to sit for 15 to 20 minutes with support. So on examination, it was a scoliotic spine. There was a back tenderness was present. Neurologically, she was intact. There was no power loss or anything. Ball bladder, okay. Sensation over the left lower limb were reduced. Pulsations were present. Medically, she was fine. There were no other clinical comorbidities except for old age. This was her X-ray in supine position. AP X-ray and lateral, we can see the levoscoliosis or left side convexity. It is a case of a degenerative adult scoliosis, and that was a lateral X-ray. And this was the standing scanograms that showed on comparing the standing as well as supine X-ray. There was some lateral listhesis at L2-3 level and opening up of L3-4 disc space. It was more of a collapsing spine and unstable spine, as a result of which she was having the back pain. And there was we got the MRI done, and on that there were foraminal stenosis over left side at L5S1 and L3-4 levels. The axial also proved the same. I even got so these are the axial images. Got a CT scan done, which showed vacuum disc at almost all the lumbar levels, especially L5S1 and above at L1-2, L2-3, L3-4. So all things were tried, but she was not improving, and her activities of daily living were significantly affected. She was properly counseled and surgery was advised. The plans were OLIF, but my surgical expertise for OLIF is not that good. Then it was a short segment fixation from L2 to L5. But like we saw in the last film, there was this vacuum disc sign at L5S1 and even at L1, L2 upper level. So I had to go from the long segment fixation from D10 to the pelvis, inserted screws from D10 up to the pelvis, the ELA screws, and did interbody fusion at L5S1, L4-5, and to prevent a future PJK, I even cemented the upper uninstrumented vertebra at D9, so that the chances of PJK are very minimal. So patient, it is just 1 month post-op. Patient is now able to walk out of her bed, and turning in bed is hassle-free. She is able to walk in the room. She is at home. She is put on teriparatide, and the fingers are crossed for proximal junctional kyphosis.
Have you done pre-op DEXA?
DEXA. Sir, DEXA is not available at my place, so that is not done. But
Okay.
I assume on the basis of the screws that I inserted.
No,
there.
even then, according to the hip X-ray, have you classified the osteoporosis if it is taken in, if DEXA are not available pre-operatively? Grading of osteoporosis from hip, have you?
No, pre-operatively not, but on putting the screws, the hold was okay. It was not very good.
Any comment? Yeah, please.
Sorry?
How did you do the neural decompression? Neural decompression, because the patient has clear signs of neurogenic pain.
It was the pain was on left side, and the
And
scoliosis.
please wait. And just decompressing the nerves would have helped this lady of 78 or 80 years old.
She had back pain.
Now
Was a
fixing this lady, I'm not finished, please. Fixing this 80 years old lady from D10 to L5 to pelvis. What were your objectives while doing this procedure?
Okay. So to answer your question, first, the back pain was more disabling than the leg pain. Secondly, on standing X-ray, the spine was collapsing, the scoliotic deformity was increasing. So only decompressing the spine would have added to her instability. So there is no option, there is no question of only decompressing the spine, because the back pain was more disabling than a leg pain. And if I had stopped, if I had gone for a short segment fixation, I was in doubt whether at the lower and the upper segment, which already shows this vacuum disc sign. So in future, 6 months or 12 months down the line, she might develop other upper or lower level instability, and that could add up to our problem. So I went in, I had just single surgery. I offered her a single surgery, and so that everything gets clear.
Very nicely done case. There was no doubt about fixation. It has to be fixed. But the only thing what I would have thought in differing was a short segment fixation, because resurgery rates, if you consider long segment fixations or short, are pretty much the same in literature. So okay. I would be on the other erring on the less invasive side rather than the more invasive. As I said, very nicely done.
Sure. Thank you. Yeah, now I request Dr. Ravis Patel.
Yes.
Okay, good evening, everybody. Let me first disclose that I am like a 12th man in deformity. I do other things which are more common, and I seldom do deformities. But I am presenting this case because of the encouragement from my friends. Okay, so thank you. Coming back to the case, so this case is a 19-year-old male patient having progressive deformity for about 7 years. There was nothing significant as far as past history is concerned. And he presented to me at this stage. And so if we look at the clinical scenario, he has scoliosis, a rib hump at thoracic region, which was about 23 degrees. Right shoulder was slightly higher, and hips were level, and neurological examination was normal. I have not loaded the MRI images, but they were also normal. So as far as the X-rays are concerned, the main thoracic curve, which was from T6 to T11, measured 68, and it was corrected to 46 on bending films. As far as proximal curve was concerned, it was 43 degree, and which corrects to just 35 degrees. Lumbar curve was almost, I would say, was flexible. There was thoracic hypokyphosis. Pelvic incidence was low, so I think I can, I don't need to reconstruct more of lordosis or hypokyphosis. So I classified this as adolescent idiopathic scoliosis as 2A minus. And there were 4 things on my mind whether to conserve or operate, but the patient took the decision that he wanted to go ahead with the surgery because of the cosmetic purpose. As far as lower instrumented level was concerned, this was the recently published paper at that time, and which said that the lower instrumented in 2A is usually selected as last stable touch vertebrae. And if you look at the X-ray, just L1 was the one which was touching the central sacral vertical line. Now, as far as the upper instrumented level was concerned, I took this paper into consideration. The proximal, since the right shoulder was slightly higher and T1 was almost parallel, so I considered this as a mismatch, and I decided to include the proximal curve up to T2. Correction, I thought that I will get away, and because 46 was already with the bending films, and I just need to add on more 20 degrees to get a good decent correction. I used cantilever, sequential tightening, rod derotation, differential contouring, and some facet osteotomies were done in the thoracic spine, and ultimately, I also had to add on thoracoplasty. It was an intraoperative decision. This was the intraoperative photos. This was the post-surgery, immediate post-surgery X-rays. And this is the 2-year follow-up. So the image on the right is before and after, and he got a decent correction. He's happy. And I can see there is some T1 slope, which has developed post-operatively, but patient is so far okay with that. And so far, 2 years down the line, he is doing well. Thank you.
Yeah, good correction. Anyone would have done something else the different way?
This one?
Thoracoplasty correction, mostly one is for cosmetic, in particularly girls. And to some extent may improve in young patient, but in skeletally mature, I don't think so. It may have an impact on a pulmonary function. But for thoracoplasty indication, mostly we have seen is for cosmetic. And if we do with vertebral rotation, then even it is better. But yeah, that if you do with vertebral rotation, then it will be better.
Well, I guess it depends on the flexibility of the curve. If you have got good release, your vertebra is moving good, probably you don't need thoracoplasty. But if it is a rigid, high magnitude curves, in my practice, I feel 50% of the time I have to exercise 1-2 ribs, just to correct the rib hump. Anything else?
Yeah, I agreed. But just coming to this case, I think it was a flexible curve and could have avoided thoracoplasty.
Yes, yes.
This is just a comment from my side.
Yes, noted. So it was not the plan initially, but intraoperatively I realized that the correction was not adequate. There's still hump left.
Yeah, so that means you should have released it much better,
Maybe.
or the other maneuvers need to be done.
We should have
because
done
this
it.
was not a very rigid curve.
Even till yes, noted.
Yeah, here the right.
Okay, noted.
Here the right side shoulder is elevated than the left side. In the deformity is also on the right side. And you said how much is the proximal curve?
46.
46. And how much is in the bending?
35.
35. Sometimes what I have observed, because of the sometimes like stiffness of the patient itself and who is doing the bending films, that also matters. So even in the literature, even my personal experience, when you do a traction film, that will give a better idea of the proximal curve rather than the bending films. So you can try a traction film and decide. So when you have a shoulder like on the opposite side is like a higher side or on the same level, then I prefer to go to the D2 level, rest D3 is fine to me in this case.
Okay, noted. Thank you.
Good. Ravish, thank you. Nishar, Parikh.
Thank you, sir. Good evening, respected teachers and dear colleagues. So getting straight to the case. So here is the case of 14 years male patient, left-sided thoracic hump was the major complaint. No other significant clinical history, right, from the birth history to the developmental milestones, and no other clinical symptoms like pain or weakness, and normal neurological examination. So this was the curve. And as in our previous discussion by Dr. Vishal sir, this typically falls into a double major or type 3 curve. Obviously, the bending films will highlight more onto this classification. And main thoracic curve was of 80 degrees, lumbar was 55. Apical rotation was of grade 2 to grade 3 and reserves grade 3. Bending films show no, it wasn't that much flexible curve. Although on the AP X-ray, the CSVL line, it fell into type C. So it was a type 3C N curve. These are the side films. On MRI and CT scan, no remarkable finding was present. Cord was absolutely fine, and no hemi or the bony bar was present. So this was what done the surgical execution. T4 to L4 posterior fixation for correction maneuver. Apart from the routine rod derotation and cantilever maneuvers, facetectomies and multiple ponties at apex was done at thoracic level. And post-operative X-ray showed a decent, reasonable amount of the correction. The COPS was 24 and 11 degrees for dorsal and lumbar curves. Lateral X-ray showed near normal lumbar lordosis and well-maintained dorsal kyphosis. These X-rays were taken at 1 year follow-up. In the immediate post-operative period, there was some, you can see, pardon for the X-ray, but L5 vertebra did show some amount of rotation. So that was a little bit worrisome. But on the 1 year follow-up, the curve was maintained very well. And this is the 1 year clinical follow-up. Thank you.
Good correction. Any comments from the audience?
Yes. So I would like to add one more thing. Sorry for that. Costoplasty was done for the rectification of the rim hub. Although I put a flat convex rod, it didn't, rectify the rim hub. So I had to perform costoplasty 3 ribs.
I think costoplasty would have been avoided in this case because the well-balanced spine with 2 curves.
Just a general faculty. What is a choice of material for rods for the cases cobalt chromium versus the titanium? Whether you have a set use or it differs depending upon how flexible the curve is on table or how much of a confidence you have on your apical anchors. Just general question to all the faculties.
That was the same question. That what was your rod?
Titanium rods on both the sides.
Because we were just discussing the same thing. Because titanium rod in these type of flexible, you should try out the CC rod to get your more thoracic kyphosis as well as lumbar lordosis. Otherwise, whatever you give, I call it as a poly rod. You know that.
Yes, sir.
So they are going to flatten out.
So anything apart from that, I mean, to avoid the costoplasty, apart from using CC rods or flat rods on the convex side?
Absolutely great. No problem.
Okay. Thank you.
Just was not to you, sir. One question just about the direct vertebral rotation. In one case, we felt that me and Hardik that it was not adequately rotated when we tried. So, any tips for direct vertebral rotation? Any particular thing we have to keep in mind? It was not adequate. We tried for the segmental rotation. We tried for the end block rotation also, but it was not satisfactorily rotated at the end. What is done? So is there particularly about the some levels should be fixed, some is
On concave and convex side, if you just want to go for segmental rotations at the apex, then you have to fix all the apical convex as well as concave. Then only you will be able to derotate it. All the concave as well as convex, both the sides.
So what my personal experience, what I feel with the Indian implants, whenever you use these poly screws, that usually, yes, so
I always now, even before I was using actually non-poly screw. That means uniaxial if you have, or a mono screws at the apex. That will also give you much more rotation. Definitely. So that's what I'm telling. Either uniaxial, or if you don't have uniaxial, and if it's a rigid, it's not a rigid curve. If it's a rigid curve, then you don't use a monoaxials. Otherwise, you can use a monoaxials. That's what. So in rigid, so it all depends on flexibility. Otherwise, the screws will break up.
Thank you very much, sir. Thank you. May I call Jinil Doshi to present his case?
Sir, in which cases we should avoid derotation? In what all cases should we avoid derotation? Sir, in what all cases we should avoid derotation, not to be tried at all?
What I'm asking is if you have a very short. Sorry, friends, you later on discuss personally. Thank you very much.
So I would
Yeah,
like to
Dr.
present
Jinil, please go on.
Yes, sir. Thank you. I would like to present the case. She is a 66-year female with a past history of cervical laminectomy and the intramedullary SOL excision done 16 years back elsewhere, followed by radiotherapy. She did well. She presented to us with neck pain with a forward stoop posture with recent worsening for the last 2 months in the neurology. She had balance trouble, unable to stand or walk without support. She was literally wheelchair bound with bilateral hand tingling and weakness. Examination revealed both hand grip weak, lower limb spasticity. The power was grade 3, plantars upgoing, and the lower limb sense of joint position was impaired. This is the previous post-op pre-op MRI, which had shown there was an intramedullary lesion with a syrinx. Just for a reference, this is not our pre-op MRI. This is the pre-op MRI which the patient presented, which shows there is no residual of the tumor. The syrinx had resolved, but there was significant post-lamic kyphosis with a myelomalacia without any active neurocompression. The axial cuts confirming there is no active neurocompression, but it was a dynamic compression. These are the X-rays, the static films, the dynamic films showing that there was a kyphosis, but which was correctable on extension. This is a CT, the axial views. So now we are planning whether to conserve or operate. We had to operate as there was neurology, anterior, posterior, 360, any role of pre-op or intra-op traction. So we went through the literature, which shows that post-cervical lami kyphosis is very common, especially when done in case of young patients with a history of radiotherapy. So as per this report, it shows that if the deformity was correctable by proper positioning, then we can approach it posteriorly. But if it was a fixed deformity, then we have to do anterior release followed by anterior plus minus posterior surgery. So we went on with this plan. Under neuromonitoring, we took the supine readings followed by correcting of the curve under neuromonitoring. We took the prone films. The signals of the neuromonitoring improved. Confirm under C-arm, approach posteriorly, did a lateral mass to fixation and fusion using bone graft. This was our intra-op C-arm image. Though it is not that lorded, but we were able to correct the kyphosis. This is the post-op X-ray. And clinically, the patient's neurology also improved, which was correlating with the improvement in the neuromonitoring signals. At 1 month follow-up, the patient was able to stand with a walker, but we are still awaiting the long-term follow-up. Thank you.
Yeah, so how long is the follow-up up till now?
Sir, we just operated last month, sir. Like, this was a very previous case. Like, just one follow-up we have.
Okay.
So we are still curious.
So are you still worried about like getting this fuse in the corrected position whatsoever you got the correction, or still you
So
are
if
confident about that?
We are also skeptical. So we have started teriparatide strict bracing for 3 months. That we are doing, sir.
And any specific reason for not going anterior, because it's likely it's the deformity
Sir,
which is
yes, but as the curve was correctable, and secondly the neurology was improving.
okay. Good.
There was signals improved. I am
fine. Yeah.
Can you please show the pre-op X-ray? It looked like listhesis at 2, 3, 4, 5. And if you see 3, 4 and 2, 3 are pretty much lordotic.
They were all lordotic and they were fused when we saw intra-op. The laterally they were fused.
Correct. So how about going just 5, 6 anterior? 4, 5. 4, 5 anterior. Just 4, 5 anterior give good lordosis. 2, 3, 3, 4 are already lordotic. 6, 7, 5, 6 are fused. Only 4, 5 is going listhetic and kyphotic.
Yes.
How about going just single level anti-ACDF? Anyone else's comment on that? Okay, 2 level, maybe 2 level ACDF. If I see that 5, 6 is pretty much fused, so it won't even correct on posterior fixation. We won't get correction even on putting screws posteriorly. It is fused anteriorly. 2 level ACDF would have given probably a better correction to the curve rather than going just posterior.
If you would have just done ACDF,
yeah,
it would have been fine for the 3-4 level. 4-5 would have been an extreme challenge because of the angle of the disc. Secondly, if you are doing 2 ACDF levels above, now that would have changed your IONM monitoring if you were to extend it.
Already posterior laminectomy done, so I don't think that would have done much damage further. Positioning,
but then you would still have to put a plate to
Yeah.
protect those. Now, to put a plate into that sort of a kyphotic cage, a kyphotic spine would have been much of a challenge when you can achieve the same result posteriorly. One. Secondly, I do believe that your fixation might have been a little bit longer. You could have extended it to T3 or T4 just to give it that stable base. So posteriorly was a safer surgery, in my opinion. Fair enough. Agree with the cage.
2 level cage would have distracted, given a lordosis, and then put in a plate anteriorly.
Agreed, but I think here the problem is mainly at the kyphotic level, which is below the C5, C6 level, rather than 3-4 level.
It seems to be fused. I don't think that might be given, but you are a better judge.
Yeah. Okay.
Point noted.
Fine. Thank you, Janil. May I ask Dr. Rohit Thakur? Okay, this is present his case.
Good evening, everyone. We have talked a lot about scoliosis, and here I am presenting a case of a kyphosis. So this is a 41-year-old gentleman who was a heavy truck driver initially. He presented to us with a mid and low back region pain. He has some deformity in a mid back region since childhood, but that was never a concern. He was not worried at all about his deformity. But since last 4 months, he developed weakness in both the lower limbs, which was gradually increasing. Initially, he started to feeling burning sensation in both the legs, and then eventually he started to develop a weakness. And in last 1 or 1.5 months, he was completely bedridden. He also has involuntary passage of urine and stool. And patient does not have any history of childhood trauma or like anything. He was investigated for the same deformity, or he was not having any history of like treated for tuberculosis or anything. On examination, there was a deformity in a mid back region, which was mildly tender. There was a hypertonia in both the lower limb. Plantars were upward, reflexes were exaggerated, and there were below L1 hypostasia, and power was around grade 3/5. So patient basically presented with a spastic paraparesis with a bowel bladder involved, and he has some deformity in a mid back region. X-rays were done. X-ray were showing significant kyphotic deformity at the dorsolumbar junction. It was around 110 degree, and there was not much movement in a flexion and extension view. So it was almost stiff deformity. There was no scoliosis at the same level. On X-ray, it was visible that L1 was completely deformed and L1, L2 were fused, and D12 was also deformed. In MRI, it shows that L1, L2 were fused, D12 was deformed, but the D12 and L1 disc was open. It was not fused. And because of that, no fusion at D12 L1 disc, there was a micro movement over there, and patient has a ligamentum flava hypertrophy posteriorly. So basically, cord was pinched between the internal gibbous from the kyphotic deformity and the ligamentum flavum hypertrophy from behind. And because of that, patient has developed cord edema, and that was the main cause of his recent neurological development. Otherwise, patient has this deformity since childhood, and he has no problem with the deformity. So management, so we went ahead with the deformity correction surgery by only posterior approach. 2 level above, 2 level below were fixed, and on one side D11 and D12 roots were sacrificed, and internal gibbous was completely removed under neuromonitoring. We used the expandable cage and achieved as much as correction possible with the reduction technique. It was done under neuromonitoring, and to not further deteriorate the neurology, we accept the whatever correction we could achieve. These are the immediate post-op X-rays. Deformity was corrected to 70 degree, which was almost maintained up to the 2-year post-op follow-up. These are the clinical recent clinical pictures of the patient. Deformity is corrected to 70 degree, and is very well maintained at 2 years. He is now driving and doing his all day-to-day activities, and patient is very happy right now.
Yeah.
Thank you.
Any comments, questions?
Yeah, so in this case, there's a significant amount of kyphotic deformity to begin with. And I think that the amount of stress that is on the rods is tremendous, since now you have done the anterior work also, and till the time it is fused, there is a significant stress on the rods. So maybe the upper screws, there would have been, I think 6 anchors would have been better at superior aspect.
Yes, yes.
And what do you think about addition of the crosslinks, just to or the additional rods in the center of the construct, just to prevent the rod failure?
The upper one screw has not that much hold intra-op, so we add the crosslink to enhance the strength of the structure. And definitely 3 anchor would have been better, but the deformity was very significant, so we avoided it.
It's a junctional area with so much correction what you are expecting, and 4 anchors probably I think it should have having at least 6 anchor. That what we usually prefer. Anything, sir? Okay.
And sir, I will like to one thing. As patient has only neurological development, that was his main concern, and it was because of the ligamentum flavum hypertrophy. So it could have been avoided rather than only doing the like fixation at the single level and doing the decompression surgery without doing the deformity correction.
So that you have to decide before surgery,
Yes.
dynamic X-ray, MRI review, CT scan.
Yes.
Then you can do it. But in kyphotic deformity, posterior element excision may lead to worsening of deformity, but in a stable fused column may not worsen.
Okay.
It may be sufficient only decompression. So if anteriorly fused, there are less chances of further progression.
Yes, sir.
So all this CT scan evaluation before dynamic view, everything should be done.
It could have.
Yeah.
Thank you.
Thank you. Dr. Harshil Patel.
One of the last cases of the day. I'll just rush through my case. My case is of sagittal balance due to fixed kyphotic deformity of a 32-year-old male patient with dorsolumbar kyphotic deformity since last 3 years, gradual in onset, and it progressed to its current state. Other systemic examination and history was normal, and yes, hip examination of that patient was normal. Pre-operative X-rays, full length, AP and lateral, wherein pelvic tilt has increased, sacral slope has decreased, thoracolumbar kyphosis, lumbar kyphosis has increased. So the main complaint here was difficulty in walking, unable to sleep in supine position, forward vision, chin brow vertebral angle 55, and occiput to wall distance 60. No significant findings in MRI and CT scan. Yes, hip X-ray, PBH. So our aim was to restore the view angle and sagittal balance and relieve the compression of abdominal viscera by rib margins. And yes, to bring SVA around 5 centimeter and chin brow vertebral angle around 10 to 20. The principles followed here were more caudal the osteotomy, greater is the collection in sagittal balance. And the correction of CBVA, chin brow vertebral angle, is independent of the level of osteotomy. Thoracic osteotomy is not preferred much as primary osteotomy, as it has narrow canal and ankylosed facet in case of ankylosing. And yes, lumbar osteotomy is very well preferred due to wide canal and below L1 level. Now, what to do first? This is still a controversy till date. Hip surgery is less morbid and compensation can be provided by mobile hip if THR is done first. Patients with severe kyphotic deformity whereas they have high chances of hip dislocation when done first, and the intraoperative version is also difficult in kyphotic such patients. So we prefer hip surgery first if there is severe OA hip. So in this case, hip was normal and we planned for spine surgery. Planning was done at L3 level osteotomy, wedge of 30 to 35 degree, pedicle subtraction osteotomy. Positioning after anesthesia, bent table with fiber optic intubation. L3 level pedicle subtraction osteotomy was done. In the image below, it is after the closure of osteotomy. Osteotomy was closed with differential rod reduction. Reduction screws were used. Compression, final compression was given between the screws, and then broken table was made straight in the end. This is the final view. Pelvic tilt has decreased, slope has increased, kyphosis has decreased, chin brow angle we have been able to correct it to 12 and occiput wall distance to around 15. Final image. This is the gate, but I'm not able to open the video. This is just another case where we did only THR, no spine. So the message here, Pontes achieves only minimal correction in ankylosing cases, so we should plan accordingly. Special care in positioning the patient. Inflammatory back pain often persists after surgery. Patient should be explained beforehand. L3 is the most common level, and PSO is the osteotomy of choice. And fixation should be extended till upper thoracic level to prevent residual imbalance in case of severe kyphotic deformities. Thank you very much.
Thank you, Arsa. Any question?
Yes, sir.
Good evening. I'm Hitesh. It's a very wonderful case and it is basically indicated case. Why you need this case? It's just a comment that such patient is having severe kyphosis and that's why that chin angle is facing downwards. And in such patients, usually what happens that craniocervical junction or the C1, C2 joint is the least fused joint. And I have reported this phenomenon in JBJS in 2011, that in ankylosing spondylitis patients, because of this kyphotic deformity, patient used to develop craniocervical instability, causing cervical cord compression, and ultimately they succumb because of cardiorespiratory complications. That's why I think even if patient is asymptomatic, to prevent this phenomena, I think you need to do a pedicle subtraction osteotomy to make him look straight.
Yes,
thank you.
Very well, sir.
Noted. Any review regarding vascular complication on correction of the?
Those are, sir, very rare. There are very rare cases of correction while doing this such cases. Yes, there definitely it has such patients.
Yeah, particularly for Smith-Peterson osteotomy, they recommend that you should look for any calcification.
Yes.
You even measure the anterior length achievement pre and post after your templating.
Okay, sir.
Yeah. Thank
I
you.
have an experience of 3 such cases, but haven't.
Yeah, thank you very much.
Thank you.
Yeah.
Thank you very much. Thank you, SAG.
Thank you very much, all the presenters, Tharadra sir and Mayur sir. Thank you. Now we will proceed for quiz. Over to you.
Let's have the 4 team. I think let's have the team A, VS Hospital. Can we have you here, please? The VS Hospital residents, can you come here, please? Then the second team is Surat. Can you occupy these 3 seats, please? No, you can VS on this side. Okay. Can we have the MP Shah, Jamnagar? That's the third one. And can we have the civil hospital? Miran, you can explain the rules. Yeah, no. We have 3 judges, Dr. Subir Bhai, Dr. Amit Bhai, and Dr. Ajay Krishnan. So when I put the question for the audience, I want judges to get up and observe, who is the first one who is replying, the audience. Yeah. Miran, you can start the. Yeah.
So as shared on the WhatsApp group, the rules are round 1 is rapid fire round. The teams have to attempt MCQs in 10 seconds for each MCQ. And there is a single correct answer for each one. There will be 5 marks for each correct answer. The round 2 is the buzzer round. 10 marks for pressing the buzzer first and giving the correct answer, and -5 for the wrong answer. And round 3 is the bonus round. The time allocated for each question is 60 seconds. And the correct answer has 20 marks. And the judges will be deciding the marks.
Before we start, you all have understood? You need a piece of paper. Yeah. The judges' conclusion, we will have to honor that. That is one. Second thing, audience, whoever replies first will be given goodies at the end of the quiz. Severe Spine Hospital team, nobody is going to answer because many of them, they would know the answer, so they are not allowed to participate. And only one goodies will be given for the audience quiz. Now, in the quiz rapid fire round, the question will be displayed and answers will be displayed afterwards. And you can write the answer in the sheet written and write down your team name and then hand it over to the judge. So once the first round is over, do that. And I think you should write down your names as well. So when the certificate being issued, then we can write the name on the certificate. So all the three. And I would say that date as well. The second round, which has been explained, that it's going to be the.
Yes, it's the buzzer round. So you are given 4 buzzers. The team which pushes the buzzer first will be given the chance to say the correct answer.
And if the answer is wrong,
then the marks are -5.
Right, so -5. So that is one. Second thing, once you press the buzzer, the second one buzzer will not be taken call. So whoever presses the buzzer will have to reply. And third round is?
That is the bonus round. Each question you will be given 60 seconds. And the weightage is 20 marks. So the judges will be deciding. You have to give the answer at length.
So you have the piece of paper. The third round again is on the paper. Am I right?
Yes.
Yeah. Okay. So are we all ready? And after each round, we have the one audience question. Okay, let's start. Miran, let us start.
एक बार buzzer press कर दो.
Press the buzzer one after another.
So
have you tested your buzzer? Done. Okay. Start.
So you have to reset. Reset करना है वो buzzer.
It's all done, na?
Chalo, let's start.
So leave the question for a while. Okay, answer please. So shall we play? Okay, carry on. Let's wait. Do you want more seconds or we are okay? Teams, are we all okay for the time wise? 10 seconds? Carry on. Now that's the last question. We completing the 20 questions. Thank you. So shall we collect the answer sheets? Yes, sir, shall we collect the answer sheets, please? And now, once it is collected, thank you. Now the question to audience. I think if you are ready, can we have the question, please? What is the medical terminology for this condition? Medical word used for this condition? Top of hair. No, medical word. No, it's okay. Medical word. That's right. He has to give it. No, top of hair, sign of that. That's all. No, medical dictionary word. Let's put it more precisely. Medical dictionary word. No, medical dictionary word, not from the Soviet Union. Yeah, not from the Soviet Union, because I'm saying you would have understood. Yeah. So he mentioned that. Yeah, he mentioned that. Okay. I think judges can decide to give prize. Who shall we give prize? Guru. Okay. Okay. Now we'll give it at the end. He's not going to take it home, so it's going to be us only. Anyway, so thank you, Guru. Okay, let's now the buzzer round. Viran, you can repeat the.
Yes, so the
hypertrichosis
pressing the
word
buzzer
used
first.
for, yeah. That is why I put this sort of. Yeah. Chalo, okay. Now you write down your team name and your names as well, and the date. Buzzer round is not for the answer, but that's the last round. Okay. You want to?
Now, so you have to speak the answer, and the judges will decide whether it's right or wrong.
So you want to 10 marks for the team? You want to repeat?
Yes. So 10 marks for the right answer, -5 for the wrong answer.
So you get minus mark.
Because we need to find out -5.
A, B, C, कौन?
A, B, C.
This is BS. BS.
Give the names to the team.
Which team?
A,
Surat.
B, Surat. B, Surat.
Civil.
And D civil. Civil, you are civil. Okay, so D is civil. Jamnagar, Surat, and NHL.
BS, Surat, Jamnagar, Civil.
Done.
C is D. Civil is D.
Okay, shall we start? Are you all ready? Okay.
Flexor pollicis longus.
MC. Next question.
I think we will have the run tomorrow in the valedictory function. We'll have quick answer. I'm sure that will attract you all to stay back as well, and you will also learn as well. And we won't declare the winner as well. Shall we go for the next question? Are we ready for the next question, judges? Shall we? Next question? Okay. What is it?
Lateral mass fixation.
Okay, next question. Next question. What is the answer? Okay, okay. I think yeah.
Keep the mic in hand. Mic रखना है.
Yeah. So you have the mic. You have the mic. Okay.
Hypertrophy.
Okay, next question.
Arteriovenous malformation.
ऐसा आगे आगे तो बढ़ी जाएगी फ्लेक्शन की एक्सटेंशन सर टीयर ड्रॉप एक्सटेंशन
Next question. In the mic. Yeah, he mentioned. What did you mention? Could you repeat that?
सर टीयर ड्रॉप एक्सटेंशन
Eardrop extension injury.
extension
Fracture. Okay.
okay
Diastoma.
It's tricky.
Sir, D, fracture extending into the cancellous body of C2.
Be careful. No -5. Probably nobody will reply. This is not an audio job.
When alpha is when interbody fusion बोले तो चले कि नहीं?
Okay. No, why don't you reply? At least.
It's axial lift.
Okay, nobody reply. Carry on. Next.
Axial lift. Axial lift.
Axial lift.
It is put from the S1 to it is. It's okay. Yeah, as lift. It is exactly axial lift.
Arch lift.
It's exactly that.
I think nobody said that. Come on, this is easy. Spot the diagnosis.
L3, L4, LCS. PIVD, ligamentum flavum hypertrophy.
Good. Very good.
Now this is. Shall we run through all the 10? I think lot of audience need to know as well.
At least this 5 you can.
Yeah. After I think last 10 we can run through again. So let's go through the run through again. I think for you to know. Miran, yeah, go back. Yeah, you can go from back.
Go to 10 first. So now Ranjit will answer.
Yeah,
Who is going to answer?
Yeah, sarcopenia.
Yeah.
That is sarcopenia. You see the muscles are not there. Just leave it. Let everybody learn. There are no muscles there. That is sarcopenia.
See beyond this spine. Don't think being a spine surgeon is first going outside.
You can have the pointer. There is pointer there. Ajay, there is a pointer. So that is sarcopenia. 9 has been answered already. Action. Yeah. 8.
Answer is B.
B. Go back. This is out. Diastematomyalgia. Let me answer. This is limbus vertebra. So this is not a fracture.
So this is not a fracture. So the disc can prolapse posteriorly, extraforaminally, anteriorly also. This is anterior disc prolapse.
And it is usually
or smaller snot into the body.
Yeah. So this is the disc which has sort of gone into through the epiphysis.
It's very important to differentiate that this is not a fracture.
Yeah. And radiologists will report this as a fracture, and patient will come to you with the diagnosis in their hand as well. So make sure for the future practice. Okay. This is AVM.
This is the correct That's
fine. Back.
Ossified ligament of hypertrophy.
That's tuberculosis. So I think Ajay, you can explain.
Heterogeneous. The first thing is heterogeneous shadow, not uniform. Second is abscess cavities. You can see the locules also. So this is typical of any infective pathology which is going towards tuberculosis and not the actual
there is a
aggressive spondylitis.
Yeah, there is a ligament.
You can see the abscess which is anterior epidural with the ligamentum. There is a median ligament which is attached there. So that bulbous, that is again a feature of chronicity or slow growing abscess.
Meningiovertebral ligament.
T2.
No.
Yeah.
Meningiovertebral ligament. Can you point that out? Meningiovertebral ligament. If usually in the septic it will be destroyed, in the tuberculosis it will be preserved. So that is also an article which is writing this, mentioning the same. So that is the telltale sign of the tuberculosis. Pedicle screws. Pedicle screws. These are pedicle screws.
They are all pedicle screws.
The lateral mass has to be divergent.
Yeah. Next.
Audience.
Entry introsis now. Who mentioned that? Entry introsis.
Flexor pollicis.
Yeah. Great.
Yeah.
Yeah, one can. Yeah.
Indeed.
But you have to tell AIN.
Now ready for the audience round. Let's have the eyes. Who is answering the first? Let's play. A 78-year gentleman who is a known case of CA prostate 10 years ago and came with the head supported he was supporting his head, has neck pain since last 2 months, and all his CF prostate treatments was all done. No, let's wait. Let's wait. I have the images. And he's a well-known individual, and he had no neurological deficit. Next, please. And that's what the yeah, this is C1C2 OA. This is C1C. I think the credit goes to Hardik. Thank you. I think this is something which is to a great extent misleading. Anybody who comes with occipital pain and pain radiating neuralgia should always be investigated for C1C2 open mouth view, and we must rule out the instability by flexion extension X-ray. And the minute you diagnose them, put them in the collar, usually they respond very well. And if they do not respond, then one can inject into C1C2 joint. And of late, we have been injecting into the greater occipital nerve, just 2 centimeters lateral to the midline, into the bone. Yeah, it gives pain relief. Yeah, we have about 200 cases studied.
Basically, what happens is
Only one injection, it gives excellent relief. Yeah.
This is just to learn. What happens in this group of patients is that the physiotherapy people need to be controlled, because it is beyond isometric. What they teach is side bending and rotation. This is what aggravates this.
Yeah,
exactly. One point aggravating is the rotation of the neck.
It's also called as Reynolds neuralgia.
Yeah.
The thing that we have seen, extension to your question, autofusion. The minute you put them in 2 months of the soft cervical collar, out of 24, 23 hours, and they will blindly follow you. So a lesson to learn: when somebody comes with occipital neuralgia, if it is OA, C1, C2, put them in the collar and the block if they do not respond. And no, it won't. But then you are giving the rest to the neck.
You are
giving rest to the neck.
actually enforcing that you are not rotation. But everybody who is driving a two-wheeler or a car has a tendency to feel this way. So you want to restrict that. Avoid rotation.
Okay, so thank you. Shall we go to the bonus round now? Are we all ready? You have to reply into your piece of paper which is given to you. Again, write down. You already have written. No, there is no buzzer now. There is no buzzer now. Okay, are we ready? Yeah, please. Yeah. No, we have the largest series. We have around 200, 300 cases, and we are doing prospective study as well. And we have used about 5 of them. Only 5 out of the 300. That is why I'm saying that this is one of the best condition which will give you conservative treatment. And if they are too in a lot of pain, you can just inject, and then, and by time. And then I have the CT scan done since it is showing the autofusion. So you put them in collar, they fuse. And I have seen only unilateral. I have not seen bilateral except one case. And I'm yet to see OC1. I have not seen any single OC1. Yeah, only C1, C2. Please. Shall we start? 60 seconds for each question. And there are about 5 questions. Yeah, and 20 marks per each. And you write down the answers. The word is pathology, so more than one pathology. More than one. Okay, can we have your paper collected by? The first team who win will get the operative manual recently published by Dr. Shankar Acharya. That's an ASSI operative manual. So that, you'll get, whoever is the first, each one of you will get the book. The runners-up will get the certificate that, runners-up, and those who are the other two teams will get the certificate that you have participated in the quiz. Now, the last from the audience, you have that. There is severe radicular pain, which is in the left upper limb. The diagnosis. Deepak? No, that's no. No. No.
Then Rakesh. So give it to me.
So, shall I declare?
Yes.
It's Pankos tumor. It's Pankos tumor. It's a Pankos tumor. Never ever miss this. Patient will come with severe radicular pain and with kind of deficit. And MRI would have been reported normal as well. So it's your clinical judgment that will, help you in reaching to the diagnosis. We have put the female here, but most of the time it is a male who is a smoker. But this was classic. We have not fabricated any information here. But she was female and she had Pankos tumor. So diagnosis wise, it is a Pankos tumor. So third goodies goes to, no, well, not me. I think it goes to Miran. Okay. Are we done? Okay, over to.
So I guess we are ending today's academic session. We have a short coffee break. After that, we have general body meeting. Only members who were enrolled for membership before 2019 are allowed to be in GBM, because rest of the new members are yet to be ratified. Because of COVID, since 2019, this will be our first general body meeting. So we will request those who are have applied for membership after 2019, they can enjoy the coffee outside. And from 7 p.m. onwards, we are having our gala dinner. Being a Gujarat, we don't have a cocktail, but we have a very beautiful live mocktail counter. So we will compensate those who really enjoy mocktails. And
I think all the team members were really active and I could read them, so we big applaud, that was very good of all the four of you, for the team coming forward. And it appears that all are going to be future spine surgeon too. So I wish you all the best. And let us have Gururaj. I think you answer. Yeah.
No, please. You are not eligible.
Hardik, Dr. Hardik Sutar.
So this is the book which we are going to give as prize for the winning team. Thank you all for, it requires courage to come in a spine quiz for our 3 residents. So congratulations, all of you. And I thank Dr. Bharat Dave and Dr. Miran Dave for organizing such a wonderful quiz. We shall reassemble within 10 minutes. Those who are attending GBM, please grab your cup of coffee and come back to the same hall. So So GBM is here only in this hall. 10 minutes, grab a cup of coffee and we can start our GBM. We want to start dinner at 7.
Minutes of the meeting. Junior अमित सर नो पहले
છે કોઈ આર્ટિકલ કઈ લખવું છે 2-4 પત્તા લખવા હોય બોલ કેસ રિપોર્ટ હા તો કેસ રિપોર્ટ લખને કઈ વાંધો નહીં કેસ રિપોર્ટ હોય છે સર પણ પછી મોકલ ને શું કામ એક્સેપ્ટ નહીં કરવાનું બારે જઈએ સર નીકળું
एक જ મિનિટ
Audience.
Should I start? So I'll again say that those who have become member after 2019, they are not allowed to be in the GBM. Anybody who has been member before 2019 are allowed to be in GBM. Sir, after 19, this is the first GBM.
सर अमित सर कंटेंडर कोई हुआ है तो नॉन वोटिंग राइट्स आते नॉन वोटिंग
Whatever. So whatever it is. Okay, so we are starting the GBM. May I request President Dr. G.D. Tharadra to welcome the general body.
Good afternoon, everybody. Now, after a long time, we are meeting because of COVID pandemics. And now in GBM, this time we are going to change the office bearer or executive committee members also. And we rectified our account also. That all detailed thing, I think Neeraj will tell you further proceeding. Thank you very much.
Thank you very much. So I think 2019, when we took over, this EC took over. After that, probably this is the first GBM. So I'll just briefly touch upon all the activities and accounts of last 3 years. So in 2019, we did two. That is correct. So we'll wear this. Recording from recording from